Hello. Testing one, two. Hello. Hello. Check. Check one. Hello. Hello. Testing one, two.
Hello, testing one, two. Hello, check. Hello, check, check. Hello, check, check. Hello, check, check. Hello, 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 check. Hello, check.
हेलो 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 हेलो। वैसे पता भी नहीं चलेगा ना, मैं सामने जाके फिर बोल के आता हूँ। और सुन, एयरफोन ले, आप ऑडियो ऑडियो चालू। हेलो हेलो हेलो, फाइनल टेस्ट ऑडियो, फाइनल टेस्ट ऑडियो। हाँ, वो थ्रू कर दे। हेलो हेलो, फाइनल टेस्ट ऑडियो, फाइनल टेस्ट ऑडियो। हेलो 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 हेलो।
हेलो हेलो हेलो, माइक चेक, माइक चेक। हेलो, माइक चेक। हेलो हेलो, 1 1 2 hello, my test. Hello, hello, check, check, check. Hello, check, hello, check.
हेलो 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 हेलो।
1 2 3 1 2 3. Again.
Okay. Good morning, everybody. I am Martin. I am Martin Sloot. I'm the General Director of the MSF India branch office. And it is with great pleasure to welcome all of you on behalf of MSF, Doctors Without Borders, to the first MSF Scientific Day in India. A special welcome to the chairs, presenters, and our international guests from the region. Since we are live streaming this conference, also a welcome to all our online guests from all over the world. We welcome the MSF staff and members from our association, the South Asia Regional Association, who are watching us as well in our field projects in Manipur, in Mumbai, in Nagaland, but also in Quetta, in Chaman and Dara Murat in Pakistan, in Sri Lanka, in Kutupalong in Bangladesh, in Afghanistan. MSF has been organizing Scientific Day over a decade by the MSF UK office. This year, and I hope for many years to come, we will organize this conference also from India at the same time, the same day. That's why we are here able to live stream a session from the UK conference today in London, but also that there is the session from Delhi will be live in the UK. Aim of this conference is to exchange medical research and to build engagement with the medical community in South Asia. Our vision is to connect audiences, stimulate analysis, and initiate debate on the state of healthcare in South Asia to further improve our medical activities for the patients. We hope, therefore, that the presentations and discussions today will continue beyond the end of this conference. Our call for abstracts for today's conference went across MSF, partner organizations, and institutions with whom MSF hopes to engage. Over a third of the presentations here today are from organizations external to MSF. We received submissions from across South Asia, and today we will have presentations from Myanmar, Pakistan, Bangladesh, and India. The central theme of today is the question about neglect. How is medical care provided to those who are vulnerable, stigmatized, or marginalized? How can we reach these populations? And how are neglected diseases identified in the South Asian region? With regard to this, I want to make a special remark today about a recent disaster in our neighboring country, Nepal. Like MSF, many of us are actively supporting relief activities to support the victims of this, many of them who are in difficult positions to access. Before we start the conference, I would like to mention housekeeping rules. First of all, I have to mention the fire exits. They are over there with the label exit. Another thing to know is that the toilets are downstairs next to the registration table. I also would like to remind you to be careful with your mobile phones. So please, if possible, switch them off or put them on flight mode to avoid interference with the live streaming. We have a big and tight program today, so please come in time for each session. There is a lot of opportunity to ask questions, and we arrange microphones at least three for people in the public who want to ask questions. Note that there is also a possibility that we get questions from the online audience. Another thing to know is that all the materials today, which you will see, they are also available online. Of course, you can tweet. You are very much invited to tweet, and you can use the hashtag, which is written behind me. Anyway, I'll mention it, SCIDIND. Since this is the first time, we would also like to know your opinion about today. So please don't forget to fill in the evaluation form. You can find it in the abstract leaflet, in the booklet you received when you arrived at the conference. And then last thing, you will see a person walking around. He's a videographer, so it's good to know, but because he's basically recording the event of the whole day. So you will see him walking around. As you can see in your abstract booklet, we will start today with 2 sessions before the lunch. And after the lunch, we have another 2 sessions, including, or in addition, also a keynote presentation. I wish you all a very stimulating day, and I look forward to active participation in the presentations, discussions, and debates. Now I would like to invite Dr. Uni Karunakara, he's our medical chair for today, to come to the stage for his opening remarks. Dr. Uni Krishnan Karunakara has been a humanitarian worker and public health professional for 2 decades, during which time he has accumulated extensive experience in the delivery of healthcare to neglected populations affected by conflict, disasters, and epidemics in Africa, Asia, and America. Uni serves on the board of directors of the Drugs for Neglected Diseases Initiative, DNDI, in India, and on the board of trustees of MSF India. He is currently a senior fellow at the Institute for Global Affairs at Yale University. He's an assistant professor in the Mailman School of Public Health at Columbia University, and he's a visiting adjunct professor at Kasturba Medical College, Manipal University. Between 2005 and 2007, he was a medical director of MSF Access Campaign, and later on, between 2010 and 2013, he was MSF's international president.
Thank you all. Thank you, Martin. It's really a dream come true. This is something that we've been thinking about for a long while, and finally the days arrived that we will be hosting, and we are hosting the MSF Scientific Day. As Martin said, it's the 12th annual Scientific Day, but in MSF we have been presenting research, our operational research, on an annual basis for close to 30 years now. Epicentre, which is based in Paris, has been presenting their research for almost 26, 27 years. So today, as Martin said, with the proceedings being broadcast live, it's truly a conference without borders. Now, as medical humanitarians, we deliver healthcare to people in crisis, people living in distressing conditions in some of the poorest parts of the world. Now, these are also the places where health systems are inadequate, very often dysfunctional, and where access to patients and access to good quality healthcare can be extremely, extremely difficult. Humanitarian medicine, however, is not second-hand medicine or lesser medicine. For humanitarian assistance to be meaningful, it has to be, above all, effective. The challenge for us all is to simplify and make accessible the practice and delivery of healthcare without sacrificing quality or effectiveness. Now, this can only be collaboration, working with scientific experts and health professionals to develop appropriate models of care for diseases and conditions that affect people. This region, the Southeast Asian region, accounts for 1/4 of the world's population, 40% of the global poor, and approximately 30% of the global disease burden. But it has a disproportionately large share of tuberculosis. 35% of the global burden of tuberculosis is in India. 67% of the global burden of visceral leishmaniasis in India, Nepal, and Bangladesh. 33% is in this region, and 30% of the under 5 mortality is also in the region. Just one sobering statistic. Every year, 1 million children under the age of 5 die due to malnutrition-related causes in India alone. 1 million. And this is a country that sends satellites to space. So research on neglected diseases such as these and public health problems such as mental health and sexual violence will be presented today. These are very good examples of how civil society organizations such as MSF, working together with colleges, research institutes, product development partnerships such as DNDi, and activist groups can help develop new care models and deliver appropriate healthcare for neglected populations and diseases. Now, we'll also talk about innovations. Innovations are key if we are to health services and ensure care for all those who need it. Now, the technology itself is not the answer, but it has to be coupled with sensible, common sense, field-adapted tools to make it possible to scale up care. And this approach has helped us put 13 million patients on ARVs in the last 13 years. Very common sense approaches. So there's no reason that in the future that children should die of malnutrition or adults from TB or Kala-Azar. So during the day, we'll have the opportunity to grapple with all of these issues. These are all discussions we'll be having today on visceral leishmaniasis, tuberculosis, HIV/AIDS, malnutrition, sexual violence, and some innovations, use of technology, mobile technology, etc. And we'll have the opportunity to grapple with these challenges. And I hope you're to learn, discuss, and engage in these issues as I am. So I'm not going to waste any more time. Once again, welcome. I look forward to a day of enriching discussions and wish the presenters all. Thank you.
Thank you, Uni. Can I now invite the presenters and the chair for the first session to come on the stage? And meanwhile, I will introduce the chair of the first session. And the chair is Dr. Rohit Sarin. And he's the director of the National Institute of TB and Respiratory Diseases, which is an autonomous institute functioning under the Ministry of Health and Family Welfare. He is also chair of WHO's Regional Green Light Committee for MDR-TB in India, Southeast Asia region. Dr. Sarin is one of the leading technical experts on TB in India today, and he has significantly contributed to effective TB prevention and control in the country. Dr. Sarin, welcome.
Thank you, Martin, for the kind words of introduction. Well, friends, a very good morning to all of you and to our colleagues and partners all over the world, depending upon what time of the day it is. Good day. I would say it's a historic moment. It's a historic moment for all of us here in India, and it's a historic moment for India office, because today we are celebrating the scientific day of the MSF in this country, and we are doing it for the first time. And I'm sure whenever we look back on scientific days, today, 8th May 2015, will always be remembered. So I'd like to start by congratulating the MSF and the team under the leadership of Martin, who has made this happen. And I'm sure that this is an event which will continue over the years to come. Well, friends, the morning session is a very interesting session because it is focusing on something which we are all concerned about, and that is neglect. Neglect for diseases, neglect for cohorts, neglect for populations. And we have 4 presentations in this particular session. And each of these 4 is talking on some or the other aspect of neglect. Before I move on for the subsequent session, I will say that my first speaker is Shaneri Ann Lim. She's a pediatrician by qualification, and she joined the MSF about 3 years back. Her major place of work, or I would say research, is primarily in Sierra Leone and Pakistan. And she has done a lot of missions on emergency exploratory bases also. She's from Manila, St. Luke's College, and I'm sure that we will all have a feast on what she has to talk of, which is a neglected, stigmatized disease, cutaneous maniasis. This is on her experiences in Balochistan and Pakistan. So it's over to you, Jen, for the next 10 minutes or 12 minutes, whatever you feel comfortable with.
Thank you so much. So good morning, everyone. Ladies and gentlemen, honorable speaker, panelists, and all the people streaming around the world. Today, I will be presenting a descriptive study on the neglected stigmatizing disease, cutaneous leishmaniasis in Pakistan. So if anybody knows, Balochistan is the largest province of Pakistan with a volatile and unpredictable security context. There are a presence of a lot of vulnerable, marginalized, and displaced populations with decentralized Ministry of Health. They have a high morbidity and mortality rate in the rural areas, especially among the women, infants, and young children. MSF OCA is working in the capital city of Balochistan, which is Quetta. We are running 2 outpatient clinics for cutaneous leishmaniasis in Kushlak and 1 in Maryabat. These 2 clinics serves different target population. Kushlak serves the nomads and Afghan communities that has no access to health care, while Maryabat serves the minority population of the Hazaras community, which has the mobility limitations and facing persecution in the country because of their sectarian identity. Cutaneous leishmaniasis is a parasitic skin lesion which is transmitted by either a zoonotic cause, which is leishmaniasis major, or an anthropometric cause, which is leishmaniasis tropical. It has a vector, which is the Phlebotomus sandflies, and the animal reservoir are rodents. The lesions can be located both on the face and extremities and can cause extensive scarring and deformities, which can lead to behavioral inferiorities and psychological insecurities. Cutaneous leishmaniasis is an easily treatable disease. It is self-limiting, and only 2% of the infected develop lesions. The most commonly afflicted are the children because of their underdeveloped immunities. We don't treat all patients with lesions. We only treat lesions is located in the face, and they are located over the joints, and they are growing larger, and if the duration is more than 5 to 6 months. This study analyzes the routinely collected data approved by the MSF Ethics Review Committee. The laboratory diagnosis is made by microscopic smear of skin lesions, aspiration, and treated with glucontime injection, which is an given both intralesionally or intramuscularly, depending on the location and quantity of the lesions. MSF OCA recently added a new CL clinic last June 2014 in Maryabat, the Benazir Bhutto Hospital. The data from 2013 to 2014 showed a markedly increase in the number of patients seen from 125 to 1,492 patients. The number of confirmed diagnoses is based on the laboratory is also increased from 36.9% to 42.6%. The percentage of the confirmed diagnosis is a bit low. That is because cutaneous leishmaniasis is mostly a clinical diagnosis. That is why also in 2014, we also started 671 patients on treatment. The cure rate is 97% with very little defaulter rate of under 3% and with very low relapse rate of 4.2%. All relapse cases were restarted on treatment, and discharge as cured. For relapse cases, we either extend the number of treatment or change the manner of injection. The type of lesions the clinic sees are usually ulcerative and nodular lesions with a lot of multiple papular lesions. A lot of the lesions have a duration of more than 6 months. The chances are this patient had already sought treatment at the facility and only was given partial treatment. Or so some, they don't know where to seek proper treatment before. Now, we are noticing that a lot of people come in with a lesion of less than 3 months. The reason for this is heard about the CL treatment that the center is now being giving, and it is for free. We would rather prefer that the patient come to us earlier so that the improvement will be better. So what is MSF in all this? The drug importation in Pakistan is a long administrative process with a 6 months lead time and a lot of further delays due to custom regulation, importation requirements, and frequent personnel changes. MSF is the only organization that is giving free CL treatment in all over the country. And because of the population that we targeted, access also by the patient, not limited to the target population, is also limited due to the security constraint, which can include sectarian violence. What is the Ministry of Health's challenges? Currently, there is no cutaneous leishmaniasis surveillance reporting system in place. The World Health Organization disease early warning system was stopped due to funding constraint. There is low prioritization for the disease because of the low mortality rate. The low available in the market is expensive. Being purchased in the black market, their quality assurance is also questionable. There are still a lot of places in the country with low awareness of the disease. So what is MSF doing right now? Currently, we're still continuing to analyze the program data and sharing our achievement with the Ministry of Health. The cutaneous leishmaniasis clinic is still integrated in the outpatient department as what we have been doing in Benazir Bhutto Hospital. We are working closely with the Ministry of Health in Benazir Bhutto Hospital in Mariaba to showcase CL treatment in the region. We have a very good collaboration with the Ministry of Health. The available treatment is still effective in the region. Hence, we will push to lobby to increase the priority and budget allocations for the disease, and we will improve public awareness of cutaneous leishmaniasis in the community. In achieving this study, we would like to extend our acknowledgement to Benazir Bhutto Hospital, their medical superintendent and staff, the district health office assistant, the MSF staff in Quetta for tirelessly working in the clinic and cooperating closely with the government. I will finish with these pictures, which depicts some of the happy faces of the people we were able to treat in the outpatient we are serving in Quetta. The picture on the right is of the tree lady, which is all over her body and with a parasite test of more than 1,000. At first, she doesn't want to be seen because of the lesions on her body. A lot of people doesn't want to talk to her or even touch her because they are scared that they will get what she has. She was misdiagnosed to have leprosy even. But after treatment in our clinic, she has acquired her confidence back and is now working and smiling to everyone. We have brought back dignity to life on this patient. Thank you and mabuhay.
Thank you, Chen. I would say that we, being the first session here, are grateful to you for having kept to the time, because that's the most critical thing when you are online and having a direct cast. We can take 1 or 2 clarifications at the outset, and then of course the discussions will happen at the end of the session. So if there are any points anyone wants to clarify at this point of time. Yes, we have some caller from outside.
From the online audience, how is this different from PKDL, and any reason why it affects children more?
Yes, could I ask Chen to respond, please?
So PAKDL is more of a post-cutaneous one, and it's caused by Leishmaniasis donovani. So for cutaneous leishmaniasis, the reason why it affects only children is because of their immunity status. Their immune system is not yet well developed, so they are more prone to the disease.
Okay, are there any other clarification points, I would say, rather than discussion points? Yes, Dr. Devan.
You said that MSF is the only one which is providing free treatment for this facility. That means the Pakistan government hospitals do not provide. That's one question. And second, what is the usual cost?
So thank you for the question. Currently, in the whole of Pakistan, there is no CL treatment program by the government. Before, one NGO that has been giving free treatment, but they already moved out of the country. So currently, in the whole of Pakistan, it's only MSF that is giving free treatment for cutaneous leishmaniasis. And for the second question, the cutaneous leishmaniasis treatment in Pakistan costs around $77 per injection. And for a CL treatment, for intralesional, you have to go to the clinic at least a minimum of 8. And for intramuscular, go to the clinic at least a minimum of 20 sessions. So that means for a very minimal wage person, they wouldn't be able to afford such a lucrative treatment for the disease. So that is why a lot of the people in the country is not being given treatment or is not being treated for the disease.
All right, that's the last one, and then we move on, right?
Sorry, thanks, Chen, for a nice talk. I was just wondering, what is an alternative to sodium antimony gluconate which you would use? You know, there are many patients who would not like to take the injections, or they may not be in a position to take the injection. Is there an alternative that you have used in these CL patients in Balochistan?
Okay, thank you for that question. So as of now, there's still no other alternative for glucantim injection for treatment of cutaneous leishmaniasis. There has been proposal on using some other type of treatment modalities. This is also something that we are looking into now, but as of the moment, glucantim injection is the only one that is available. Of course, as you said, there are also a lot of example for age, for people with certain kinds of diseases, but since mostly we are treating a lot of children, so they're more susceptible to the treatment.
Okay, thank you. So if there are any further I would say discussion points, we'll take it at the end of the session. You'll have an opportunity once again. I'll now like to invite our second speaker, Janet Osley. She is a field epidemiologist working for the MSF in Myanmar, and she took her master's in public health at Emory University. Her main focus is on infectious disease epidemiology. And in fact, in a worked with MSF. She's also been with the CDC for quite some time, and she's worked in different countries, primarily in the African subcontinent and in all parts of the world. And the area which she's going to talk on is something which has an area of neglect. This is the immunocompromised individuals, adolescents having HIV positive. So there is a increased risk of treatment failure in HIV-infected adolescent cohort in southern Myanmar. So, over to you.
Thank you. Hello, everyone. Or can you hear me? Minglaba, as we would say in Myanmar. As we said, I want to talk to you about adolescence today. And I'm guessing that of what country you're coming from or your generation, you remember adolescence as a somewhat turbulent time. Adolescence can be a bit tough. It's a time when every system of the body is going through dramatic developments, especially adolescent brains. And for adolescents who are living with illness, particularly those who are HIV infected, it can be a really difficult time, and those normal hormonal and physical changes that are part of the teenage years can seem really overwhelming and can manifest in unpredictable ways and be different, to make those adolescents different from their peers. So adolescents are kind of a special cohort generally, but I'd like to speak to you specifically today about a cohort of adolescents in Myanmar, where MSF has been active in HIV and TB care, MSF Switzerland, I should say, for over a decade. We're in the far south of the country, in that little tail of Myanmar, over by Thailand. It's a region that very coastal, interesting subpopulations that depend on fishing industries. In Myanmar, HIV is not a generalized epidemic. It is more fueled by high-risk populations, so men who have sex with men, commercial sex workers, drug users, and in this region, actually, fishermen are also considered high risk. The analysis I'll talk to you about today is part of an initiative that the MSF Switzerland mission has started in the last few years, really integrating operational research and using and capitalizing on the medical data that we have after almost a decade of working in the region. And that's our sort of clever name for our operational research unit. If you'd like to know more about that, we have a poster in the hall and online, little shameless self-promotion. But what we were trying to do exactly was take some of our medical data that we had and really look at the 10 to 19-year-old cohort among those. We know that our doctors and our nurses and our counselors had certain suspicions about things that were happening, but we'd really never, before this point, systematically disaggregated that data to look at what was happening. And so what we did was a cross-sectional analysis of those adolescents. Routinely collected data that was available to us easily in the Fuchsia database. And for those of you who aren't familiar, it's the follow-up and care for HIV and AIDS database developed by Epicent. We found that we had 248 patients between the ages of 10 and 19 who'd ever been admitted in the 10 years of the clinic. Now, not all of these patients will still be on treatment. Some of them will have died. Some of them perhaps never started for various reasons. Others may have started and were lost to follow-up. And frankly, others may have started treatment and grew up with us at the MSF clinic and are now no longer adolescents. But we wanted to describe this cohort and again, really dig a little deeper into what was happening, but do it in a scientific and a systematic way. And that's a picture of our clinic in the southern Myanmar. We had a few limitations, as all studies and all data sets have. We are dependent on that Fuchsia data, so it's really medicalized data. So things like treatment adherence, a lot of information about aspects of the adolescents' psychosocial information or information about their environments, which is really important to understanding their experience. We don't have, and we're actually trying to improve upon that in the future since our counselors do have a lot of that information. We also know that a 10-year program is a really long. Perhaps the adolescents we were seeing in the project changed because of things like politics or even economics or frankly even evolving HIV care standards, and it could have had subtle effects on our data. And then finally, a real limitation that we felt was the fact that we can't currently distinguish between those adolescents who had a perinatal infection or acquired their disease from their mother and those who acquired their disease sexually or through a transfusion. And we think that these groups might be quite different. And so again, trying to better information and analyze for that. So our results, the interesting part, when we started this cohort, what did we find out? Well, first I can say interesting because the adolescents seemed like a pretty good group of patients, at least when you compared them to adults. We found that they were less sick at presentation to the clinic, at least if you looked at their CD4 counts, which is a measure, obviously, of immune health. They remained on treatment for longer than adults, and they responded better immunologically over time. But we weren't necessarily really surprised by this. We could at least explain why this might be. A higher CD4 count at presentation might be because we knew their average age at diagnosis was about 7 years. And it's possible that much sicker children had already died at that point, leaving the sample of people we were looking at somewhat biased. Or frankly, perhaps just because they have caregivers, they were accessing treatment sooner. Adolescents stayed on ART longer than adults on average, but again, they have caregivers, and that's really important in this situation. They were less lost to follow-up than adults, but many or most of these adolescents don't necessarily have jobs like adults do. And in a region that is really affected by economic migration, especially to the fishing communities, that matters. They did better over time compared to adults immunologically, but they also have younger immune systems, so perhaps could bounce back a little easier. It was interesting to describe the cohort this way and use the adult cohort as a comparison group, but we weren't necessarily shocked by what we were finding. When things got really interesting then was when we dug a little bit deeper and started to look at potential treatment failure. And this is where we saw that the adolescent cohort, about a quarter of them were on second-line treatments, meaning that they could not take the drugs of first choice that are sometimes easier to take and certainly cheaper because of various reasons. We know that adolescents sometimes have reasons besides treatment failure to take second-line treatment regimens, perhaps treatment when they were really young and developed toxicities or side effects over time. But then when we looked at another indicator of treatment failure, which was viral load testing, we saw that adolescents were over 3.5 times as likely as adults to have a detectable viral tested, meaning they had enough virus in their blood that the test could see it, and therefore we know that the treatment is not suppressing their virus, confirming that they're failing their treatment. So again, it was a consistent pattern of treatment failure, and this is kind of contradictory. They seem like great patients when you look at them as a cohort, but then when we look at a really important indicator, which is how they respond to treatment, they were failing. So what does this mean for MSF in Myanmar? We feel like we have a lot of questions still to answer. We suspect that there is large-scale adherence problems for our adolescents, that they're, despite being good patients and coming to the clinic, that they're not taking their medicines. And we don't know if this is because support networks. We know many are orphaned, though we don't know the exact proportion. We don't know if this is because there's some sort of shame or stigma surrounding take their medicines. Frankly, as teenagers, we don't know if this is a manifestation of depression and some sort of self-harm by not taking their treatment. Or we don't know if, none of these are true, and if we're wrong and these adolescents are very adherent, really we need to look deeper and see what's happening. So what we're going to do is take this cross-sectional analysis we did, and we've written a research. And in the next year, we hope, because we're currently under ethical review, we want to prospective study that will have both a clinical and quantitative component and a qualitative component that will look at psychosocial factors and the adolescent's environment to really better understand the HIV experience for adolescents in Myanmar. There's been a lot of research in the last decade on HIV in adolescents, and even in Southeast Asia there has been, but Myanmar is really evolving right now, and adolescents haven't really been a part of that conversation. So we think that MSF could really use our voice to add to that conversation. And that's a picture of one of our peer support groups that the MSF clinic runs. And so just to sum up, and I over time. But if you take away 3 messages from this presentation today, I'd like them to be this. First of all, adolescents are, as a colleague of mine at the MSF clinics, beautifully complex, meaning that they're a really unique group. They're not a pediatric cohort and they're not adults, and we need to respond to them in unique ways because they have special needs. And then to use a term, what gets measured gets done. So a good first step is looking at their data uniquely, not just aggregating them in with other cohorts, but really taking that data, stratifying by age, and seeing what's happening. And if you haven't done that, I guess we at the MSF Myanmar mission really encourage you to, because you might be surprised as we were. And then finally, simple solutions can be powerful. We've really redoubled our efforts with this group of adolescents in in southern Myanmar as a result of this cross-sectional analysis, doing more peer support and really letting the us what they need and have some agency to use that sort of newfound autonomy and independence to tell us what they need. And we don't have data yet, but we've had some really feedback from that. So a final thank you to the Myanmar team, who I kind of don't know if they can listen to this presentation because of very slow internet, but they inform every word of this, and they're a fantastic team. So thank you for listening.
Thank you, Janet. I would say that that was an excellent presentation, and it has really stimulated the thinking. There's a paradoxical situation which she's pointed out. A group of children which one would, you see, because their disease is less, their compliance is better, immunological response is better, but still their failure rates are high. It's really very, very paradoxical, and we need to really work more on this. And I would say that you also spared us a minute or two for taking some clarifications. Thank you for that also. So we'll just have one clarification from anyone in the audience, and then we move to the next speaker. Yes, sir.
Does Myanmar has a sentinel surveillance mechanism in place to know the estimates of prevalence? If at all, what is the prevalence now, latest prevalence? Segregated or not? That is the second part.
Sure. If I understand your question correctly, there is a national AIDS program, and they're really doing a lot, especially since recent political openings. And there's good monitoring and evaluation and surveillance of HIV in the country. But what we have found in our project is that there's certain subpopulations that we feel could get more attention, and that's why I think some of our analyses, the adolescence analyses, and certainly the high-risk groups that we've displayed some information about on a poster could use a bit more of a spotlight, I can say, and so that's why we're talking about them today.
What's the prevalence?
In Myanmar, the prevalence in the general population is 0.5%, but in high-risk groups, it can be up to 17% in drug users. I believe it's 6.8 in sex workers. I encourage you to out in the hall because in the high-risk groups, yeah, in high-risk groups it's quite high. Yeah. But only 0.5% in the general population. I don't have a prevalence estimate for just adolescents, but I think that's kind of what we're trying to encourage, is that the who's very active in HIV management in Myanmar, and the National AIDS Program, and all of the actors, including MSF, who engage with these patients, that we start to look at them a little more closely.
Right. Thank you, Janet. I think we'll move on to the next, and request if there are any other discussion points for Janet, we'll just park it till the end of the session, and we'll again have an opportunity to discuss with you, ma'am. We'll take your support. And now I'd like to invite our third speaker, and Sri Priya Pandurangan. She's working with the International Union Against Lung Diseases in the Southeast Asia Regional Office here in Delhi. And she's done her bachelor's in statistics and master's in econometrics. She has more than a decade of experience in planning, monitoring, and evaluation. And she has been part of the project which the union is running, dealing again with a marginalized group of population, working towards universal access, and that's called the Akshaya project. And I'll request her to give her presentation on novel interventions to enhance access to TB services for the vulnerable and marginalized populations.
Thank you, Dr. Seren, for the introduction. Good morning, everyone. I would like to thank for giving me this opportunity to present one of the largest advocacy, communication, social mobilization project which has been implemented by the union to enhance the access to TB services for vulnerable and marginalized populations. So why there is a need for this project? The universal access to TB services is critical for timely diagnosis and treatment. However, low awareness about TB and poor health services results in delayed diagnosis with resultant morbidity and mortality. So this presentation will focus on interventions which has led to enhance the access to TB services. In line with the NTB strategy, the goal of the project is to improve access to quality TB care and control services through enhanced civil society initiative. Our main objective is to reach the unreached, build the capacity of the community, engage care and control services. So I'm not going to talk about the project has actually many activities, so I'll just brief you about the activities and then I'll move on to my presentation on the innovative activities. So the project first, the project has identified, mapped and the vulnerable and marginalized population. So this is to achieve the goal of providing universal access to TB care. And the project has also involved with the community, built the capacity of the community, and then we have capacity built the existing village health communities to discuss about and include TB in the village health agenda. And thereby in the process we have also involved the health care providers, the rural healthcare providers, those non-qualified healthcare providers to talk about the TB symptoms in the community, identify them, link them to TB services. So adopting the strategy, advocacy, communication and social mobilization, the project has made advocacy efforts at all levels, sensitized different stakeholders and ensured their commitment to TB control services. So all this has led to increased TB case notification and decrease in the last 2 follow-up cases and improved treatment success rates, thereby achieving the goal of universal access to TB, quality TB care services. So where you can see the coverage of the project. So the project is implemented in 300 districts across 21 states of India. This has been implemented by 9 sub-recipient partners. So as I have told, this is the union implementing the project with 9 sub-recipient partners involving 20,000 community volunteers and 1,200 non-governmental organizations. So it has reached nearly 16 million population in 300 districts. So now I'll move on to key innovative strategies which the project has adapted. So the first one is about the Akshaya Samvada. This is an intensive outreach activity whereby we have trained the community volunteers to conduct visits, creating awareness about TB and identify those with the symptoms and the symptoms suggestive of TB. So these persons, once we have identified them, we have given the choice of referrals to the nearby diagnostics facilities, and if they are unable to go to the diagnostic services, we have actually given them the option of sputum collection and transportation. So where we collect and then we have transported to the diagnostic services, and then we have actually gone back to the patients who are positive and then ensured them to put on treatment. So nearly we are reaching 1,000 households every month in each district. So the results of this intervention, 5.1 million households were reached during this period, April 2013 to December 2014, and out of which we have identified nearly 4 lakh TB symptomatics, of them 62 examined and 7% were diagnosed as TB patients, and we were able to put 97% on treatment. The next innovative intervention I'm going to talk about is the rural healthcare providers. The unqualified rural healthcare providers who are the first point of care for the majority of rural and urban poor are trained to identify those with symptoms of TB and refer them immediately for sputum examination to the nearest public health facility. They have also been trained to provide directly observed treatment short course for which they get incentives from the RNTCP program. So the results of this training, we have nearly trained 19,000 RSCPs and out of them 13% are engaged with the project. So we mean by engagement, they refer at least 3 patients in a quarter and then do a sputum collection and transportation of at least 1 patient in a month and provide dots for at least 1 patient. So this is called engagement in the project. Of engagement, the RSCPs were able to identify nearly 50,000 TB symptomatics. 70% were examined at the DMCs and 12% were diagnosed as positive and 98% of them were put on treatment. So this advocacy social mobilization project has given an yielding of additional TB. So we have involved the community, we have tapped the local resources to enhance the access to TB services. Thereby we have also rural healthcare providers to provide the TB services to the community. So though we are implementing in 300 districts, so in the next NFM Global Fund project, this is going to be replicated in again in India in other districts as well. So thank you for this opportunity.
So it's really beautiful. I mean, fortunate that my presenters are all time, and in fact they are giving us some time for seeking clarifications and discussions. Thank you very much. A very interesting talk and universal access. Yes, all of us with the issue as a concept. We must reach and treat every TB patient till the patient gets cured. That's the part of the NTB strategy. Yes, sir. Kindly introduce yourself before asking the question.
My name is N.B. Nair. I edit a science journal called Indian Science Journal. Just want to know what is the burden of tuberculosis in India in comparison to the world tuberculosis burden. Second is, what is the linkage of air pollution in India? Mostly in Delhi and other cities, pollution is higher than what is normally should be. Linkage between air pollution and TB.
Sri Priya, would you like to take that, or would you want me to respond? Okay. Well, I would encourage, at this particular session, clarifications from our presenter. But just to answer your question, yes, the burden of the disease in India is high. Roughly about 2.7 million TB patients, to be precise, which are prevalent, and about 2 million are added every year. So that's the extent of the burden, and globally, we have about, say, 25% of the incident cases. That's the comparison in the world. In relation to air pollution, yes, air pollution does have, to some extent, that it has increased chances of an individual getting the disease. As you know, even though most of us present in this hall today would be infected, but there only a 10% lifetime risk until and unless we get immunocompromised. And airway pollution enhances this particular risk of getting. That is to do mainly with the immunological factors which operate at the macrophage level in the lungs, because whenever there is air pollution, the ability of the lung macrophages to fight against infections reduces. That's the reason why you see we who land up with air pollution also land up with other problems, other infections, other diseases, not just limited to TB, but definitely it will also increase tuberculosis. No, that's all right, but I would have preferred now only from her, please. We can discuss all this. TB is my passion. I could keep on discussing tuberculosis all day with you, but for time restraint. Yes, sir.
Yeah.
Please introduce yourself.
Thank you, Sri Priya. Very nice presentation. I just wanted to know, because this is from point of view of sustainability, what was the action of a patient when you made the strategy of active case detection and training of the these providers? What was the extra cost? What was the cost per detection?
Cost per se, actually, it's the project is being implemented by NGOs. So the NGOs were paid for each household. We are paying a 10 rupee to go and reach about the messages to tuberculosis. And for the rural healthcare providers, we are giving a training at the district level. This costs around for 30 recipes. We pay them 6,000. Per training. So
yes, I think that's a very important. We'll come back to that, sir, again, because sustainability of such interventions should always be kept in mind. You see, we can't have this operating at a project level for decades and decades, because it's a one-time intervention is maybe simpler, but if we have to bring about an impact, we'll definitely have to have it more often. Yes, sir. And that's the last clarification from you, and we move on to our last speaker.
Thank you very much. My name is Suman Rijal. I'm from DNDI. I just want to ask, you had 62% of those who were tested. What happened to the others who were suspected but who did not get tested? I mean, there is a system that to capture those patients or to look into that?
Yeah, actually the project where we are doing a follow-up of actually who are, and we go and do a follow-up and do collections, sputum collection. And some of the, we have seen many studies also in our project also, we see some of them, they are not willing to go to the government facilities. So they either land up in private health facilities or to any other quacks who they feel that they are comfortable in revealing their diseases.
Right. So with this, thank you so much, Sri Priya, and we move on to our final batsman for the day. And we have George Varghese here, who's from the Christian Medical Corps, and his interest in infectious diseases is well known. He's studied it not only in country, he's also been to London School of Hygiene and Tropical Medicine, wherein he's done his postdoctoral fellowship in infectious diseases. And Varghese has been doing a lot of work in many infectious diseases, but today he will be presenting mainly on typhus, scrub typhus in India, emerging insights and future challenges and opportunities. So Varghese, let's have what you have to say.
Thank you, Dr. Saran, for those kind words. Good morning, ladies and gentlemen. Typhus claimed millions during the First and Second World War. The story in India is no different. It is very clearly documented. The typhus and the other rickettsial infections were major threats to the British Army during those times. However, for several decades, it became a rarity. It was unknown disease. This was not even kept in the differential diagnosis of someone who comes with acute febrile illnesses for several decades. We started noticing a group of patients, this is in the late 1990s, group of patients who come with acute febrile illnesses with multiple organ involvement, most of them with hepatitis, some of them with frank jaundice, with pneumonitis, which may even progress to ARDS, aseptic meningitis, and where you look for common causes like falciparum malaria, leptospirosis, etc., were all negative. Looking harder for these, harder for an answer in these patients, we found that there were small S-scars considering the possibility of rickettsial infections. This is the time when we looked at it prospectively. We looked at 2001-2002 period. We looked at some patients coming with these multiple organ involvement with illness, with them having LFT abnormality. We clearly documented that this is due to scrub typhus. 4 major serotypes where their serology was positive for IgM scrub, where all the other workup was negative. This was published in Annals of New York Academy of Sciences in 2003. In the smaller group of cohort, the case fatality was around 11%. As you know, this is a mite-borne zoonotic bacterial disease caused by Orientia sutsugamushi. The bacteria was earlier called as Rickettsia sutsugamushi, which is transmitted by the chiggers, which is the larval trombiculoid mite, Leptotrombedium most commonly. And this is usually maintained in nature because of the reservoirs, the chiggers and the rats. There is transovarial transmission, and therefore it's indefinitely kept in nature, and the humans are incidentally infected. So we started working on, whenever at that time, nowhere in the country specific diagnostic test to diagnose this particular infection. So we looked at what are the ways, when would you suspect scrub typhus. The pathognomonic eschar was found only in 10 or 15% of patients at that time, primarily because awareness was very low. Unless you search carefully in the axilla, in the groin, unless you search carefully, you wouldn't find the eschar. Even if you search carefully in 50% of them, you may not find the eschar. It may have been very or fallen off. So have also recognized that transaminase elevation with thrombocytopenia and leukocytosis could be indicators of multi-organ involvement in acute febrile illnesses with the appropriate epidemiology, which reasonable predictive value in these group of patients. But as you know, these specific indicators. Now the issue is, even today, 10 or 15 years down the line, it's grossly under-recognized. The burden and the pattern of scrub typhus have not been documented in India. Therefore, this particular study was to describe the public health spread and severity of disease, which can serve as the basis for formulating policy in our country. So what we did is, to assess the disease burden, we reviewed the medical literature and also the Government of India's integrated disease surveillance programs and rickettsial infection database at CMC Vellore. We also did a cross-sectional population-based survey in Vellore district to estimate the community seroprevalence using IgM and IgG serologies. Now, there was also a case control study done to assess the risk factors for acquiring the disease in the community, and the severity of disease and current management options were assessed among patients admitted to CMC. Now, when you really look at during this 5-year period, there were about 6,649 cases of scrub typhus documented from 24 different states. This is the last 5 years or so. And 5 states, the burden has been quite high. With Tamil Nadu, of course, Vellore has been instrumental in part of recognizing this re-emergence. And all these 5 states, more than 300 cases were documented during this period. Now, if you look at the entire burden which is being reported, this is just the tip of the iceberg. I'll give you a comparison. When we looked at our database during this period, confirmed scrub typhus of over 3,000 patients, and what has been published in medical literature is only about 450 cases or so. So even that, you must remember that CMC is a tertiary care center, and therefore more severe cases are only admitted into the hospital. So what you're really seeing is just a very tip of the iceberg. Now, when we did the community prevalence study, this was we have done a good clustered sample design, taking about 721 participants from Vellore district, about 61% from rural and 30% from the region. Majority were female, 62, and 37.4% were male, and the mean age was 50.6 years. As you recognize, the mean age was higher because all these surveys was done during the daytime, and most of the younger adults would have been out for work, and there was a bit of bias in that. However, it still conveys the message very clearly. About 30% have had evidence of infection in the past. IgG is a good marker of the past infection in these for this infection. When we looked at the case control study to see the risk of acquiring the disease, we took 128 confirmed cases and almost similar number, 132 age and sex matched controls from the same village. We tried to look at various factors would be a risk factor for acquiring the disease. Being agricultural laborers, there's an increased risk, bushes or shrubs around home. So basically, either as part of occupation or as part of daily life, if they are around the bushes or the scrub, they are at higher risk of developing the disease. And of course, clothing again makes a difference. You can see the odds ratio. These are some of the ones which clearly stood out, saying this is where they are getting exposed and probably getting the disease from. And if you look at the seasonality, the cooler months of the year from September to January is when the maximum number of cases are occurring. So this is when the mites breed and the larva comes out and the disease is transmitted. This is over the years we have seen the same pattern of seasonality as well. When we looked at the severity and complications, about 1/3 of them will develop or developed multi-organ dysfunction, almost the same number with adult respiratory distress syndrome, many of them going on to require ventilatory support, but it's a dying disease to treat. If you recognize early and treat them, they come out beautifully, unlike most of the other ARDS. So a very gratifying disease to treat. The case fatality in the sicker group still continued to be about 9%. Doxycycline is the choice, but IV doxycycline was not available in our country until now, which was a major problem. And the alternative was azithromycin IV. So what we used to do was give IV azithromycin along with oral doxycycline. Somebody who's on ventilator, the absorption, there is a problem. There the option was IV azithro with doxycycline, which probably may not have been the best, we don't know, but it was quite a reasonable therapy. So to conclude, scrub typhus is a significant public health threat in India, yet it is under-recognized and grossly under-diagnosed. Doxycycline is the drug of choice. Azithromycin is a good alternative. Unavailability of IV doxycycline to treat severe infection necessitates urgent advocacy. That is where MSF comes in. When we discussed several months ago, we have been advocating this for quite some time. MSF was more than happy to help out, and that is when the whole initiative started. But I'm sure you will be happy to note that now the IV doxycycline, we have just got the first stock in the country. Maybe the MSF's willingness itself made a difference to help out. This is one of the major reasons why we thought MSF, we should work with MSF in advocacy to get this IV doxycycline available in the country. It's a very cheap drug, less a day for the oral doxycycline for the entire course, but so most of the pharmaceutical industry, because the margin was very low, was not willing, but we are happy that it's available. Information and advocacy are still needed for investing in surveillance, prevention and detection, as well as appropriate management strategies. Thank you very much for your patient listening and also this opportunity to MSF.
Thank you, George. As I would say that he's also followed the trend. We have time with us, and now also time for the discussions on any of the questions also. In fact, he's talked of a disease which again is, as he's rightly said, underdiagnosed, but a disease which has a definitive treatment, a disease where we should have a high index of suspicion, and a disease, if left untreated, could be very fatal. So friends, this now all the presentations are open for clarifications, discussions, comments. And please introduce yourself.
Yes, my name is Seisei from MSF Mobile Project. Okay. First, my question goes to Dr. Josh. I would like to know what is the sensitivity and specificity of serological crab first, because to my experience, the sensitivity is not very, very high, and confirm the diagnosis. Thank you.
Actually, we started off with the serology. That was the biggest question which everyone was asking. How sure are you what you're saying is true? If you really look at the serological gold standard today is the for serology, immunofluorescence is taken as the serological gold standard for this disease. But now of late the ELISA probably is even better, although they are emerging. On the whole, these serological tests has about 90% sensitivity and specificity. So the error is only about 10%, 5 or 10%. So any clinician will be willing to accept that 10% error. So for all practical purposes, these serological tests are excellent tests. But we also have PCR to confirm the disease. The culture is mostly in research laboratories. We've also just completed an ICMR funded project on genotyping the organism. So we have actually genotyped the organism, so we know for sure what we are talking about is absolutely the same pathogen or the organism. So for practical, the serological tests are about 90% sensitive and specific.
Yes, sir.
I'm Dr. Rajiv Jain. I'm Joint Secretary of Indian Public Health Association and a pediatrician and an epidemiologist by professional training. The session is titled as Neglected Diseases, Cohorts and Populations. I personally don't believe that HIV and tuberculosis are neglected. Rather, there's a counter argument today all across that HIV has had more share of attention than the more important diseases like tuberculosis. We may be biased because we are placed in South Asia. Having said that, no doubt this session has brought in important dimensions of the crises in neglect in emerging diseases like cutaneous leaf in Pakistan and scrub typhus in South India especially. These are diseases which we are going to face much more strongly, and there will be challenges in actually giving access to treatment, and that's how the MSF agenda and these two issues are they are on the same footing. But the largest issue which will remain in this session is do we have the tools to measure, as Janet had rightly pointed out. If you are not able to measure, it will be very difficult to actually have a tool to control or to get over the problem. Do we have the systems in place where epidemiological surveillance is built all across, especially in remote and neglected areas? That's the issue I feel we should devote little time now at this point of time. I feel that way.
Right. So thank you so much for your comments and observations. Yes, HIV has received a lot of attention, as you rightly said. But I think when we talk of certain subgroups within the population we serve, the present talk focused mainly on the adolescent group, in which maybe more needs to be done, right? Though, so this would, I would say, a neglected cohort rather than saying that HIV is neglected. I wouldn't put it like that. I would say that maybe this cohort needs more attention, right? And in terms of surveillance system, the government has its IDSP system in place, as you are well aware. But definitely more needs to be done in that context, not only for the diseases which we have talked here, but even for other diseases. If there is anything you'd like to add further to that, Janet?
Sure. I actually think this is a really good point, because I agree with you. I think that we can have neglected subpopulations, and it's more a way to say that, we're not done. We haven't done enough, and we need to keep our eye on subpopulations. But even with adolescents, the WHO defines adolescence as the ages of 10 to 19. However, if you look across the spectrum of scientific literature, you will see wildly different strata. I mean, some people say adolescence is 13 to 25. We went with the WHO definition for the purposes of our project and this analysis, but I think that when we talk about surveillance and do we have the right tools, even in a disease like HIV and adolescents who've been studied around the world, I think it's a valid question of are we monitoring and surveying them correctly?
Yeah, and I'm just going to share with you something which is happening in the context of tuberculosis. You see, there are new models which are developing to capture the data and information, taking the advantage of the information technology which is available. And there are, handheld devices wherein anyone diagnosing or putting a patient on treatment can convey that in split seconds, and the information flows right up to the level. So these are things which are coming up, and I would say that yes, other diseases should also improve upon, including TB, wherein we can capture the information. Without the information, we may not be able to do the right intervention. Any more questions, sir? Yes, sir, please.
Hi, I'm Hemant. I'm trained in community medicine, and I work with the Operational Research Department of the Union. So my question is for Dr. Verghese. So thank you for the informative session. So there are two main points that came out from your session. One is that there is high seroprevalence of scrub typhus in the community. And the second point is we have so many number of reported cases in the tertiary care hospitals, which you say is the tip of the iceberg. Data from India which says that 30% is the seroprevalence. And out of these 30%, how many move on to clinical disease? And out of these number, how many move on to develop severe scrub typhus? So do we have that information from India especially?
Yep.
Thank you.
Good question. Let me tell you, there was no data even for seroprevalence. This is the first time. This is not yet published. It will be coming out in print. So going back to the same point which earlier raised, surveillance is something which is extremely important. It's not about the measuring. There was nothing which was measured about scrub typhus. We've been working on it for more than 50 years, and the biggest argument initially was serology. There's a lot of, it's not very specific. There are a lot of issues with that until we amplified or sequenced and showed this is what it is. The IgG prevalence in the community, what it means is a past infection, which means they've had either overt infection or subclinical infection. They've had the infection. 30% means there is a significant burden in the community. That is all it means. Now, they will not go on to develop the disease. We also looked at the IgM, which is actually marker of acute disease. After an acute disease, how long does the IgM last for? Data available, just getting analyzed. It takes about 6 months. After that, it will just go down. But the IgG will stay much longer. These are all people who have had the overt or subclinical infections in the past. This disease, nobody exaggerates the burden. We actually were trying to make some efforts to give an idea about the measure of the disease.
Right. I would just say that, that is how this qualifies for the session. It's one of the neglected diseases, right? So even though it's existing, it's... yes, so first let him ask his query. After him, we'll have your...
Thank you. I enjoyed all the 4 presentations, and you are from different diseases.
So could you introduce yourself, please?
Yes, I have actually introduced that time. So I am Suman Rijal from DNDI. I have a couple of questions. I will just limit myself to a couple of questions. One is for Dr. Verghese is, with neglected diseases or cohorts, one of the challenges is to diagnose them at the rural settings where most of them are, available and most of them attend. And with this ELISA, I think it's probably quite challenging if you to implement it at the PHC level. So there are 2 questions here. Do you think there is some tests which are available which can be applied at these levels, like for example a rapid test or immunochromatographic test which is available? And does the serology of the general population, will it interfere with the interpretation of these serological tests for diagnosis? And also I would like to just make a quick question and a comment on the cutaneous leishmaniasis. Injections are always difficult to implement, give to the patients, and as cutaneous leishmaniasis, though due to different species, is also seen in Latin America, and they have seen very good results with heat therapy, thermal therapy. These machines are now FDA approved and available at quite cheap prices. So has there been any experience anywhere in Afghanistan, Pakistan, because you have a different species with using heat therapy? I'm not sure myself, so if you have, it would be good.
So George, you can take the first one, and then Jen.
So excellent questions. Number one, are they are they tests which can be applied in rural settings or in the primary care centers, etc.? Yes and no. Yes, as there are rapid tests available in other parts of the world. We have tried out, doesn't work very well. It is probably because of the in the strains. There's a huge variation in strains, not only from country to country, even within the country. We have genotyped these organisms in different parts of the country. So we are actually in the process of making a new rapid test with the knowledge of the strains which are circulating in India. Probably DNDi could help us out. So this is actually something which is very relevant. We will be working on getting a rapid test which is available, which can be used as a point. Your second question about how specific could it be, meaning in the community will it interfere? Now, if you really ask me, if you look at that data which I presented, IgM will be taken as the marker for acute disease. It is only in a small proportion which will be positive, which is about 1 to 2%. So if you really see the ones who develop the disease, our data is just coming out. Having a positive IgM, it disappears in about 5 or 6 months. So it may not matter so much. My guess is, yes, it will interfere in up to about 5% in the population, which anybody will be willing to. Thank you.
So thank you for the question. Actually, it's been one of the biggest challenges that we have in the project, actually, of giving especially if it's intralesional injection. The injection is really quite painful. As I said earlier, since MSF is the only one giving free treatment in the whole of Pakistan area, we haven't really other type of treatment options available as of now. It's a very, very young project. We only started last June of 2018. It's still an ongoing process for us, all these challenges that we are encountering. So that is the reason why also as of now, we are still exploring some other options on better treatment modalities that we can actually offer to the population. Thank you.
Right. Yes, sir.
Good morning. This is Dr. Sarvjit Dudeja. When we are talking of neglected disease, I think neuromuscular disorder are a great number of diseases, particularly Duchenne muscular dystrophy and all types of muscular dystrophy and all neuromuscular. So do you think it is also relevant for this type of conference?
No, I would say that there are many such diseases which probably we were not able to take on in this short time that was available. Yes, what you say is one of the other illnesses which we could have talked on, but I'm sure the organizers will have other opportunities to include other diseases which are again neglected, other populations which are also neglected. But due to paucity of time, I'm sorry we could not include it in this session, right? Yes, anyone else has any questions, please? Yes, ma'am. Could you give her a mic, please?
I'm Jayashri. I'm from BMMC and Sardijang Hospital. My question is to Janet.
And just put it on. Sarabjit, is it on?
Janet, because we do a lot of research. Adolescence as cohort never takes our interest. How come it took your interest? Only seeing the non-response thing or any other thing which caught your attention that you took the adolescence cohort?
I think it was really our doctors noticing this treatment failure and giving us those anecdotal feedback that made us look a lot closer. But really, as I was kind of presentation, we're trying to do a lot more operational research, recognizing that we've got, again, 10 years of data. And I think it's not uncommon. A lot of programs, we sit on mountains of data that sometimes we don't take advantage of. And so the adolescents were one of a list of subpopulations that we knew we needed to take a closer look at.
Yes, sir.
Well, Petros Isakidis from Mumbai Project MSF. Actually, since the adolescents a lot of attention, I would like to share a little bit of our experience from Mumbai. And in our case, we had a co-infected HIV MDR-TB adolescents. And the first who noticed that something was going bad with them were the counselors who were struggling to give them good support. And then we looked at our small cohort, and it was surprising because we had only very small numbers, but still we didn't see that most of our adolescents actually either died or were lost to follow-up. So this is really a neglected group in wherever you look at them, either HIV or TB or MDR-TB or diabetes. Yeah. Yes. Yeah, so it started with an observation by some councils who were struggling to give them good support. Then we looked at the data and were shocked because even such a small cohort, we didn't list how much loss to follow-up and the mortality was among them, just to emphasize how neglected it was.
Yes, I think, ma'am, your point is very valid, and maybe that tells us that yes, we need to have a closer look at certain specific age populations than we conventionally do. You know, our convention, you're right, is generally either children or the elderly and all that. But here now, this particular group has shown that it has its own characteristics, and maybe we'll need to look more exactly. Yes, there could be other issues which are involved in this particular.
We are not looking into this group.
Right.
And you know, Petrus, sorry, I was going to say Petrus has a great point. I mean, there's really interesting research that's come out recently, coming out of Thailand, coming out of India, on adolescence, and there's a lot being learned. For us in Myanmar, though, like I was saying before, part of the conversation, and I think you're right that we can look at different diseases in adolescence there, but for us, really, we just felt like Myanmar is in such a transitional phase, and there's just so much activity happening in health, and yet this was a group that wasn't really being paid attention to.
Dr. Selvin?
Yes.
Am I allowed to ask a question?
Of course, also part of the group.
Okay. To Janet, Janet, the fact that you brought out unsuppressed viral load in these adolescent group compared to adults, I presume it was well matched in terms of the number of years which they have been on ART, etc. The issue is probably the underlying reason, major reason could be the adherence. Is that something which you have come across, which will need focus and attention and work further? Is that
that's our suspicion, is that it's absolutely adherence. But this kind of comes back to that conversation we had earlier, that question we had earlier about surveillance and do we have the right tools? Because our counselors are fantastic, and they really are capturing a lot of information, but they're in a different place. The data is stored in a different place. And so for us to easily start looking at that, I mean, we're now, you know, after this analysis, responding to that and trying to get a better idea of what's happening with adherence, because we do think that's the problem. But I think again, it's we need to look at our tools and make sure that we're capturing everything we need to.
Right. We still have some more time with us. Any more comments? Okay, ma'am.
It's to Siri Priya. Yeah. Because I have observed that in your presentation, it's a very nice presentation. First, the yield rate of TB suspect and then diagnosis is quite amazing. It's a very high percentage. So what makes it's this outcome? I would like to know, because we generally say that symptomatic screening in the active case finding is not sensitive enough tool. And second question is it because diagnosis is done by smear microscopy? So is it only smear positive TB cases that the 7% yield or 6% yield over there? Okay, thank you.
The data what we have presented is only the positive from the smear microscopic diagnosis. And the first one, I didn't get you. What is the first question?
Screening.
Yeah,
we've screened the population, and the high rate of the suspected case, come out percentage is quite high. So from then, again, TB case yield rate is also quite high, 6%, 7%. For example, in some other country, in the household contact screening, the yield rate is only 1 to 2%, something like this, and suspected case, yield rate is only 10 or 20%. So here in your presentation, it's quite high. So I would like to know what makes good outcome. It's learning for us as well, because I work in Mumbai in TB project. That's all.
So this project is basically the Akshaya Samvad house to house visit They're made by the trained community volunteers. So the community volunteers were trained to identify symptoms of TB, the basic symptoms. So they know cough could be a reason for TB. So they went into each and every household. So they talk about TB and gave them about the TB, and then we identified those who have the symptoms of TB. So they were either referred or in case of they were not able to, so we were given the option of sputum collection and transportation. So the trainings probably be the strategy what we have been able to identify more symptomatics.
Yeah, I think just to complement what she's saying, the other factor to training for a better yield of patients that you talk of is also maybe the population which they have studied. Now this is a marginalized group, and in that particular population maybe the yield is higher than it would be in, say, other populations. Yes, Sarabjit, you'd like to make some comment. Dr. Sarabjit is actually part of the union, and he's also spearheading this particular project. Maybe you could...
Thank you, Dr. No, I just wanted to clarify that the 2 or 3 strategies which we deployed during this intervention, which was the first of its kind and at this scale across the country, we are working in 300 districts out of 700. So one was that the selection of the population, which Dr. Sareen just alluded to. These were all populations which were vulnerable or marginalized, and our focus groups were tribals, scheduled castes, scheduled tribes, difficult to reach, having poor access to health services. That was one. Number 2 was that even when we took only 2 off as the primary screening symptom, there were a lot of cases. And when these cases were actually referred, we found that only 20% of them found the microscopy center. So this intervention was actually complemented by sputum collection and transportation, which is the yield, the success of this intervention. So if you look at it, almost 60% of the cases in the second phase, we started this intervention in April 2013 until date 5.2 million households. Initially, we were doing only referrals, and we found that not much success. But later, we complemented it with sputum collection, which yielded to these results. So these 2 approaches have actually helped: 1, selection of population, and 2, sputum collection and transportation to this high yield.
Right. So could someone help her with the mic, please?
My name is Parvati Nair. I'm from the MSF Mumbai project. My question is to Janet. You'll have physical load as a marker for treatment adherence and failure. Now, this is specific for HIV-1. What would be the load of HIV-2 in your project, and how are you monitoring any sort of for them?
Sorry, our project is actually trying to increasingly use viral load monitoring rather than CD4, as many projects are trying to transition, and I know there's a transition in India. And so there was a slide, I think, but I think a lot of our cohort, I can't remember the exact numbers, has already gotten viral load testing, less of the adult cohort, but we're hoping to transition to using viral load monitoring increasingly.
No, I agree, but the viral load monitoring is used for HIV-1 patients. In HIV-2, CD4, as of now, we don't have anything which is standardized for viral load.
Right, so but in Myanmar, it's still largely appropriate for the cohort that we're.
So what is the burden of HIV-2 in your project? Any idea?
I feel like I wanna get you the actual statistic from my computer rather than speaking from my head on this one, if that's okay.
Thank you.
Right, and if there are no more questions or comments, I would take this opportunity to thank all the 4 speakers on this panel. They have done an excellent job, both to their topic as well as to the time. And they have given us opportunity to interact, discuss, and learn more about these neglected diseases, about these neglected populations. Thank you so much. And I'd also like to take this opportunity to personally thank the MSF India giving me this chance to be with all of you and to chair this most important session. Thank you so much.
Thank you very much, all presenters, and of course also Dr. Sarin for chairing, I think, a very engaging session, first session of the day. So we have a small present for Dr. Sarin. And can I ask the new presenters of the next session to come to the stage, please? Thank you. It's good to mention that, and I think we already did that once, but that outside there are also poster presentations of additional research. And in the lunch there are also presenters close to the presentations, the poster presentations, who can help you and explain and inform you more about the other research, which is not presented live here in the venue. So I would like to ask the next presenters to come to the stage, and then I will also introduce the chair of the next session, which is Dr. Jashari Bhattacharjee. And she's a director and professor and principal of the Vardman Mahavir Medical College and Safdarjung Hospital. She's a national committee member of National Accreditation Board for Laboratories, and is president of the Indian Society for Atheroclesioris Research, an association of clinical biochemists of India. Besides many other accreditations, she has been also member of the National Task Force Committee, Ministry of Health and Family Welfare from the Government of India. She's a past graduate committee member with the Medical Council of India, and she has over 40 years of rich experience in medical academics and has several publications to her name. Welcome. Thank you.
Good afternoon. Namaskar. After this previous session of communicable disease or the infectious disease, we are coming to a very different session of non-communicable disease, but not at all less important, though it is communicable. Our session will be dealing with a very important aspects of malnutrition and psychological problems, but our focus will be mainly through the tools and the data. How could you reach those and get the data collected from the marginalized section of far off places like Darbhanga, Kashmir and all? How could they get this data? The first two presentation will be taken by Raman Mahajan. Raman here. Raman is a public health professional and trained epidemiologist who in 2010 has worked with MSS in Delhi, where he has carried out epidemiological research work, operational research and monitoring and evaluation using both qualitative and quantitative data. He is experienced in designing studies, developing monitoring and evaluation tools, database management, data analysis and documentation. His main focus is infectious disease and childhood malnutrition. So today his first talk will be on measuring acute malnutrition, retrospective mortality and measles vaccination coverage through standardized monitoring and assessment of relief and transition survey in Darbhanga district, a very marginalized area of Bihar itself, and focusing on malnutrition. Raman Mahajan, please.
Thanks for kind introduction, ma'am.
He will be continuously presenting two.
Yeah. Today I'm going to talk about acute malnutrition, mortality, and measles vaccine coverage survey using SMART in Darbhanga district, Bihar. So what exactly is SMART? So my presentation will be more focused on methodology rather than results and everything. So SMART stands for Standardized Monitoring and Assessment of Relief and Transition. So as name suggests, is mainly used for emergency setting. Even MSF has used SMART methodology surveys, but majority of these surveys were conducted in Africa. There's very limited evidence of such surveys being conducted in Indian setting. So SMART is basically a rapid assessment service. So it's a basically prevalence studies. Is highly standardized and simplified. So you can get a situation analysis in terms of malnutrition, mortality, and vaccine coverage. Let's start with context first. As Dr. Unni in his morning talk said that there is more than 1 lakh children died every year in India because of malnutrition alone. So in India, malnutrition is major public health issue, but there is very limited information about the exact situation of malnutrition in India. The last survey, the National Family Health Survey, which was conducted in year 2005, the prevalence of malnutrition in India was around 20%. Prevalence of global acute malnutrition in India was around 20%, and prevalence of severe acute malnutrition was 6.4%. In Bihar, where the situation is even worse, where the prevalence of global acute malnutrition was around 27%, and prevalence of severe acute malnutrition was 8.3%, which is quite high. Following widespread flooding in Bihar in year 2007, MSF did a nutrition and mortality survey there. And what we found there is that the prevalence of global acute malnutrition was 19%, and prevalence of severe acute malnutrition was 4.8%. And the mortality rate was quite higher also. It was 0.5 deaths per 10,000 population per day. So based on these results, MSF start his CMAM, community-based management of acute malnutrition project in a Birol block of Darbhanga district with the aim to treat malnutrition. So the program was started in early 2009, and since then over 17,000 children has been treated. The project has a good outcome, but we have quite high defaulter rate, but those who do not default, the cure rate is as high as 90%. After 6 years of intervention, we don't have the exact data on the current situation of malnutrition in Darbhanga state. With this aim, with this objective, we did this survey to determine the prevalence of undernutrition among children aged between 6 to 59 months. And the secondary objective was to determine the mortality rate, cured mortality rate, as well as under 5 mortality rate, and measles vaccine coverage in the Darbhanga district. So methodology, as I said, that we use SMART methodology. So SMART has a system to do quality check, data entry, analysis, plausibility check, data reporting. So everything is inbuilt. They provide a software, which is emergency nutritional assessment software. So you can use this tool. I have given a snapshot of the planning page of this tool. So the area was Darbhanga district. The population is very high, 3.9 million. So that was our sampling frame. It's majority rural, 92% rural. And there's more than 1,000 villages, 80 urban blocks. We did this survey in June. And so timing, of course, there is associated with seasonality. So if you conduct same survey in December, you have different result than you did it in June. So June is generally is the peak season for malnutrition, what we have seen in our admission trend from our project. So for sample size estimation, we used a estimated prevalence of 15 and the desired precision of 3.5%. And because it's a cluster sampling, we used a 1.5 as a design effect, and we get the minimum sample 653 children of under 5 years of age. To get these children, we need some assumption of the demography. So on the assumption that there will be 4.9 person each household, and there will be 16% children 5 years of age, and there will be 5% non-respondent rate. So to get these 653 children, we need to survey at least 974 households. And similarly for mortality sample size, we estimate 832 household. But since the nutrition sample size for nutritional assessment it was 974, we used the higher sample size, that is 974. The methodology was two. So villages and urban wards were our first stage of sample, and so the 41 urban wards were selected using probability proportionate to sample size, to probability proportionate to size sampling. So we use this tool to get these 41 villages. We just import the data of population, village-wise population in this ENS software, and 41 clusters were automatically selected from it. And then we used a already ready-made household list to get further second stage. So we used recently done socioeconomic and caste census survey to get the household list. And since villages are very widespread and very populated in Bihar, so it's not feasible for our survey team to cover all the village. So we did a further segmentation based on enumeration block. So each villages was further segmented into enumeration block, which covers around 250 to 300 households. And then we selected each enumeration block from this 41 selected village based on same PPS sampling. And then from each enumeration block, we select 24 households using simple random sampling. So we used two questionnaires, open, close-ended, standard questionnaires. One for questionnaire and one is for child nutrition questionnaire for children aged between 6 to 59 months. And the variable which we anthropometric variable which we collected was weight, height, age, and MOAC. Age, I will tell you that age in that context is very difficult to obtain, because in Darbhanga, mothers rarely know their children's age. So what we use a locally made event calendar, so that the event calendar is basically we report all these important events in Darbhanga district, like festivals or seasons or harvesting season, and so that we can came as near as close as much to the child exact age. So what exactly is malnutrition? So when child has inadequate calories in their diet, they usually have low protein energy and they suffer from protein energy malnutrition. WHO, according to WHO reference, there's three main indicators for malnutrition. One is wasting, then stunting, then underweight. Wasting is the most important, which is an indicator of acute malnutrition, which is when the child have low weight for their height. So when it is less than 3 standard deviation from the reference WHO standard reference, it is called severe acute malnutrition, and when it is less than 2 standard deviation from the WHO reference, it is global acute malnutrition. Apart from WHO Z-score, the other commonly used criteria for wasting is MOAC, which even in our project we are using. MOAC is mid upper arm circumference. If it is less than 150 millimeter, it is severe, and if it is less than 125 millimeter, it is global. Stunting, which is of chronic malnutrition, which is also very prevalent in this part of the world, is also when it is less than 3 standard deviation from WHO standards, severe, and when it is less than 2 standard deviation from WHO standards, global acute malnutrition. Underweight, which is a sort of composite index, which covers both chronic as well as acute malnutrition. Similarly, it's less than 3 standard deviation for severe and less than 2 standard deviation for global. For SMART methodology also recommends some cleaning criteria. So when data is like plus minus 3 standard deviation from the observed mean, there's more chances that data is either miscalculated or there is wrong entry. So we exclude these flag data from our analysis. So for survey, we use 5 teams of 3 members each, 2 measures and 1 supervisor. There were several pre-survey activities, like we did a 3 days training to surveyors, then we did a pre-testing of the questionnaire tools, then we did a standardization test to evaluate the performance of survey team. And the data quality check was done by plausibility check report. Plausibility check report gives a estimation that whether your data is of good quality or not. So in our case, we get it gives a number. So we get like 22%, which is acceptable range. So we are okay with our database quality. So, and we use ENS software for data analysis. So these are some pictures of the actual survey. This is the first picture is of standardization test. Then second is the pre-testing of the questionnaire. Then we use a locally made height board and Salter scale to measure height and weight of child. And all these instruments were calibrated every morning before the survey. So let's come to the results. In fact, we didn't reach the minimum sample size. There were several reasons behind it. First, like there were few houses which were missing because it was vacations in Darbhanga. Children were out of their house, and we also overestimate proportion of under 5 children. We said 16%, but in reality it was 12%. So that's why we didn't reach a minimum sample size. So we reached 906 households covering 5,537 individual and 510 children aged between 6 to 59 months. Among 510 children which we surveyed, 55% were male, 35% were less than 2 year of age, 12% belonged to scheduled caste. And we also asked question about public.
Raman, just to remind you of the time.
Okay.
Just hurry up and.
Okay. So we also asked question about public distribution system, and so 43% the children have shows that they are below poverty line. 7 children reported they have some sort of morbidity in last 2 weeks. The major morbidities were fever, cold and cough, diarrhea and vomiting. And these graphs show that our data is quite representative of our sample was quite representative of the demography. Acute malnutrition, we found that 3% of our children were severe acute malnourished and 14% global acute malnourished. If the graph is quite skewed toward the left-hand side from the WHO standard graph. And the main risk factor for global acute malnutrition were age less than 2 years, children belong to scheduled caste community, morbidity in last 2 weeks, and the only significant risk factor for severe acute malnutrition was in last 2 weeks. And based on MOEC cutoff, we found that 3.7% children were SAM and 9.8% were CAM. And the only risk factor for finding children SAM is age less than 2 years. And the prevalence of underweight was also very high. The 44.3% children were underweight in our survey, and of these 13.6% severely underweight. And the prevalence of stunting was also quite high. 45.6% were underweight and 18.2% were severely stunted. Mortality rate was low. The crude mortality was 0.2 deaths per 10,000 per. There was no significant difference between male and females. Most of the deaths, 2/3 of the deaths were people who were more than 65 years of age. Under 5 mortality rate was also low, 0.34 deaths per 10,000 per day. Measles vaccine coverage was minimal. We found that coverage was 80.3%, but only 35% was verified through immunization card. The remaining 45% don't recall, so it could be or right, we don't know. So this is the result. This table is comparing results with NFHS3 conducted in 2005-06 with and MSF survey conducted in 2008 and 2014. So there is some declining trend.
Raman, can you come to the conclusion,
okay.
Or do you have any more slides to present?
Just one more slide. So there is a slight reduction, just slight reduction in acute malnutrition if you see from NFHS3 in 2006 and with the current survey. So I would like to conclude with the remark that the prevalence of GAM and SAM is reducing, but it's not to that extent, because if we compare with 2008 survey, MSF survey, and this survey, the confidence interval is overlapping. So it's not much difference from the 2007, and we don't have any evidence of on improvement of general food security in the community. But good thing is that both the severely acute malnutrition and global is below the threshold of emergency as given by FAIR standards. The under 5 mortality rate is quite low, and the measles vaccine coverage is okay. So what I would recommend with this study is that the level of malnutrition is still very high in Darbhanga district. There need to be some good intervention needed to be done in that community to make these treatment for malnutrition more accessible to the children. So community-based management of acute malnutrition could play a good role in it. Malnutrition is caused by several factors. There's not only single factor which is responsible for malnutrition. And high morbidity in the community, that is 57% in month of June. That shows that their children are suffering from many seasonal illness. So there is need to improve the access to public health care system. And in the gap of evidence, I would like to recommend smart methodology to use for conducting malnutrition survey. That's all.
Thank you, Raman. I understand his passion and his emotional involvement with these malnourished children, but our time is short. And you are also having another topic to talk about on the same thing, management of acute malnutrition program in Darbhanga, using another mobile data collection, I think another tool. So before we go for questions, I think we can start with the next one, and we can have the question. But if you want to have little question from them, you have to hurry up now. I can give you only 5 minutes so that we can interact more. Can you finish by 5 to 7 minutes, the next one? Please, otherwise we won't have time for interaction.
I have a question.
Yeah. Online? Yes.
Online?
That you answer.
It's called, it says, can you share the cost of using SMART?
It's very minimum. We didn't hire any consultancy to do the survey, so I think it was around 300,000, something around this. It's 1 month, 15 days.
So his next data collection for routine monitoring of the community-based management of acute malnutrition program in Darbhanga. Raman, please.
Good afternoon again. So the second presentation is about the use of mobile phone for data collection in this management of acute malnutrition program in Darbhanga district, Bihar.
This time, please take less.
Yeah, it will take some time, less time. So,
Sorry.
no, it's okay. So what exactly is CMAM, Community-Based Management of Acute Malnutrition? So, model of care for treatment of malnutrition. So, once malnutrition children came to you, you screen children using some appropriate criteria. It could be weight for height score or mid-upper arm circumference. And then the severe acute malnutrition is with no complication. Children are treated. Majority of children, more than 85%, treated in outpatient basis in the community, and those who need immediate medical attention, and they were or have some complications, they were the inpatient therapeutic care are providing to them. So now I'm going to talk about MSF CMM program in Darbhanga district. We started this CMM program in 2009, so more than 70,000 children treated since then. Children admitted is between 6 to 59 months. The admission criteria we use in our project is mid-upper arm circumference. We use MOAC less than 115 for admission and or bilateral edema or and discharge when child has MOAC more than 120. So it's a three level model. So at the baseline is a accredited social ASHA, which is a government health, which usually refer to children to us. They screen children using MOAC tape and refer the same children to primary health center, where our ANMs again these children, if they found children as SAM, then they start treatment. And those children who are complicated and need medical attention and inpatient stay, they were referred to second level of a model, which is nutrition rehabilitation unit, where there is GNM, general nurse midwife, look after these children. And those even more severe children from these, those who need a doctor, they were referred to tertiary care hospital, medical malnutrition intensive care unit situated in Darbhanga district. So why we collect data as an all program MSF is doing this, mainly for monitoring and evaluation purpose, and also to keep track of patient response to treatment. Also we use this data for operational research purpose, which we can later use for advocacy purpose. The conventional data entry method was that we doctors enter patient information in treatment card. Data entry operator took this treatment card, entered data into Excel database, and then we analyzed. But the it need time to enter data, and it need resources, paper, data entry operators. There's common and there's reporting delay. So what our innovative legislation think of in 2013, that maybe we can use mobile phone for data collection and sharing instead of common paper-based data entry. So we consult a social enterprises company which provide a open source platform, which is ComCare, which is subdivided into two platforms. One is ComCare Mobile and one is ComCare HQ. So basically, the aim is to provide field worker better track and support registration and follow up. So how does it work? So you can create a form in the ComCare HQ, which is a server-based device. Then you can install this application in your phones, and then from the phones you can enter data, and then
Raman, 2 more minutes. Okay. Then we'll go for discussion.
And then data can be and then from the server, data can be data can be accessed by anybody who is registered. So here 5 nutrition in our project is sending this data through their Nokia mobile phones, and then this data was received in the server in Delhi. Then we can monitor the data routinely from our site. So for example, a mother came to our PHC in Darbhanga, then A&M entered the data, A&M make a summary sheet. Then our nutrition link worker visited the site and take the summary sheet from the A&M and enter data into the mobile, and then submit the button, and then this from the mobile the data was received into the server, and the registered program managers can access this data from the server at any time. So it saves our time, it saves paper. The data is actually real-time database. There is no need of data entry operators or papers. So this is some data we received from the mobile device since September 13 to September 14. There's some missing when we compare with the conventional way of entering data. There is some data lost. So only 70% of total admissions were recorded. So main challenging is delay in data sending. Our nutrition link worker not sending data. There's no check rules applied in the mobile. If they weight of 5-year-old child as 50 kg, we cannot differentiate it whether it is right or wrong. Sometimes there is no or poor internet. Also, the nutrition link worker reported that screen is too low and screen is too small and keypad is very small. And so what we learned from our pilot intervention is that there's need some improvement. We need a system to develop daily quality control and upload data. We need to have a on-call tech support. Instead of 3G system, data sent through SMS will be more useful. We need a training of A&M nutrition link worker, and instead of having a summary data set, we can use to have this phone mobile to get information directly from patient. Thank you.
Few quick questions. Yes, please. Please speak into the mic so that even they can hear you what you are asking.
Thank you, Raman, for your nice presentations. I would like to understand, you mentioned about the NRC model of the MSF in Darbhanga. How is it different from the Government of India Nutrition Rehabilitation Centers model, which is operational?
For example, Nutrition Rehabilitation Center and a very limited capacity. It's only inpatient. So, for example, for whole district is 30-bed NRC. See the burden of malnutrition is very high in that district. It's not sufficient, and it's not outpatient basis. And in our CMM model, is majority 85% children is treated in community on outpatient basis.
Can I have one more question?
Yeah.
This is regarding your first presentation, the smart tool that you were talking about. What is the possibility of adding your own customization questions in that instrument? I mean, like, it seems to be very suited for nutritional surveys. But
you can add, but in analysis, in report, it will analyze only data inbuilt in SMART. Like we added the questions on measles vaccine coverage, but then you need to analyze separately using different software or like other softwares.
Thank you.
Any more question? Yes, one or two more we can having 1 or 2 minutes more.
Thank you, Raman. I think excellent work which you guys are doing in Darbhanga. I work for Government of Karnataka, and we used to run the mother-child tracking scheme. and we found this tremendous inertia amongst the A&Ms, especially in the 40 plus age group category, in terms of using mobiles for entering data, and behavioral issue of getting them to mindset that mobile is also used for. So what was your experience in terms of the more senior health workers in implementing this mobile-based app?
Actually, we didn't use government. We used our MSF staff who were using mobile phone. They were quite okay with it. So they were sending every day, but we give a training. So still there is some problem. They are not sending. They are not sending every the data every day, and if there is some problem, they are not. Even we don't have any in-house capacity. If there is any technical problem, right, we are still depending on the company who is providing us the. So as I saw that we need a on-call tech support and a training to health workers to make it more useful.
Yeah.
Thanks, Raman, for the presentations. Just one question quickly. Have you thought of looking for TB? Considering that we're in India, you looked at measles. TB is associated with malnutrition. TB is heavily underdiagnosed or grossly underdiagnosed among these young children, but we know that it happens. But just have you ever thought of incorporating, including TB screening strategy among this population?
Not yet.
Last question.
Thanks, Raman. I just want to ask, what is the cost of this software and like this computer server, they store this data in the server. So what is the total cost involved? It's like number of patients or for like it's for 3 years, duration of the study for 3 years?
It's a open source software, but if you need more qualities like sending GIS coordinates or sending images, then you need to pay for it. But the basic is free.
So I personally thank Raman for this wonderful work, because it is not easy to data collection. Even in Delhi, it is very tough. So I can understand being in Darbhanga. So congratulations for carrying out this research and giving us the opportunity to hear your findings. So next week, from malnutrition, I will go to mental health. Our next speaker is Shabnam Ara. She is a clinical psychologist and works in MS Health project in Kashmir, India. She received graduate and postgraduate degree in psychology from the University of Kashmir and her M. Psychology, the Department of Government Medical College. She qualified for the NET conduct test by UGC and prepared papers in JK Science Congress and Regional Science Congress 2013 conducted at the University of Kashmir. Shabnam Ara will be speaking on adapting mental health screening tools to the Kashmir Valley, a contextual description. Shabnam, please.
Thank you, ma'am. Good afternoon, and I welcome all of you.
Please stick to time. Your time is 7 plus 3.
Okay. My presentation is about cultural adaptation and translation of depression, anxiety screening tools in Kashmir Valley, India. This is the outline of my presentation, what I'll be presenting here. Context of mental health in Kashmir, why we did adaptation and translation of these two tools, why we chose Hopkins symptom checklist and Howard trauma questionnaire, and finally how the main steps involved in this cultural adaptation and translation, how we did this translation and adaptation. So as many of us here know that there is more than 2-decade-long armed conflict going on in Kashmir, which has a serious impact on the mental health of the people who live there in Kashmir. And the psychological injuries resulting from this conflict can have more damaging and long-term consequences, but they remain distanced and undetected. Therefore, the need of the hour is to highlight the damaging consequences of this this conflict on the mental health who live there in Kashmir. It's pertinent to mention here that MSF has been providing mental health services in Kashmir since 2001. We are planning to conduct a mental health survey to estimate prevalence of depression, anxiety, and post-traumatic stress-related disorders in Kashmir Valley. once we decided to just estimate this prevalence, there was a question how. There has to have some tool to estimate this prevalence. Therefore, we approached two mental health institutions. We were searching for the tool, and we approached two institutions in the Kashmir who primarily deal with mental health. One is the Institute of Mental Health and Neurosciences, which was formerly also known as Department of Psychiatry, and the postgraduate Department of Psychology. But to our surprise, we found that there was not even a single tool that has been validated, adapted, or developed for the Kashmiri population. Here comes the question of why. That is why we just chose to adapt this and translate this tool, so that we have some tool that will be adapted and translated for this population. And also, by first adapting and translating a tool, we can just focus and get the robust results for the survey. Then once we decided to adapt and translate a tool, there was another question: which tools we will take for this adaptation and translations. There are several tools available, but why we chose this specifically Hopkins symptom checklist and Howard trauma questionnaire, I will mention here why. But before that, I'll give a brief description of these questionnaires. Hopkins symptom checklist is a 25-item questionnaire. First 10 items are used to assess the anxiety symptoms, and the remaining 15 items are used to assess the depressive symptoms. And the Howard trauma questionnaire, HTQ, it's used for assessing the post-traumatic stress disorders. It consists of 16 items. Now I was just mentioning why we chose specifically these two tools, because we found that they have been extensively used in post-conflict settings, and also there is another thing that came out, that it has been translated into Urdu and has been used in similar populations in Afghanistan, Pakistan, Iran, and more importantly, from our initial roundtable meetings, collaborators, Institute of Mental Health and Neurosciences, and the faculty members, Department of Psychology, and the MSF clinical psychologists, we just felt that the items in this tool are appropriate to the Kashmiri population, but they need to be culturally adapted and translated. So now I will be discussing this thing, how we culturally adapted and translated this tool. Multilingual Kashmiri team in which we had psychiatrists and faculty members from the Department of Psychiatry, the faculty members from the Department of Psychology, and the MSF clinical psychologists. This is a multilingual team who reviewed every single item in these tools and then identified the Kashmiri constructs for these items. Mentioned here, they identified Kashmiri constructs. It was not a direct translation. It was that they identified these constructs. Then and kind of a draft was formulated in Kashmiri. And then in the second step, we had a free listing interview. We trained a few students from the Department of Psychology who conducted 40 interviews with the 40 individuals, socio-economic groups and different domiciles. Male and 20 were female among them, and then these interviews were conducted to find the lay terms, the cultural terms that Kashmiris use to express these symptoms, these disorders, and the results from these interviews were compared with these constructs that were already identified. They were compared with those constructs, and kind of a pre-final Kashmiri tool was formulated and framed out, that was sent to the translators, to independent translators, to experts who were from the Department of English, University of Kashmir. I have mentioned here, it is blind, back translation blind. Blind by blind, I mean that they were not the part of the group who participated in identifying the constructs. So we sent simply the Kashmiri version to those translators, and when we got these translations, they were reviewed again. By the team consisting of those psychiatrists, faculty members of the psychiatry, and psychologists and the clinical psychologist. We just reviewed, and kind of a pre-final draft was formulated. Kind of a final, I can say, final tool was formulated. Kashmiri adapted tool was formulated and translated. We had that tool that was then pre-tested by 4 MSF clinical psychologists across 6 different locations in Kashmir. Is that slight variation in the use of the terms from North to South Kashmir that we include within parentheses in our tool. Then another finding in that pre-test came out that item number 9, that was of the Harvard trauma questionnaire, that was feeling on guard, was found very difficult to adapt, and therefore we changed that to constantly feeling and acting ready for any kind of threat. This question was then rechecked and rechecked for understanding and felt to be appropriate. The internal reliability was by using Cronbach alpha, and it was found for Hopkins symptom checklist to be 0.92, and for Cronbach and for HTQ, Harvard trauma questionnaire, the Cronbach alpha came out to be 0.95, indicating a very strong internal reliability of these tools. The limitation of this study was that it was confined to the pre-test, which had a very small sample size. The conclusion of the study is that the direct translation of these tools into Kashmiri would have led to confusion, misunderstanding, and inaccurate results. Therefore, the transcultural adaptation and translation ensure tools identify local constructs for expressing symptoms of mental illness. And more importantly, I would like to conclude with this thing that very basic and root level exercise for getting a tool so that we can conduct such a huge survey that MSF is planning to do there in Kashmir in coming few months. In that we will be serving 3,700 households across 10 different districts, and having a very reliable some tool that is culturally adapted and which will provide us some valid and reliable results is very important. That's all from me. I just want to thank all the collaborators who collaborated and participated, and my special thanks to the principal investigator and the epidemiologist of this project, Tamri Housen, who provided me this opportunity to present this here. And I thank you, all of you, for listening to me. My request to you, you can just hold on. If there is any question, any query regarding this, all the questions I have.
Without question, we can go to Mario. He's talking. Nantas is currently working as a logistic coordinator with MSF Holland in India. He values the role logistic plays in enhancing MSF's work and stresses the importance of continuous improvement. He believes that field workers should push for change and excellence in humanitarian work. Nantas, please.
Thank you.
And his talk is use of mobile technologies. Again, we are coming back to mobile technologies in data collection for a mental health survey in Kashmir, India, a pilot study. Nantas, please.
Thank you. So apparently, as you all understand, there's a lot of talk about mobile, right? Raman already mentioned something. Dr. Sharing mentioned that the Public Health Foundation of India is on top of it. For those that yesterday watched the London Scientific Day, there was like 3-4 different solutions presented. So the question is, for me as well, when I was developing the solution, was what is the new element that I'm bringing? I'll answer this question after giving you a little bit of background. So the plan that we have is to conduct a mental health survey in Kashmir that will involve a 10-district, 3,700 households in that. And MSF historically has been collecting the data via paper questionnaires. For those that in the past have done surveys like this, the number 3,700 questions, 15 pages, and data entry afterwards, I'm sure it gives you the chills, right?
Yes.
I mean, the picture is realistic. The image on the presentation is realistic. That's what people have to deal with that do long surveys. So for us, we decided to try something new, and instead of the paper, to use tablets. So we piloted. We took the chance of the validation of the mental health tool that Sabnum just presented, also to test and pilot the use of the tablets for that solution before we go to the big survey, so to reduce the risk of failure, let's say. Okay. Our target was to eliminate time-consuming and error-prone data entry, paper-filling questionnaires by default, because human behavior involves a lot of errors. Okay. To reduce the time for processing the data, imagine that after collecting the data, someone has to sit with a pile of papers and punch all this data into a computer. A lot of mistakes happen over there as well, plus the time that someone spends on that. And of course, we can also involve the photocopying costs, if you want. Almost 4,000 questionnaires, 15 pages each, 2-3 rupees per page, so you can do the calculation roughly and see how much is the cost, only for photocopies, let alone the rest. Based on research that has been done, I'll just give you a rough number, some rough numbers. We're talking about reducing the cost of big surveys at around 25%, with the accuracy of data increases, the time of the whole survey reduces. Some research, they even mention 94%, so it halves, basically. Are reduced. You don't need someone to punch the data afterwards into a computer to transfer the data from paper to a computer. And of course, the data quality, and that is the biggest advantage, I think, for the epidemiologists. The data quality increases tremendously. Research mentions that several research sources mention from 14 to 57% more data accuracy, and an error rate of 3% of errors versus 35% if we compare mobile to paper. Yeah. So the project for us, we also use the Open Data Kit. It's a very common open source kit that we developed in-house. The questionnaire was uploaded on tablets that 4 of our counselors, psychologists, used to provide to a sample of 5 outpatient departments. There was a different language script provided, so the counselors had the choice to choose between English script and Kashmiri script. That was also in order to avoid wrong data, we provided pre-coded skip patterns. So if a question was not relevant, was not appearing afterwards. Okay. And also we provided limitations on the range of data. So the head of the family, just to give you an example, the head of a family cannot be below 20 years old, right? It's a bit of a common sense. Okay. So these were possible to integrate. We had the questions were stored into the tablet, okay, and we had automated. So the moment that the tablet would return in our office, automatically the data will be uploaded on our server without any human interaction. That will happen automatically. There was also the option. There were the options to do it over 2G or 3G. The data size is very small. We're talking about a few. So there was this one to do it. It can also be done via if you connect the tablet with your smartphone. If you are outside in any place that has mobile coverage, you can create your mobile phone as a hotspot and connect the tablet and upload the data. Okay, so everything is possible, also offline via cable. So the outcomes, I think it's better for Sabnum to, with first-hand experience, to present to you, and I'll come back later.
Thanks, Nuntas. I'll not take more than 2 minutes. Nuntas just asked me to present the outcome. It's because, as you can see, I was among one of the psychologists, data collectors who use this tablet for data collection. I think I did more than 70 interviews by using this tablet. And the overall impression that I had by using this tablet is that it's very innovative, very efficient and accurate method of data collection. As you can see from the study, we did some of the interviews using the paper that we found later not properly entered, and all the cases, some of the cases were, some of the data was missing. As you can see, only 96% of the cases were complete, and rest had some problem with them. Either data was lost, and even in those complete cases, there were 20% cases where clarification on the handwriting was sought. And it's here important to mention here, we did only few interviews. It's only 9 interviews that we did by using this paper, and we had trouble doing this, and there was missing data and things like that. While the interviews that we did by using, there was no such issue, and it was very efficient and accurate method. Another thing that is, it was about us, the data collectors. Then there was another thing that what will be the perception of those with whom we use these tablets, the respondents. And we found that there was overall very positive. They responded very positively when we collected data by using these tablets. Found that the respondents were in fact impressed and intrigued by this technique, and this is first time that we used technology data collection. Traditionally we use in Kashmir or in many areas paper for collection of data. And one important thing as data collector was that this technique served as icebreaker. Here by this I mean that it helped us to build more rapport. Once we are noting down something with paper, it requires more resources. We have to focus on and enter every data that we are asking, so we do not get really proper time and to just interact with the person from whom we are getting the information. Therefore it helped us in that while we are talking to the person, we can enter simultaneously also. It does not need us to actually sit down and first just note down the things in the series. That in that way it to build the rapport and do the interview properly and get the proper information. And there is again one important one, I can say, a good feature of this tablet: auto calculation of the scores. Once we did this interview, automatically we get the summated score of the person, so that if sometimes the person respondent asks, where do I stand on these dimensions, we can just provide the feedback instantly. And there is again one implication of this auto calculation of scores. Once we are interviewing the person, maybe he or she comes out to be in a depression, in anxiety, or something like that, within traumatic kind of a situation. So these scores, although we can clinically find out in the interview that he or she is depressed or something like that, but this helps us to actually instantly corroborate our clinical observations, and we can simply refer the patient to the psychiatrist or the concerned clinical psychologist for the immediate help. One more implication of this, using these tablets, and there are a few other features that maybe Nontas can more elaborately speak on that. Nontas, please. Thanks.
So to add to that, there's several possibilities. You can record the geolocation, so afterwards when the data downloaded, our epidemiologist can do an analysis based on the location, based on the area, using the GPS coordinates that are recorded automatically. Of course, the real-time, as already mentioned, the real-time review of the data provides the opportunity very fast to give feedback to the team, to ask clarification. So it also improves the quality of the data. And for us, we didn't also encounter any issues with data losses or technical issues. So the conclusions that we have is that our experience advocates for open source mobile technologies to be used wherever MSF gets data. Secondly, our pilots proved the upscalability of the solution. The big mental health survey that we are planning in Kashmir for the 10 district survey. Okay, it proved that we can do it. It's easy. It doesn't cause any big problems. For me, additionally to that, and to answer the question, the difference that we bring is that this solution is a frugal solution. This was built in-house, existing resources. I'm not an IT person, despite someone might suspect. Probably most of you here are better in IT than I am. Okay. But this is a very frugal solution. It was built in-house without the need for expertise. And to be honest, I even avoided asking for HQ expertise to avoid the bureaucracy of HQ. So we did it. So we did it ourselves. Okay. It's possible. It's an easy solution. It also breaks the silos. Logistics with medical departments, with the project collaborated all together, and we brought this in place. We didn't ask for experts. We didn't fly people in. It's also a solution that is easy and doable in insecure settings where people, experts and externals cannot fly in. Okay, here in India is fine, but imagine flying experts and companies in places like Afghanistan or Iraq or Syria at the moment. It's a high security risk. Regarding the sustainability of the solution after, let's say, myself leaving, for the moment we have trained our national staff, we have trained our IT officer, we have trained our national staff in the medical department, and they are already able to pick it up and continue and actually expand it even better than we would do it. In terms of confidentiality concerns, someone asked the question about confidentiality. There is a secure transfer the data online, but the good thing is that you also can do it simply via a cable. Okay, assuming that those guys steal data from us are always more sophisticated, we can do it the traditional way via a cable. So that option is also there. So again, I'm not an IT person. The only thing that I touched was an Excel file, and the rest happened via the ODK software. And there is a very strong volunteer community active, the ODK community, which have a lot of information. So thank you very much for listening.
Thank you, Shabnam and Nantes, for carrying out this work in Kashmir Valley. So now the house is open for questioning. I think there is one online.
There is one question from the online audience, and I think it's for you, Raman.
Tambin horses? Where?
To join us maybe in the panel because he was also.
Where? Tambin, Shabnam and Nantes want you to join for the discussion. Question from here. The online question.
There
you
is
want
one
first?
question from the online. Raman. It says, can you explain why the data is aggregated and not individualized?
In the mobile phone technology.
That's right.
Because we cannot, because it's a pilot initiative, we cannot rely totally on mobile phone. As I told that we don't have even in-house capacity if something happens, if like device fails. That's why we keep our conventional way of data entry as parallelly, but we just do it for summary. But the summary you cannot do operational research on it, but you can have good idea, good monitoring statistic from that.
One more online question, offline.
As both Raman and Nonta said that they are using mobile technology and internet tablets in remote areas. So in India, remote areas, they don't have the access of internet. So how you handle this kind of situation to send the data to your office or?
For example, in our case, so the system is like this: if there is no internet available, whenever there is excess of internet, and data will be sent to server. So there is slight delay in data sending, but we receive the data. So
yeah, from our side, it's pretty simple. If there is no data connectivity, you're stuck, right? But I mean, reality has it that there are very few places around in India that actually they don't have connectivity. Okay, so for us, we can set it up. We had the choice to set it up, and the software automatically, the moment it picks up the signal, the data are uploaded. That can be done automatically.
Data will be on the air and it will come later on.
Good afternoon. I'm Dr. Soumya. First of all, I would want to congratulate the MSF team for working on something as neglected as mental health in India, not just India, across all conflicted areas. My concern is regarding uploading data on the internet services, because something like mental health in conflicted areas is it has socio-political repercussions. So I'm concerned about tampering of data on something which is uploaded on the net. How do you deal with that, or what's your experience on that? Thank you.
Yeah, for us, for the pilot, we made sure that there was no way connecting the data with individuals. Okay, they were happening at counseling centers and not at the houses of people. Okay, but indeed that is a concern. Yeah. So for us, we have two options. The software itself offers a very strong encryption. Yeah. That can be used. There is also, as I said, there is also two other options to restrict the transfer of data only on an intranet that is not connected to the cloud, okay, or to do that completely offline with cables, with USB cables, which is, let's say, the most secure.
Yes,
okay.
Cable will be not secure.
The issue of mental health screening tools or having the cultural limit is very well known. It's nothing new. We all know it. But the larger issue is how relevant and how strong is the database or the social environment for giving a translation tools all across the country. And that's the fundamental issue that has been raised. Am I audible? If you see in Google Translate, we do not have Kashmiri as an option available. Leave aside the nuances within the Kashmir, that's North and South Kashmir that you mentioned. So the real thrust could have been that we need to devise a tool which gives very strong culturally adapted translation tool, because that will be the point actually. One translating one mental health screening tool and another, that's so that it is not physically possible in one's lifetime. All of them, the standardized Western mental health screening tools, which are not tuned to Indian environment. I think that could be the second issue that you mentioned. The interviews that you had with 250 OPD patients and this ODK software, did it have Kashmiri as an option?
Yes.
It had. But then the question of validation would arise, because in our paper, she mentioned the issue of validation. It was not valid. The translation was not valid.
Thank you, sir. It is noticed a very important point that we should have made some indigenous tool that would have been specific to the Kashmiri population, but because of limited time and resources, we could not do that. Therefore, we chose to adapt and translate. After this, there is another step of validating the tool. I have only presented first part of it, that is translation and adaptation, how we did it. It was about that only. So next step will be after this, that we are in the process of validating the tool, getting the cutoffs for the Kashmir that we can use. for that. That is it. And the second question, maybe Mohandas can answer.
Indeed, you have a point there. That was also our question. Like some terms that in Kashmiri is very difficult to express them in Hindi or in English. Okay, that's why for us we provided the option the interviewer to choose between different scripts. That was there. They could choose between English, between Kashmiri. You can put any language. You can put Chinese. You can put Greek, which I'm interested in actually. But yeah, you can put everything. The option is there.
I'm Uman. I work with the George Institute. We've been using tablets for data collection in Andhra Pradesh, and we have a large cohort of more than 25,000. One of the questions I want to bring to you is that the quality of data is directly proportional to the amount of training that you give your health workers. Because for something as simple as a height and a weight, there can be so much of inter-observer variability, which or a software can take. So whatever money you save from the paper forms, you have to reinvest that into training of the workers in actually collecting the data points the correct way.
Yes and no, I would say. It depends also. I mean, for us, we had the luxury. You have a bit of a different case. For us, we had the luxury that our counselors are highly educated people, and they are used, in any case, in tablets. For us, just to give you an indication of the cost for doing this, it was just the cost of the 4 tablets to buy them, which was 7,000 rupees each, and the cost of my tickets to fly to Kashmir for 1 day and show them how it works. That was the whole cost. Okay. So in terms of investing on training, it depends on the questionnaire. The good thing is that the questionnaire has auto-validation algorithms in the back. So indeed, it reduces the errors. Okay. At the end of the day, I agree that it has to do with humans, and you can never predict that. But at least we try to minimize the errors as much as possible.
There is a question from this side. If the purpose is to validate a tool for collecting data, why did you choose Kashmir for it? You could have as well done it from any other place in India and done it.
Sorry, you're asking why we chose Kashmir? Exactly. Okay. Because we are planning on doing a mental health survey in Kashmir. Although small research studies have been conducted in Kashmir on specific populations, looking at PTSD, depression, and anxiety, there's been no survey across the see what is happening as far as mental health goes. And the clinicians that are experienced in seeing patients are reporting increased prevalence of depression and anxiety disorders. So MSF have decided to do a valley-wide survey, and for that we needed a specific tool we would use in Kashmir and know that our results are not going to be overestimating or underestimating the problem there.
I'm Dr. Indira Kurana, and I work with IP Global, but I'm not a medical doctor like all of you, so excuse me if my questions are not really. I'd like to really congratulate all of you, and especially you, Raman, for the work that you've done addressing malnutrition. So you moved from doing an assessment to actually taking some kind of action after you get the results. So I think that is something which is really great. I've nutrition more looking at it from the drinking water and sanitation angle. And I did a survey looking at, okay, what is the access to nutrition and what are the malnutrition levels in excluded communities, namely scheduled caste and scheduled tribes. And during that study, I found that there's so much data that the government collects. I mean, kinds of data that the government collects. Is it not possible to use this data in some form, analyze this data? Because places I go and all the documents I see, people refer to the NFHS 3 or whatever, 2005. It's now what, 20 years, how many years down the line? We have a global hunger and nutrition index which says India has moved several steps. We don't have the primary data. Possible to use the government data? That was my first question. The second question was that in terms of why so much of malnutrition in Darbhanga, you mentioned that flooding was one reason. I think access to wash and sanitation, wash is another major criteria, and we have several reports which link stunting in India to lack of access to drinking water and sanitation. And Bihar is not very good on access to these two in any case. And also you mentioned the poor PDS system. I think you'd be glad to know that in this month itself, Jean Reyes has come out with a report which says that from a 20% level of satisfaction in Bihar in terms of what quality food grains they get, it's now moved on to 80%. So we are still not completely there, but at least hopefully Bihar is making progress in the right direction.
Thank you, ma'am, for questions. For your first question regarding data access, as far as I know that NFHS 4 is undergoing. So, and NFHS 3 data available, you can available easily online. You just need to, yeah, yeah. But the latest one is ongoing.
As part of their programs, no?
Yeah.
And because they're implementing nutrition programs, they have all this kind of data that they collect. Can that be used to actually assess faster what is the level of malnutrition?
Yes, that can be used, but that is organization's policy, that whether they use share data or not. My personal opinion is any data or any research organization, the data they are collecting, that could be utilized for operational research or research purpose to generate evidence. Regarding your second question, which was sanitation. As I told that malnutrition, there's several causes, and there's no single cause for malnutrition. So like there's some studies on nutrition causal analysis going on. So it could be Watson, it could be disease underlying, and there's some study that there is also some cultural issues like girls' preferences in India. So girl is more malnourished than boys. So yeah, but Watson water and sanitation is important thing which always need to be collected when you consider risk factor. And public distribution system, I agree with you, because for the survey everyone was happy with public distribution system. I think that's an achievement for government.
Okay, can I? Are we looking at maternal malnutrition as well? That's a question, but I have a comment as well. Towards the end of your presentation, you compared your figures to the SPHERE standards.
Yeah.
We have to keep in mind that the SPHERE standards were developed for emergency situations. It's a very crude, so in situation, especially in places like Bihar, where you have other sources of data, we use different measures for. We can't always go back to, in MSF we have a tendency to go to SPHERE standards because we work largely in emergency situations. But in as much as it's possible, we should try other measures for comparison, because SPHERE standards are not good enough, I think, for our purposes. Then my question was following on from, we look at malnutrition in children and we say girls are more malnourished than boys, but we also need to look at the status of the mother, right? The mothers usually tend to be malnourished, and that could be one contributing factor to children being malnourished.
Yeah, for this survey we didn't consider it, but I am agree with you that maternal malnutrition is significantly associated, should be significantly associated with childhood malnutrition. Also, there is like some studies that maternal malnutrition during pregnancy is a risk factor for low birth babies,
yes,
which ultimately leads to malnourished children.
There's a question from Vilma from Luxembourg. He says a couple of questions, and I think it's for you, Shabnam and Nontas. The question is pre-tested before making the template, or could it be template itself? Why less missing data? Was it impossible to move to the next page if data was missing?
Can you please repeat the first question?
Okay, the first question is, were questionnaires pre-tested before making the template?
More questions?
Pre-tested.
Were the questionnaire pre-tested before making the template?
Questionnaire pre-tested. Questionnaire was pre-tested
Yes.
or not before making the template?
Yeah, with Shabna's presentation, there were 21. There was a pre-test of 21 questionnaires prior to us finalising. Those 21 questionnaires were done on paper.
The next question is, why less missing data?
Less missing data?
That's right.
Because of the way the tablet was set up, you couldn't move to the next question if you hadn't answered before. So there were lots. So actually we had 100% data for our 200. Actually, it's now at 280 interviews have been completed with 100% data completion.
Thank you.
Yeah, my question is regarding Kashmir mental healthness. The way you have taken population, the Kashmir population is very wide. So have you taken all types of people, whether they are involved in college going, school going, or they are involved in freedom movement, or military people also, because there is stressful life in military people also.
So you are asking that have we taken into consideration sections of the society? Yes, we have taken that into consideration, and we have randomly chosen the population from different districts in our study. Thank you.
So if there is no more question, we are coming to the end of this session. I think at the end we are in time. So in the summary, in overall, we are in time. So on my behalf, I congratulate all the presenters. They have done wonderful work, new think of data collection, that mobile way. And I thank MS for giving us the opportunity to be on this typical or atypical, I must say, in medical way, atypical conference, where the presenters and the audience, they are not only scientifically connected, they are also emotionally connected because of MSF. So in that way, it is atypical. And I thank myself for giving me the chance to get more involved with MSF.
There are 2 more questions from online.
We thought we have finished in time. All right.
It's for non-TAS actually. What was the cost while conducting survey, how patients were oriented about the M technology process using tablets?
For the first question of the cost, the only cost was the cost of the tablets to buy them, which was 7,000 rupees, around 90 euros each, let's say. For the development and the rest, there was no cost. It was done in-house, and the whole support was in-house. So that's it, basically. Okay.
This question from the Siddesh from Mumbai office, OCB office.
Okay, thank you very much, the presenters and the chair, for your time and for your presentation. Okay, we have lunch now, and I would like to remind you that during lunch there is also now live streaming from the UK session. So in London they are starting Scientific Day because of the time difference, and they are starting with the session called New Approaches to Treatment and Diagnosis in HIV-TB. And we are going to live stream that session during your lunch now here on these 2 screens. So you are very welcome. When you have lunch outside, it's possible to with your plate to see the live stream. Okay. You can also, by the way, about that live streaming, and you can do that by Ask Kritika, the lady in, can I say orange or what, I don't know the color, but you can ask via her. You can ask questions about in the UK. You're very welcome. And then last but not least, again, I mention it again, because a lot of people put a lot of effort in the poster presentations outside. So also take your time to look at these poster presentations. And then the lunch ends, or basically I should say it restarts again with session number 3 at 2:45. So please be here and be to continue today with us. Thank you very much.
Yeah, thanks. So Chris, we ideally really want to get at least a couple of my questions a session, even if it means maybe working on this or pass on comments. Yeah, thank you. I'm not security.
Can I take their seats? If you can quieten down in the auditorium, we'll start. There will still be people trickling in, and for those who've arrived on time, if you give them the dirty stare, that would be great. If you could also shuffle into the middle of the room so that people who arrive a little bit later can join us. We're going to start on time because our online audience is patiently waiting for us. So good morning to you here and good afternoon to those watching in India and elsewhere. I don't know about you, but I got to start my day watching online some presentations from India, an excellent session chaired by my colleague Rohit Sarun, and starting the day dressed in my pyjamas about cutaneous leishmaniasis, the problems of adolescents with So my favourite topic, Orientia Tsutsugumushi, something that we don't talk about enough. And what we got to hear about is looking at research and the questions that are most troubling our clinicians with our patients and our programs. We get access to not just doxycycline, which is a very cheap drug, but intravenous doxycycline for those who have severe scrub typhus. How do we think about a national program for cutaneous leishmaniasis with actual free access? And how do we think about, with the patients who are actually coming to our clinics, such as adolescents in the Myanmar clinic, getting treatment for HIV, up at the clinic, but their rates of viral detection were actually far higher than adults. So it's not just do they turn up to clinic, but how do we give good care? And not to neglect a fantastic talk also from a non-MSF speaker talking about active case finding in TB, and something that really there's a lot of evidence about that we should be doing it, but we really neglected, and I urge you to watch that talk later on, which will be available online. I'm going to give a few housekeeping notes. So our colleagues in India set the standard to time. And that's my job today, is to try and keep us to time. That's going to be a difficult task because we have fantastic presentations lined up. And we're also going to have questions from you and the interaction with the panelists and the speakers afterwards, but also with our online audience who will be given some preference for asking questions as well. So for those of you who are Twitter freaks, feel free to follow the feed #MSFSci online, because some of the most interesting discussion is actually happening around the world, where last year we were watched in 100 countries at over 2,000 different computer sites. So there is a network of people interested in the topics that we're talking about today. I have to say this, but just in case there is a fire or an emergency, for those in the auditorium, there are some exits up the back signed and also down the front, and you're to make your way through the front of the auditorium and assemble in Cavendish. If you need during the day, there are toilets downstairs through the auditorium, and there's going to be lots of topics to discuss. Don't get stuck in the auditorium, because you'll miss the exciting talks during the day. So make sure you're back here on time, because we will just keep starting and moving along. I'd like to also just remind you that it's fine to use your mobile phones and tablet devices for the online information following, but please can you turn your phones to silent so we don't hear you getting all your messages from your email all day. Thank you. It's now my great pleasure to introduce my boss, director from the UK office, Vicky Hawkins, who has worked with MSF for many years and most recently was based for 3 years. Thank you, Vicky.
Thanks, Phil. So I'm very happy to be the one to welcome you here today for what is the 12th day and my as the General Director of MSF in the UK. So welcome to those that are joining online. Yes, for yesterday we had over 2,200 people join in over 90 countries, and I know that we're expecting about the same today. And welcome to those of you here in the audience at the Royal Society of Medicine. It is, of course, rather a momentous day here in the UK, and not only because of a rather decisive and unexpected election result, which had me frantically changing my speaking notes this morning, but because it is the Scientific Day. And in particular, I want to acknowledge to this year's format. On that note, I want to extend a particular welcome to our colleagues in Delhi. So they have been scientific daying since 5:45 this morning, discussing some really fascinating topics, as we just heard from Phil. They'll be joining us for the HIV-TB panel first thing this morning, and we will be joining them for their leishmaniasis panel at lunchtime today. So I hope as many of you as possible will take time out from the delivery provided here at the RSM to participate in that Delhi-based session. They've been discussing research from Myanmar to Pakistan, and it's very exciting to be hosting today over 2 locations and using this as an opportunity to connect with the Indian community. I want particular thanks to those that have been working on the technology that enables us to join up with Delhi today. For those of us that work inside MSF, we all know that the technology is not on our side, but today it definitely feels like it's working with us, so that's absolutely great. Yesterday, we had a fascinating on innovation in humanitarian assistance. To name just a few of the presentations, we heard about mapping of factories in the slums of Dhaka, from which patients come to MSF clinics suffering the toxic after effects of their day job. I'm sure people in this room that feel they have quite stressful day jobs, but I don't think there's many of us that can literally say that we are poisoned by them. We heard about paradigm shifts in the application of data, in boreholes, in non-communicable diseases, and in tablet technology. And having just returned from Beirut, where I was meeting with our regional heads of missions, I was particularly galvanized by those technologies that allow us to remotely work with national medics that are working tirelessly in exhausting conditions, the effects of a 4-year. I, of course, am talking about Syria, the biggest humanitarian crisis of our time. While I was there, I was reminded of last year's keynote speaker, Jennifer Leaning from Harvard University. She confronted us with our inability to reach those people that are stuck in the most dangerous and violent conflicts of our age. She exhorted us to change in order to be able to reach them better. The innovation and technology that we heard today can help us to do just that. Our keynote speaker today provided us with similar support. 2014 has been dominated for many of us by the Ebola outbreak. 26,000 people infected, 11,000 people died, 14 of which were MSF's own staff. For MSF, it was our largest ever Ebola, but it was not enough. Our regular tools failed us in the face of an outbreak of that magnitude. We needed new tools. We needed rapid diagnostic tests, we needed treatment, but above all, we needed vaccines. We have to acknowledge that the efforts to produce these were accelerated through an almost unprecedented coalition of academics, science, business, and government, but it was not fast enough. We need a total change to the research and development system. We need a research and development system that provides outcomes for a global public good, one that is adapted to patients, healthcare workers, and governments, and that produces accessible and affordable outcomes. This is a vision that I know MSF shares with our keynote speaker of today, Jeremy Farrar from the Wellcome Trust. But before Jeremy to help us deconstruct and the global architecture for R&D, we have many other interesting topics to cover and many other insightful speakers to learn from. They will be introducing us to smaller scale research, but research that is no less impactful on the daily lives of our patients. So without further ado, I would like to the first chair for the day, Katerina Kranzer from the LSHTM, who will be leading the panel on HIV and TB.
Thank you very much. I'm very happy to have been invited to chair this session. I have worked in HIV and TB in South Africa and in Malawi, and I'm very happy that we start off with a TB topic, and then we are going into very special populations within the HIV field. So I would like to welcome Esther Casas, a medical doctor, worked for MSF for a long time, to lead us through the 9-month short course MDR-TB treatments.
Good morning to everybody, and good
Everybody online? Yeah, well, this morning I'm going to you the interim results of these two prospective studies that are looking at implementation of short course to treat multi-drug resistant TB in two settings in Swaziland and Uzbekistan. So why is this relevant? If today any of you is diagnosed with multi-drug resistant TB, your physician will give you a cocktail of drugs for at least 20 months. And amongst these, 8 of these one are going to be on injectables. So we had results a couple of years ago from Bangladesh challenging that and letting us know that actually it might be possible to treat multi-drug resistant TB for a shorter duration with also a cocktail of drugs, shortening the intensive phase with injectables, and with still the same drugs that we are classically using, first and second line drugs. These people, they showed from an observational cohort analysis that after 9 months of treatment, the success rate was 88%. So MSF chose to look at that a bit more in depth and to increase the evidence in specific populations in settings where there is high prevalence rate of second-line drug resistance and in settings where the HIV prevalence is also very high. So we go to Uzbekistan, where MSF is working since 2003, supporting comprehensive TB care in Karakal, Pakistan, and where the rates of MDR-TB prevalence, I'm not going to go through, but you can see that they are quite high, quite impressive. And in Swaziland, we are working there since 2010. Swaziland is a small country bordering Mozambique and South Africa, has also the highest HIV prevalence rates in the world, and not only that, the highest TB incident rates in the world as well. And not only that, more than 80% of the cases that we are going to see with TB are HIV co-infected. So we are going to look how we can improve the treatment for these patients with multi-drug resistant TB. Both the studies, they share the same objective. We aim to describe effectiveness and safety following treatment completion of this regimen in patients with MDR-TB with and without HIV co-infection. Any patient that is diagnosed with MDR-TB and that consented is included in the study. If patients they had any contraindications to the drugs, XDR-TB or other resistant patterns, severe renal insufficiency, abnormalities in the electrocardiogram, or in the case of Uzbekistan, additional exposure or previous exposure to second-line drugs were studied. So in summary, these are two independent prospective single-arm cohort studies. So Uzbekistan is aiming at including 147 patients in 3 sites. Swaziland is looking at including 120 HIV co-infected patients in 2 sites. The study in Uzbekistan started in September 2013, the study in Swaziland in January 2014. They both got approval from the ERBs in country and in MSF, and they are both working with independent drug safety monitoring boards. The time of the analysis, the moment of the analysis, December 2014, we see that in Uzbekistan we are 119 patients. Of them, 14 withdrawn a posteriori from the study. In Swaziland, 61 were enrolled in the study, 4 of them withdrawn later on. Why we had to withdraw patients from the study? Mostly because they showed different patterns of resistance from the criteria. So we saw some patients that had confirmed drug-sensitive TB, patients with polydrug-resistant TB, patients that showed additional second-line drug resistance with XDR-TB or extreme drug-resistant TB, and in Swaziland, 1 patient withdrew consent. We have a look quickly at the baseline demographic data. I put them together just for the sake of the presentation. We do not aim to compare results. In Uzbekistan, out of the 105 patients, we can see 50% male, and the median age was 30 years old. In Swaziland, out of the 57 patients enrolled at that moment, 40% were male, 35 years old. The BMI, body mass index median, was around 20 in both cases. To highlight, 3 out of 4 patients in the Swaziland cohort were HIV co-infected. To also note that amongst the registration group, more than 70% of the cases in both cohorts were new cases. And having a look at the closer look at the HIV subgroup, we can see basically that the baseline demographic data is the same in the HIV subgroup than in the overall group in Swaziland. And looking at the interim outcomes at the end of 2014, in Uzbekistan, there were still on treatment 66 patients. Out of them, 35 were still on intensive phase, that means on injectables. 24 patients had documented successful outcomes, 2 died, 3 patients failed, and 10 patients were documented loss to follow-up. In Swaziland, out of the 57 patients enrolled, 39 at the moment of the analysis were still on treatment, 21 of them on intensive phase, 10 patients were cured, 6 died, 2 failed. And again, having a look closely at the HIV subgroup analysis, revealed to us is that all the patients that died in Swaziland were HIV-related deaths. So what patients died? In Swaziland, as I said, we had HIV-TB-related deaths, advanced HIV-TB with a case suspected of cryptococcal meningitis, encephalopathy related to late stage of HIV/AIDS, 2 cases related to advanced MDR-TB, and with liver failure. In Uzbekistan, one of related to the MDR-TB process, another one not. Let's have a look at the culture conversion. And we see that in all the groups in Uzbekistan and in including the HIV subgroup cohort, at 4 months, we have more than 90% of the patients converting culture. A closer look at the analysis at month 2 in Uzbekistan, we saw that already 73% of the patients had culture converted, as I said, at month 2. In terms of toxicity, we still see a number of side events. The most of them in Uzbekistan are mild grade 1, mostly nausea and vomiting and headache and dizziness. And in Swaziland, also a number of adverse events, the most of them mild grade 1, mostly also nausea and vomiting and arthralgias and mild that at 2 and 4 weeks, the median increase of this corrected QT was 4 weeks, the median increase of this corrected QT was less than 20 milliseconds in all cases, in both programs, I mean, and then there is a number of patients that had an increase of more than 60 milliseconds, and in one case in Swaziland, we documented an absolute QTC of more than 500 milliseconds at 2 weeks. This patient had also documented electrolyte abnormalities corrected, and he could resume treatment. So in conclusion, we know that we need, I'm not saying anything new probably, we need shorter, safer, and more tolerable regimens to treat multidrug resistant TB. These outcomes indicate that there is early culture conversion in this regimen. As expected, we have some failures. We have a challenge in terms of loss to follow-up and AIDS-related deaths, indicating that there are components of the program that we have to improve and to work on further. There is still, this is not yet a regimen that is toxic-free. And think about the next steps. Obviously, when it comes to to look at the final outcomes of this regimen settings, we want to look at relapse rates as part of the effectiveness assessment. And when it comes to TB, it seems that there is some light at the end of the tunnel with new drugs becoming available, and we have the MSF commitment to continue on the fight against tuberculosis. And this is actually great news, and I have the pleasure to show you a couple of very nice initiatives. I can only give hints, but this is related to randomized trialing several regimens that combine new drugs. With all that, I would just like to thank the teams in the field, the Ministries of Health, mainly, and to you all for your attention. Thank you very much.
Thank you very much for keeping to time. We are going to take a couple of questions. They are all going to be technical questions because there is a discussion at the end. So if anybody wants any questions of clarifications, then Nathan.
Is it on? Yeah. Hi, thanks Esther. Nathan from WHO. Did you have any information on antiretroviral therapy status or immune status of the patients?
For the
in Swaziland?
For the HIV cohort in Swaziland, it's included in the protocol also, and in the management of treatment, all the patients, they are either on antiretrovirals or they start soon after treatment, antiretroviral treatment, and we are looking also at response of the treatment baseline if they have already been there with viral loads and so on. This analysis I cannot yet share.
Thank you. Any other questions? Thank you very much. Our next speaker is going to be Katie Whitehouse. She is working for the Access campaign to look at a very difficult topic, which is essentially pediatric HIV diagnosis in a non-PMTCT setting. So looking at how to improve and where to best diagnose patients.
Thanks very much for having me. It's a pleasure to be here. So to give you some context on why we conducted this systematic review, we know that globally the number of children living with under the age of 15 years is approximately 3.2 million, 90% in sub-Saharan Africa, and reducing mortality of infants infected at or around birth is achieved with early treatment initiation. So in order to initiate diagnosis, and we know that there is an increase in the number of tests that are being conducted on children, but these are still insufficient numbers. There are ambitious global targets and focus on efficiencies in order to achieve a bridging of this gap, and new strategies are needed in order to So the review was conducted to inform and update the WHO's global guidance on identifying these strategies and finding HIV-positive children. So we formulated the following research question: and middle-income countries, does HIV screening in 4 key contexts enable a higher yield of HIV diagnosis when compared with screening in prevention of mother-to-child transmission settings? So those 4 key contexts are paediatric inpatient, paediatric outpatient, nutrition centres, and essential programs for immunisation. So our methods, we limited to 2004 to 2014 studies published in English or in French in the 4 key contexts mentioned, and we looked at under 12 HIV prevalence. We included either serological or molecular testing and either universal or triggered screening protocols, and did an HIV positivity of those tested included in the studies. We excluded anything outside of those 4 key contexts. We excluded diagnostic testing, and we excluded studies where testing criteria was not stated. We also didn't include studies that had highly specialised or specific out or inpatient care, so for example TB. We searched the databases using a highly sensitive search strategy, extracted titles in duplicate and reviewed everything in duplicate, and had a third-party tiebreaker. And we age disaggregated our outcomes and pooled the data using random effects meta-analysis. So a review, we found 2,890 studies after deduplication of the main databases, identified 38 studies with HIV prevalence data, and of those 25 with specific under 5 HIV prevalence. And those are the results that I'm going to present today. So an overview, as I said, 25 with primary outcomes, so that's under 5 HIV diagnosis. with 15 reporting secondary outcomes. So we also extracted data around acceptance rates by caregivers for HIV testing. We looked at retention in care, and we also looked at feasibility or acceptability by healthcare workers. I'm not secondary results today, but you can tell me about them. Geographically, 23 studies were in sub-Saharan Africa, one was from India, and one from Papua New Guinea. And the majority of studies were in pediatric inpatient settings, with 16 studies reporting those outcomes. So to have a look at our results, there's a fair degree of heterogeneity in these results. But what we can see when we look at pediatric inpatient settings, which is the top section of this forest plot, we can see that the pool proportion was 25.3% for HIV positivity in under 5. If we look at nutrition settings, which is the second section down, that reduces to about 13.1%. And in EPI settings, again, reduces to 4.9%, with outpatients the lowest HIV positivity rate at 1.62%. Say is that these results offer us a certain amount of direction whereby to investigate new to try and find HIV positivity in pediatric patients. And to give you some context for why this is relevant to MSF, we did a very quick extraction of one operational centre, so one section's offering of HIV testing to paediatrics in projects where there's an HIV focus within the country. So to have a look at those results, again, this is just one section. And many thanks to Helen for helping us out and pulling this data together for us. We can see that broadly, HIV testing for paediatrics is available, but primarily if symptomatic. And where it is available, there are a number of barriers that healthcare workers noted as to why it's difficult to offer HIV testing. And those include availability of trained counsellors, consent for testing, and the confidence to provide and to disclose results. So it's available in EPI settings. That's worthy of note. In terms of a breakdown as to the number of projects, as compared where HIV prevalence is greater than 1% within the country that the projects are operating, we see that the number of projects actually offering testing is substantially different from that number. So if we look at inpatient departments, we see projects are operating in countries with a prevalence greater than 1%, but only 4 are actually offering HIV testing to those paediatric patients. So then work done as to how we improve the situation within MSF itself. And so some of the recommendations that we've pulled together, we need a bigger emphasis on postpartum retesting of mothers in EPI contexts, which would be much easier than actually testing the paediatric patients. There's an ongoing lobby. The HIV working group and the paediatric working group are both proponents within MSF to integrate HIV testing into paediatric projects. And there is guideline training and support materials available, which have also been no excuses. So to have a look back at the review, I just want to note a couple of main of our systematic research. The studies were limited by language, so that may have an indicator for other studies that are available, not published in English or French. We limited by date and to lower and middle income country contexts. The primarily available is only really for under 5s. It's very difficult for us to have disaggregated the data for the 5 to 12-year-olds, and that will be interesting, and that's something that we're continuing to try and work on. and the data is only really from sub-Saharan Africa and in inpatient settings. Is provided comparable background prevalence data, so they're either inadequate or indirectly comparable. MTCT coverage changes have occurred since some of the studies were published. So to look briefly at our recommendations, we have one main policy recommendation, which is that testing paediatric populations in some key contexts may well offer high-yield opportunities to identify HIV-infected children, and notably paediatric inpatient settings would appear to be the most pragmatic approach. And our research recommendation is that we definitely need more studies from other settings, including nutrition, outpatient and EPI. With only 3 studies in systematic review, it's quite difficult to really draw strong conclusions on that. And we definitely need studies of sub-Saharan African contexts. And in order to address the barriers that were raised, notably within the MSF projects that I mentioned, whilst HIV testing is already recommended, the uptake is low, and we need to consider how to address training needs, what to do about the availability of testing and counselling, and the legal barriers, so age of consent to test, must all be addressed in order to improve the situation. So many thanks to the brilliant collaborators and colleagues that I've had the pleasure to work with on this. Thank you very much.
Thank you very much for an excellent talk and for a very important, to cover a very important topic. Again, it's just technical questions we are going to take, and then hopefully we will touch on that subject again in the discussion round. Any questions?
Thanks, Katie. That's a very interesting talk. I mean, as you say, the recommendation for testing kids has been around for a long time now, and I guess I was very surprised to see how low the rates of testing are. Has somebody looked at what the actual reasons are? Do we have any? I know there are possible theories, but has someone actually collected reasons for why we're not testing?
I'm not actually sure, but there are a few people in the front row who probably have an idea as to why. I don't know if Helen, you want to.
I think
you might need to.
This is, as you know, Daniel, a long debate within MSF. Some sections are better at it than others. Still, the question comes back to: are we going to test? Who's going to treat them? Believe it or not, still in 2015, that discussion goes on. So it's something we're still really pushing the nutrition projects and paediatric projects towards, that it should just be a normal part of the care we're providing, but we're not quite there yet.
Thank you. Any other questions? So there are questions from the online audience.
I have a question from MSF India, who are asking, is there a reason why we're not testing at present qualitative research study planned?
Sorry, I missed that.
Sorry. This is a question from MSF India, and they're asking, is there a reason why we're not testing at present, and is there a qualitative research study that's been planned?
I've got no plans for qualitative analysis as yet, but reasons for not testing, I think, are probably covered mostly by the challenges and the barriers. It's very difficult to age of consent issues. I think a number of us feel quite uncomfortable with providing testing for paediatrics when either the paediatric is a little bit older and there's that blurred line between sort of a minor and an adult. I think also disclosure is another aspect within age of consent. An HIV positive result when the parent or the caregiver hasn't actually initiated the test is probably problematic. And then in terms of availability of staff, the MSF projects all noted that it's very difficult to have staff available, ready to give trained counselling. And then within EPI contexts, it's quite a quick turnaround of paediatrics. So you're seeing them very briefly. So actually we probably need to look at a different strategy, i.e. testing mothers rather than, or caregivers rather than the paediatric themselves.
If I can just add, and so it's not an MSF project, but it's from Zimbabwe. So I have been working with Rashida Ferrand on adolescent testing. And we actually had 6 primary care clinics where we tested, where we had provider-initiated testing. And only 70% of the children got the test offered by the healthcare providers because the healthcare providers weren't very comfortable. And we did a qualitative piece around that and asked, why are you not testing the children, even so, you know, we have trained you for. And really the main barriers were running out of test kits because PMTCT is prioritized. The second bit was not really being sure if a guardian who is not the mother or the father is going to be allowed to consent, age of consent, and how to actually do the test in the context of a young person. And following that, we did a big stakeholder and training campaign, and that brought the offer up to 95%. So, I mean, it is achievable, but you need to bring your healthcare providers on board. And I think we have to think about moving from something which we call provider-initiated testing. The provider still says, what is the risk? I'm going to do it on a symptom basis because I'm more comfortable with that. That patient probably has HIV and that one doesn't, to a real routine opt-out testing for children. Thank you very much.
Thank you.
Speaker is Helen Bygrave, so she's going to continue with a slightly older age group, and these have already been diagnosed, and it is looking at the Kailicha project and how to deal with adolescents who are but seem to fail.
Okay, good morning, everybody. First of all, I'm not John Timer, so I'm on behalf of the Kailicha team this morning, so I guess they're watching online so they can tweet and do whatever they're doing online if I say something wrong or to add things to this presentation. So Jonathan is one of the most kind of enthusiastic paediatricians I've with or met in the last few years, and I'm sure he and I are both got not just 1 but 2 paediatric HIV presentations this morning, because an area I think that we haven't paid enough attention to in our. So I'm going to follow on from what Katie said. Why is this so important? Of the 35 million people living with HIV, 3 million of them are children less than 15. All the children less than 5, most countries have followed the WHO guidelines, so they're all eligible for ART, so they're put onto treatment straight away, and in fact a number of countries are now putting all children less than 10 on ART. But still, after kind of 15 years of kind of programming, I think there is still a real bottleneck around putting kids on treatment, and the challenge of paediatric adherence still is really, when you chat to our counsellors, it's a real challenge that they face. And what's interesting, in the last 2-3 years, as we've scaled up routine viral load in the project, started to get a feeling of how big a problem this adherence challenge is. So, what do we already know from the literature? So, from the IDEA cohorts, there's around about 20% failing by 3 years, and another South African study, even worse rates of failure, up to 38% of children. So, not great, okay? If we look at our, these are OCB cohorts, where we started to roll out routine viral load in the last couple of years, and you see similarly not great outcomes, and really quite consistently children having kind of 2 to 3 times the rates of virological failure compared with adults. So this pilot project was started in Kailicha. It's one of our oldest HIV projects within MSF. It's an urban township just outside Cape Town. And really what happened in the analysis of the viral load data, the team really started to see and flag up, 30% of our kids are failing, what are we going to do about it? So they actually set up a specific paediatric risk of treatment failure project. It's in a separate building, it's very child-friendly, it's got dedicated staff. The programme is nurse-led, but there is a doctor, a paediatrician involved. And basically they enrolled in the programme all kids from infants up to the age of 19. So basically any kid, so child or adolescent, who had a high viral load was enrolled into the programme and they received some specific adherence interventions. And that really was a combination of kind of one-on-one counselling with some, paediatric-friendly tools, and combined with, and I think this is the really important thing, it's not just about sitting for a longer period of time with a doctor, combined with peer support. So they had family clubs for the younger ones, where the caretakers also kind of brought together, and then kind of teen clubs for the older adolescents. So very much kind of learning from each other, finding out about their disease from each other. The other really important thing I think Jonathan wanted to bring out is just having the luxury of spending more time with that child. And I just want to link back with Emily's presentation yesterday. If we can employ strategies to decongest the clinics and get the stable patients kind of out of the queue, maybe our healthcare workers will be able to spend more time with the kids and also the adults that are failing and need more kind of clinical input and attention. So after getting that adherence intervention, they get a repeat viral load. If the viral load is still high, then the clinicians are deciding, do we need to switch the regimen? Or actually, if the viral loads kind of come down a bit, will we go on and do a further adherence intervention? So if we just look at kind of demographics of the kids who went into this programme. So up to the time of analysis, 133 kids had been enrolled in this project. The median age when they started their ART was 3, which is quite late, and the median age at time of enrolment in this failure programme was 10 years. Median time on ART was 4 years, and the viral load at enrolment 14,500. 4 of the kids actually, on questioning once they got into this clinic, weren't actually taking their drugs at all, but the majority failing a protease inhibitor-based regimen. In South Africa, it's really the only country in the region at the minute that is using a protease inhibitor-based first line. Although it's recommended, other countries haven't quite got there yet because of the difficulties around the formulation still. 3 children, so only 2% actually had concurrent TB at time of enrolment, but 15% did have other comorbidities, so they were sick with their failure. So ranging from nasty skin infections, tinea capitis, to pneumonias. So these kids were actually sick with their failure. And then I think some interesting stuff around the social situations. The majority, 68%, did come with their parent, but clearly what came from the team is that these kids are swapping caretakers. So they might come with the parent, but they're kind of passed pillar to post in terms of who might be giving their drugs. The other interesting thing, I think, is 71% of those caretakers were HIV positive themselves. And I'm going to get the team to look at, I'm quite interested in, are they suppressed? Is the parent taking their drug or not? But I don't have that data yet. And ignore that slide, because what we've actually looked at disclosure rates according to age. And 83% of the children more than 10 who should have been disclosed were disclosed, but that still means 1 in 5 didn't know they had HIV. Yeah? And it's when we talk about disclosure, it's does the child know they've got HIV, but it's also about disclosure within the family. And often another story that came out was often, if a lady gets a new partner, she's not then telling got HIV. Therefore, she's not telling that partner the child's also got HIV, hence the drugs stop. Disclosure is a bit of a kind of a hot topic for us. So just to also say, a colleague of mine looked at this across our projects. And again, despite the fact we've been trying to do this for 10 years, we're not doing that well. So most projects hovering around 50% of the kids who should have been disclosed to getting to that point. So if we look at suppression of these kids, having gone into this programme, having had those adherence interventions, left-hand side, kids failing on a protease inhibitor, right-hand side, kids failing on a nevirapine-based regime. 67% of the kids on a PI suppressed after around about 3 months, 53% on an NNRTI. And if we look at those kids who suppressed, the majority, 85, 87%, stayed suppressed. For those that didn't initially suppress, we're giving them a bit more time, giving them a bit more support. A further 9, so 60% went on to suppress on a PI. This side of the chart, the kids were actually switched, so they would change their regimen to a protease inhibitor, and again, a third of them went on to suppress their viral load. So overall, of the kids who'd been in the programme for, let's say, 9 months plus, and had three viral load follow-ups, 84% of them had managed to be suppressed through basically good adherence support. They also, in Kalicha, they managed to, they genotyped 34 of these children. 100% of the kids failing an NNRTI regime were resistant, kind of supporting the public health kind of principle of switching directly from NNRTI to a PI, and 43% of them resistant to the protease inhibitor. So, in conclusions, some of the points Jonathan wanted to make. The median age at starting ART was very late. We need to be better. We need to be testing those kids earlier and getting them onto treatment. Disclosure rates weren't good enough, although they were better in Kalicha than some other places. This is something we really, really need to do better in our projects. Most of the on NNRTI showed resistance, kind of as we suspected, with lower rates of resistance in those on the protease inhibitors, basically showing we need to push towards a PI-based first line. We need population that's accessible in our settings. And this was a pilot project. It was quite resource intensive, say specific HR, specific building, but I think there are some really important pieces of this implementation that we can take to other settings. So I'm going to say it again, disclosure counselling with the tools available. We need to be supporting our staff to do this better. And actually, it's not just about MSF projects. I don't see any Ministry of Health that's providing these tools, providing counsellors, somebody even to do the job. Yeah? And this is something I think at national level really needs to be addressed. Really simple, just book your kids on the same day. Yeah? Automatic kind of peer support for the caretakers, peer support for the teens on the same day that they're picking up the drugs, and preferably after school. Yeah? Can we organise that in our clinics? And also just thinking about, is a home visit possible? Because I think seeing that social situation and understanding that better is kind of a really important piece of the puzzle. And as I said before, just having the luxury of spending a bit more time with these vulnerable kids, with these vulnerable caretakers, yeah? And to do that, if we're going to put another 15 million people on treatment to add to the 15 million already on treatment, we're going to have to revisit how we're delivering the services in the clinic. Okay, so thank you very much. Thank you very much to the Kalicha team, the patients there, and yeah, to you for all listening.
Thank you very much again. Anybody, any technical questions? Otherwise, we will move on swiftly and leave it to the discussion round. Okay, thank you very much, Helen. Sorry.
Oh, sorry. Thank you very much. I think it was an excellent presentation and goes back to all the great work the Kalicha project has been doing. It links to both of your presentations from the previous speaker as well. Helen, can you tell a little bit more what this project is also doing with regard to the identification of the children? Because your presentation, of course, is very focused on the children under care.
Yeah.
What are the strategies in the project for creating access for the ones not yet being diagnosed?
Identified. It's a really good question. I really think it's an area we haven't worked hard on, because I think the issue of testing kids where they're coming to EPI, to the under 5 clinic, it's still not a routine thing that's in those caretakers' minds. We see time and time again kids that are coming with diarrhea, and they're still not getting a test. So I think now we're starting to have a bigger push trying to normalise testing within the EPI, and trying again to work around some of the barriers
around healthcare workers, the issue of the issue of healthcare workers, the best interest of the child principle. There's a lot of kind of quasi-legal issues, that we have to take on board with the Ministries of Health, at country level, because healthcare workers often just don't feel comfortable to test a child without that guardian consent, and it's a very fine line for them. I don't blame them, but there are kind of some training issues, but there's also some kind of political issues around it.
Thank you very much. I just ask Shona to come up to for the next talk, and in the meantime, can I ask everybody who is sitting in the aisles to just shuffle in and move in? There are lots of empty chairs around, so if you can just all squeeze in a bit more. So Shona is going. She just told me she came back from Swaziland actually yesterday. She is going to present some quality research on viral load and how viral load could possibly improve or potentially less improve the feeling of patients towards their treatment, and do they actually really understand the results of a viral load. Thank you very much.
Thank you. Good morning, everyone. Sanibonani Gulaba Bugalago Gangwane, which should mean hello to everyone watching in Swaziland as well. As was just mentioned, I'm going to present a qualitative study that was conducted on viral load monitoring in Swaziland. How do HIV-positive patients on antiretroviral therapy interpret and understand their results? So firstly, to introduce the study setting, Swaziland is reported as having the highest HIV prevalence rate in the world, with 31% of those aged 15 to 49 years being HIV positive. MSF, in collaboration with the Ministry of Health, have been providing decentralized HIV and TB care in the Shiselweni region, which is in southern Swaziland. Within this project, a viral load monitoring pilot program was started in 2012, and this is now routinely offered for all patients on ART, with additional support for adherence. So why was it decided to conduct this qualitative study? Well, while we know that viral load monitoring can help prevent treatment failure through earlier identification of adherence challenges or need for treatment regimen changes, we still don't really know how patients feel about viral load monitoring and what effect viral load monitoring has on their experiences, for example, with treatment taking. Concerns were raised within the project as to the potential disinhibitory effect of having a known undetectable viral load, i.e., could those patients engage in riskier sexual practices as a result? And there was also anecdotal information of certain patients stopping treatment early or lost to follow-up, and also retesting for HIV through interpreting their undetectable result to mean that they had cured. So therefore, we decided to do this study to describe patients' views and experiences regarding viral load monitoring. The methods that were adopted, participants were recruited from a larger quantitative viral load monitoring study sample, stratified for their viral load result in order to be able to explore a range of different experiences with different results. So therefore, there were those who were suppressed, who were initially detectable, who then resuppressed, and those who remained detectable that were included in the study. 22 interviews were conducted in total, and interview transcripts were analysed thematically using coding to identify emergent themes, patterns, and concepts that came from the participant responses. Deviant cases or discrepancies from the majority themes were also actively sought. Now to the interesting part from these interviews. Well, 4 main themes emerged around treatment literacy, support for adherence to ART, sexual practices, and patient non-compliance. And I'll now go into these in more detail. So the first key finding was on viral load monitoring and enhanced treatment literacy. And when we talk about treatment literacy, what we mean by that is patients' overall health knowledge about their treatment. So all participants found viral load monitoring to be positive, useful, and it also reassured them that they were being taken care of. Some said that they preferred it to CD4 count monitoring because it enabled them to have a direct view of what was happening with the level of the virus in their body. An undetectable viral load result brought feelings of happiness, hope, and encouragement for the future.
but on the other hand, having a result could bring fear, sadness, and confusion. Viral load monitoring provided patients with a sense of ownership and control and also over their health. And they said, it is important for me to know about my life and how I am living. Some participants still had limited understanding about viral load, and they said that they hadn't been given much information during visits to the clinics, and they really expressed a strong desire to know more. So they said that they wanted more knowledge and more information about viral load monitoring. The participants that had lower understanding confused CD4 count and viral load monitoring. The second finding was that viral load monitoring supported adherence to ART. And how was that the case? Well, viral load monitoring was said to, or the process of having your viral load monitored was said to motivate adherence to ART through patients being able to see the effects that treatment had on the level of the virus. And that was particularly for those who had had a gap in their treatment taking when their viral load had subsequently increased, so they could really see what effects that had on the viral load. And this increased their trust and belief in the treatment and therefore their motivation for continuing to take it. So you can see here one patient said, "It encourages me to hold on and to take my treatment as prescribed." The point on stress or emotional difficulties has two parts to it. Some patients had periods of time where they stopped taking their treatment as a result of going through stress or emotional problems. Some also saw stress as directly causing their viral load to increase. The third finding is around viral load monitoring and sexual practices. So I mentioned earlier that there were concerns about whether having a known undetectable viral load result could increase unprotected sexual practices. We didn't find that to be the case. Viral load monitoring was said to motivate condom use, but with an emphasis on self-protection. So these participants said that they were more motivated to use condoms because they either wanted to protect their undetectable viral load status, or those that had a higher viral load, they wanted to use condoms to try and lower their viral load. And that's linked to the health messaging within the project, whereby patients are told that it's essential for them to use condoms to avoid their viral load from increasing. The connection between ART, viral load suppression, and HIV transmission, particularly infection with resistant HIV, are still not well understood by patients. The difficulties that women face in negotiating condom use has been reported before. We've also found that women can have severe difficulties on condom use negotiation, including experiencing abuse on suggesting condoms to their partners. And you can see here that one female participant said, "At times you would say, 'Here is a condom,' and he refuses to use them, and then you'd be beaten. I have experienced such problems." So that really highlights the complexity of the reality. The last key finding is all about the interaction between health practitioners and patients and the effects that that has. Practitioners are said to assume that patients have done something wrong to cause their viral load to increase. For example, not adhering to treatment, unprotected sex. Participants describe feeling blamed, abused, and judged by practitioners. This adds to their confusion and upset, receiving a detectable result. And it also makes it difficult for them to come forwards with potential challenges that they're facing because they're afraid of being reprimanded by health staff. This therefore undermines a supportive practitioner-patient relationship. In conclusion, this study found that viral load monitoring has a positive impact on adherence to ART, potentially also on treatment outcomes. And what can we take away from this? Well, there's a real need for increased patient information and knowledge about viral load monitoring to maximise the potential benefits that it can bring, for example, for treatment literacy and support for adherence to ART. We also need careful training of health practitioners to avoid viral load monitoring being used to reinforce those hierarchical practitioner-patient relationships. And we also need to consider the messaging around viral load monitoring that is disseminated, for example, on viral load monitoring and sexual practices. So I'd like to thank all of the patients and the staff members within the Schüssel We Need project who participated and contributed to this study, and also thanks to all of you for listening.
Thank you very much. If I can ask all of the speakers to come up here to start the panel. We can start off with some questions directed to Shona, if there are any kind of follow-up questions, and otherwise it's open for discussion and questions, please. There's one question here, and then we are going to have an online question, so if you could start here. And could you please introduce yourself and with name and the organization you're working for, and who at the panel the question is directed to?
My name's Kiralee de Polnay. I worked for the Institute of Tropical Medicine in Antwerp. My question's for Helen and Katie, really, and it's two parts. The first is the data about the level of HIV testing in MSF projects. Is that just that MSF are doing, or does that include MOH testing within? It's the both.
It's in the sites where MSF is. We're very much integrated in MOH settings, so we're working in primary healthcare centres that are MOH.
Yeah. So that's my question as well, the second part of my question. When I was working in a paediatric project with MSF in Sierra Leone, for example, on my nutrition ward, I was very pleased that I could test all the children, but so often MOH weren't there. And we were we were encouraged by operations that it should be MOH testing, and when then our lab had to do it, it was quite overwhelming for the mental health team to do the counselling. And so then, question B, in terms of, do you think it's worth just MSF trying to do all the testing themselves, or the reality is often if MOH aren't there, they're just not there. But then what can we do to increase testing?
I mean, I think obviously every project's different in terms of how the project's working, MSF staff versus MOH staff. I think our point is where MSF is working, in a paediatric setting, children should have access to HIV testing and TB diagnosis. And you were very lucky, I'd say, in your Sierra Leone to do it. But the reality is, that that's not happening in many of the places we're working. And I know with our paediatric working group colleagues, I mean, there's a great degree of frustration that isn't still happening. I think, MOH has limitations. We have limitations. You have to work together to see whether that's us putting in one or two extra dedicated people to do that, so be it. But to look at it in the context that there's a lot of kids who are malnourished, who are not getting better because they've got HIV or TB.
If you can take the online question, please.
Hello. Sorry, I have a question. I have two questions, if that's all right. The first one is from the deputy editor of the Lancet Infectious Diseases, who asks, MDR-TB treatment could involve new drugs, but is this likely to be affordable, and what are the cost implications?
And I guess that the question goes to me. Yeah, it's true. I think that it's one of the big challenges in the TB world and in the HIV world. Drugs are expensive. And I think that as MSF, we do have the responsibility to fight and to lobby and to show that these drugs are actually needed. And then we can bring down, have the example of in the HIV world and the antiretrovirals, that we can bring down prices. I think that this is an example that speaks on its own.
And my second question is from MSF India. They're asking the panel, where do MSF see HIV in the world in the next 5 to 10 years? And what important steps will MSF take to reduce or lessen the effect of HIV in the world again?
Helen, I think you're going to take that question.
Thank you so much. Okay, so the message is we're not done. Okay, so there's another, we've got, well, I don't know, Nathan will tell us, but around about 15 million on treatment. We're aiming basically with the 90 targets to get another probably 15 million people on treatment. So, I mean, it's been one of the most successful public health interventions of the last decade, but I think there's a lot more. I think MSF still does have a role in that. I think people still look to MSF, I think, in terms of our programmatic interventions, simplification interventions still. So my message is we're not quite done yet.
Another question, please.
Bertie Squire from the School of Tropical Medicine. I was interested in the results of the MDR short course regimen implementation, but struck by the figures from Uzbekistan, which indicated that I think you had 299 MDR cases, but only 199 were actually enrolled. Could you say a little bit about those who weren't enrolled and the reasons? Because I suspect that's all to do with second-line drug exposure. And as a consequence, can you say a little bit more about what you think that means for those patients in terms of their access to medicines and their costs incurred in adhering to what must be much longer regimens?
Yeah, thank you very much for the question, very relevant. I think that for the particular details on Uzbekistan, I actually would like to get Philippe Ducros responding to the question because these are two independent studies. He's the principal investigator. Is that okay?
Very cheeky, Esther. So, excellent questions. I think there's a couple of things we've learned from doing this study. One is when we started the study, we weren't sure whether this would work for all patients, and we were particularly concerned with the initial results from the Bangladesh paper around failures in patients with ofloxacin resistance. Given high rates of second-line drug use in Uzbekistan and in the region, we had quite restrictive exclusion criteria, and therefore I think we were a bit too limited and cautious. I think the second thing we learnt is when we started and when we counselled patients for consent to go into this study or to take the regular international recognised treatment, there was many patients who actually said, well, actually I don't want an experimental regimen. I want to at least take something that I know that works. And people who chose that, it changed over time. But I think that shows that we at least addressed an issue that comes up in many trials around proper informed consent, and that's something we're still learning how to do well, to counsel about the risks for new treatments. And I think the other thing to say is that, while this regimen, the interim results look promising, I don't think this is the answer for all MDR-TB. There's still a lot of cases where this is not going to work, and we also need to be looking for the new drugs and other solutions. For the patient costs, that's a long discussion, and maybe I can throw to Shona, who's done some separate research on adherence in MDR in Uzbekistan.
Shona, do you want to comment on that?
On the adherence challenges so there was a qualitative study that was conducted in Uzbekistan last year looking specifically on adherence to MDR-TB treatment. And that found that while we know that side effects can be a challenge for patients and that all patients on MDR-TB treatment experience side effects, there are a lot of techniques that can be taken that can really help mitigate the sort of extent to which people feel those side effects. And that's things like looking at, rather than focusing on the negative effects of treatment on the body, by using visualization, distractions from treatment, that patients actually felt that they less. I'm trying to remember now that I'm getting my head out of Swaziland. There's a poster, so catch me in the break and we can talk more about it.
Maybe if I could add, I think that what really pays off, and also learning from the HIV experience, is the time that you invest with the patients and the psychosocial support team, and how strong they are and how well they are addressing and working with the individual patient on making them understand the disease and what it needs to recover.
Thank you very much. Any other questions? There is one question behind here, and then if you can just pass the microphone on to the lady with the
it's
yellow.
Doris from MSF Austria Evaluation Unit. I have a question to Shona. I wanted to know what you're planning to do with the problem you were mentioning with the healthcare providers in the relationship with their patients, because patients were complaining that, they were beaten or abused, kind of verbally abused in the
not beaten
encounter.
up.
Yes, and you said you are planning to do some training, but I think it's not only about training, but maybe also more on motivation and the question, how do we welcome our patients? That they feel comfortable in
No, yeah, completely. Thanks for raising that point. And this is an ongoing challenge that we face because we know that the challenge of practitioner-patient relationships can have a big impact on how much patients feel able to come forwards and discuss their issues and so on and so forth. But we have done training on practitioners in the past. Also, I was just doing a study on linkage to HIV care in Swaziland, and we found too with that study that things like losing the form that patients were supposed to bring with them to the clinic could prevent patients from feeling able to link because they were afraid that they'd be told off for losing their form. And that really highlights actually the extent of the impact that can have on patients' ability to access care. So I think that's something we need to look at more closely and to think not only just saying that we need to train practitioners, but actually what exactly can we do to improve that relationship, because it has a big impact on patients. Yeah.
Next question. Yeah. Hi, thank you. I'm Isabella Panunzi, vaccination referent from OCB. And my question goes to Katie, because I was very happy to see in the same slide the two words API, because usually we don't integrate the two things in our project. And then actually with Helen, we did a short survey in OCB HIV projects. Our question was, do we vaccinate HIV positive children? And the answer was no. We don't look at it at all. So my question is, looking at your result, have your thought gone a bit further in the sense, do you also want to look about if we vaccinate the HIV positive children, the PMTCT program, so not just to test about HIV, also because we work in contexts where we have a very low API uptake. It's not just the HIV testing uptake that is low. So I would like to know if, looking at your result, what you say, the next step is to try to integrate more and then to go more into the API program to test children, also to think about the other part of it, so to vaccinate HIV positive children.
I don't think I can actually comment on vaccinating the children because really what we were just looking at where the prevalence results are. But certainly we recommend that testing in EPI settings would be a good move. The results were slightly around the background prevalence data, so it's a reasonable yield. But in terms of vaccinating, I don't.
Yeah, I mean, yes, Isabel, we know it's kind of chicken and egg. Of course, we want the HIV positive kids or the exposed babies coming to the PMTCT clinics. We want our clinicians to be aware, have they also completed EPI? It's an essential bit of the exposed baby follow-up. So I think the message is, yeah, we're trying to push. But I think what Katie really nicely demonstrated, that EPI is a captive audience for us to try and scale up testing. And in PMCT, what we know some women who tested negative antenatally will seroconvert. So we want to catch them by testing them when they bring their kids for EPI. The second thing is 10% of the women we start on antiretrovirals antenatally don't ever come back because the healthcare workers have shouted at them. That's a fact. And healthcare workers say that about themselves. It's hysterical. They say, our bad attitudes actually are one of the reasons they don't come back when you do these exercises with them. So by trying to catch the ones who were lost to follow-up, EPI also is potentially a catch to recatch the women who didn't come back, because they at least will bring their kids for a vaccination, despite the fact they won't come back to get their ARVs because the healthcare worker shouted at them for whatever reason.
In fact, my question came from the answer Katie gave before, saying that it's very difficult when we want to work with API and then this is the infrastructure and everything. So if we start working with that, it's an opportunity then to look also at the other side. It's just this. Thank you.
I think with regards to catchment of children in particular, and especially with the problem of if you test a child positive, then you inadvertently kind of have tested the mother positive. I think what we have absolutely underused and what Kenya has done very nicely is to actually do family-centered approaches. So to go and use the ART, the patient ART, as the index case, almost as we do for TB, where we say, okay, there is going to be clustering of HIV in this family. And we should not forget to invite the children back to say, have these children actually been tested, no matter how old they are? And it is so often the case that actually somebody in the family is on treatment and still the child is undiagnosed. Any further questions? There is a question here, and then we are going to take the question in the back, please. You can just raise your hand so that the people with the microphone know where to put them. Yes, please.
My question's for Helen. I was just intrigued about what to do with the children who are on NRTI regimens, because you seem to show, if I remember rightly, that 57% of them you could suppress at 3 months by doing enhanced adherence counselling. But perhaps the downside is that when you did genotyping, they all had resistance, and therefore in the longer term you might end up with more resistance because you've only theoretically got 2 active drugs. So on a policy level, what do you think about a good idea to do enhanced adherence counselling in children on RTI regimens, or should you just accept that you're taking a risk and switch them straight over?
Yeah, that's a big debate where kids, to be honest with you, it's the adults as well. Anybody failing an NRTI, do we give them the chance to suppress? And I think there have been a couple of studies looking at the people who suppressed, and indeed, many of them are going to have an NRTI resistance. I think we're taking a very public health approach to this. When we talk about suppression, we're talking about to less than 1,000 anyway. So there's a compromise within that we're taking. So yeah, I think for me, Daniel, I think it's a very public health approach to this. Should we be talking about genotyping all the first-line failures as well, potentially, given a cheaper? That's maybe a route to go. But I think the public approach algorithm we have at the minute, I think is feasible to put in place, and I think probably does a good majority.
Thank you. Yes, please.
Okay. Hi, I'm Megan, MSF Canada. This is a question for the entire panel. In the last month, HIV has been approved for over-the-counter purchase in the UK. Do you think this model of at-home testing could be applied in the developing world?
So it's basically, I'm just going to repeat the question because I think it wasn't that clearly heard in front. So it's basically about oral self-testing, which has been approved or is FDA approved anyway and has been approved for the UK. An option, is that a possibility for the settings you're working in? I don't know who wants to take this question. Helen?
Definitely. It's already being piloted in a number of the countries that we're working. Different kind of models of using it. Some places are using it at facility level just to try and scale up the access to PITC in terms of human resources. A number of countries using it at community level, often through community health workers. I think the really important thing that's come up is the issue of linkage. Yeah, what information is given with that test kit in terms of what do I do if I do test positive. But definitely, community-based testing, so going to people's homes to test, is something that many countries are looking at and rolling out. And self-testing definitely also is coming on the agenda. Yeah.
And if I can just add on to that, we also want to include some qualitative research on that, partly because reporting rates of linkage can be difficult, as Helen just mentioned, but also understanding clients' views, and we know that acceptance and how you process a HIV positive result are really, really important for how you then access care and also how you're then retained in care. So thinking about how individuals experience that, how they view it, what information they need in order to be prepared for if the result is positive, and to make sure that they know, where they go if they need extra support and so on and so forth. Yeah.
Thank you very much. Any other questions? Yes, please, in front here.
Okay, thank you. Kieran from MSF UK. It's a question to maybe the whole panel, including Catherine, and it's about health practitioner barriers to paediatric testing. This was described quite well in some of the presentations that in many of the settings we work, health practitioners will find it very difficult to test a child if they are not accompanied by their normal caregiver, and sometimes this raises legal and political issues. If I can give the example Swaziland. We did try to work with the Ministry of Health there, and the art director came and spoke to all the nurses in the region to say we should you to test a child, even if they're not with in the best interest of the child. You will have the Ministry of Health's backing if there are any problems. And it didn't change anything.
Don't have a lot of time. Okay, good afternoon, everyone. I hope you had a good lunch and break. So we are happy to continue for session number 3. And for that, I would like to invite the presenters and the chair to come to the stage. By the way, in the break, you saw the first session of MSF Scientific Day in the UK, and they're gonna continue with their second session, which we cannot follow live, because we have our session here. But if you still want to see that, that's possible, because we will make a show, and if you go to our website, you can still see the recording of that session. And it's good to know the session in the UK is reproductive health and sexual violence, so it links with our session here in Delhi as well. So now I would like to present Anjala Gopalan. She's the founder and executive director of the NAS Foundation in India, Trust, a Delhi-based NGO dedicated to fighting HIV/AIDS. Established in 1994, NAS Foundation provides support to stigmatized and vulnerable communities with HIV. In 2000, Anjali also founded the NAS Care Home to provide a safe and supportive environment for children living with HIV. The home employs a holistic approach to look after the nutritional, educational, medical, and psychological needs of each child, and has been designated as the only care center for children in the entire northern region. Bestowed with several prestigious awards, Anjali also spearheaded an 8-year legal battle under 377 of the Indian Penal Code, with the court ruling in favor of NAS India. Welcome, and I hope also welcome to the other presenters, and I hope we have again a very engaging session. Thank you.
Thank you so much. Good afternoon, everyone. And welcome to this session. We have 2 speakers, and I've been told to actually keep time, so I'm not usually rude by nature, but I may sound so right now. So we have 2 speakers with us. And the first speaker is Paul Lungdim, who has been working as a coordinator at the Delhi Network of Positive People since 2013, and is responsible for coordinating projects concerning expanding access to essential services, increase treatment adherence, reduce stigma and discrimination, and improve the quality of life of people living with HIV. His HIV status was confirmed in 1995, and he has been on retroviral treatment since April 2013. Paul is going to share his thoughts on monitoring stockouts in the National AIDS Program facilities in India. This is a case study that was done by DNP+. Paul? I'll introduce you next. And the way this works is after the second, so we'll take questions after both presenters are finished, as we have some time for doing precisely that.
Namaskar. My name is Paul Lungdim. I'll be presenting on monitoring stockout in National AIDS Program facilities in India. DNP Plus mission is to improve treatment services for people living with HIV, monitoring stockout or shortage of ARV, OI medicines, or diagnostic kit in ART program. We started monitoring stockout shortage at Government Antiretroviral Therapy ART Center. our methodology in this for monitoring stockout is we monitoring of stock of ARV and diagnostic at the ART center in Delhi from the last 8 years. And I'm going to present retrospective study of daily monitoring of all 9 ART centers in Delhi from June 2012 to February 2015. This study has met the MSF Ethic Review Board approved criteria for analysis of routinely collected program data because it is DNP daily activities to carry out daily stock of ARV or kits, and confidentiality is maintained and no harm is done to the PLHIV as confidentiality is maintained. PLHIV has complete trust on DNP+. And this is the ART center in Delhi. What we did is we screen ART cards, identify treatment interruption. We ask patients about their experiences issue with ARV or testing, whether they have received the required amount quota of ARV or whether they have got tested for their routine tests. And we question staff working in the ART center on availability of essential supply. And here I'll like to explain a bit more on stockout. What exactly is stockout meant? Stockout meant no physical stock of medicine and kits. And shortage mean medicines were given for less than designated 1 month supply to patients. Routine tests not available on designated date for monitoring and diagnosing resistance. Our results shows that 32 episodes were recorded on shortages, and just in 2014, 15 episodes were out of the 32 recorded episodes. And this resulted in repetitive ART center visit by patients. So, because since they are not getting 1 month quota, they have to visit, they are told after 15 days or after 3 days. And even some have to shift their regime from to SLN Stavudin. And it hampered their economically travel costs, or they have to purchase with their own money. And last but not the least, they are psychologically affected. And this is 2 pictures of how we recorded evidences of stockout or shortages. In the first picture, we saw the circle shows that Stavudin is given in place of tenofovir. The patient has to be given tenofovir, but since there is stockout, Stavudin was given. And in the second picture, we can see 3 days in the circle mark. So the patient was supposed to get 1 month, but due to stockout or shortage, due to shortage of ARV, 3 days was given, 3-day dose was given to the patient. And this is the letter sent to Secretary Health Minister regarding stockout of viral load kits. We have 2 letters to NACO official regarding viral load testing kit stockout, but we met no response. So we went ahead and sent this letter to Health Minister, trying to make him aware that viral load testing kit had been on stockout for the past 1 year. How we tried resolving it? Some with technical support from MSF Assist campaign. We met NACO officials, we met procurement agencies like rights. We met procurement agency rights because there is a delay in timely issuing of procurement or tender. ARV manufacturers so that they can bid for timely. When they are not bidding timely, there is a shortage of ARV or kits. And when such thing happens, stock out or shortages happen, we'll roll letters to the WHO, HIV department, UNAIDS, Global Fund, and pediatric supplier to make them aware of stock position, the stock out position. And when when the stock out is happening for a long time, we even send legal notice to Health Ministry. And when repetitive stock out shortage continues, we even intimate and engage media or journalists, and with our issues and concerns are published in articles in national and international media. And these are a few pictures. The first and second picture shows of our sit-in protest at NACO office. The first picture is in 2011 when there was ARV nationwide. So, and the second picture is in 2013. We had another sit-in protest at NACO. That is the way when we how we work out. And the third picture is showing us having a silent protest at 10-year celebration of ART program in India, organized by NACO, to highlight consistent recurring stock out of ARV that is hampering PL-HIV life. When stock out or shortages continues, there are times when even DNP had to go ahead and purchase drug ARV for patients. And then monitoring of the supply chain led to identification of stock out shortage in public facility, resulted in behavior change in clinic staff. They started to inform about stock position. We pushed Cipla Pharma Company to bid for pediatric formulation. WHO, MSF, Clinton Foundation, emergency donation. Pressure to finalize bid for first line and second line ART in September 2014. Motivated other positive network to come out and actively report on stock out, like Mumbai AIDS Forum and Positive Women Network. Limitation. In DNP Plus, the limitation we face is that we have no particular staff or resources or fund to do this monitoring. We are just doing extra work. That is the limitation. And the situation is still grim. Budget of National AIDS Program further reduced. And the comment made by Indian Health Minister, this is what the comment made. AIDS was a concern. That is the mindset. Never-ending delay in issuing and finalizing bids. So monitoring is a challenge. Supply chain reform is still pending, and viral load kit stock out is happening for the past 12 months. What we need is national monitoring system on stocks for timely stock out report so that timely replenishment can be had.
Okay, you're 10 minutes over.
Thank you.
Oh. Thank you, Paul. Now I'd like to introduce Padma Deosthali, who is the coordinator at the Center for Inquiry into Health and Allied Themes. She was instrumental in founding the Dilasa Public Hospital Crisis Center and sat on the national committee which, under the Ministry of Health and Family Welfare, developed the national guidelines and protocol for medico-legal care to survivors and victims of sexual violence. As a member of the WHO Guideline Development Group Steering Committee, she contributed to establishing clinical guidelines for responding to intimate partner violence and sexual assault. She has undertaken research on standards of care in private sector healthcare, its unregulated growth, women's work, and the health implications of violence against women. Padma is going to speak on making the health sector responsive to sexual violence, the lessons learned from this. Thank you.
Thank you, Anjali. Thanks for that introduction. Yeah, it's a challenge time. I will. So this presentation is really, as the title suggests, it's lessons learned from an intervention project that we are running in Mumbai. And when we talk about the health sector response to sexual violence, one immediate thing that we all recognize is that the health sector has a dual role to play when it comes to responding to sexual violence in terms of the clinical and therapeutic care and also the forensic. Before we get into the actual context, what has changed in India is after the 2012 Delhi incident of brutal sexual assault of the physiotherapist, there were some legal amendments made, passed a certain legal mandate which further emphasize on the critical role, both in terms of therapeutic and forensic, on part of the health system. So right to treatment for survivors of sexual violence was not a legal mandate. It was an expected role that the doctors needed to play and not just focus on forensics, but that has come through with the law, both in the CLA 2013 as well as the child sexual abuse law that came in 2012. There's also a provision for mandatory reporting to and the entire definition of consent as far as rape is concerned has been clarified, and there is a clarification saying that absence of injuries in rape victims does not mean consent. And rape has been, the definition of rape is expanded from penovaginal penetration to include all orifices, anal, vaginal and oral, and insertion of penis, finger. So I think that puts the health system in a very different situation and a challenge for them to more sensitively. Now going back to what is the current response of the health system to sexual violence, this is a typical medico-legal form that you will find in most health facilities of India across the country. One is that there's the informed consent is merely a blanket consent which is assumed because it's a medico-legal case. So it's a police case. So there is no specific consent for different procedures, so there's a blanket consent taken. History is often written as alleged history of rape without getting into details of the nature of assault. So it's all history of rape. There's a whole focus on hymen examination. Rupture of the hymen is mentioned prominently without mentioning whether it's an old rupture or when the hymen had ruptured. The size of vaginal opening is definitely mentioned in almost all cases, whether it's a child, adolescent, or an adult. 2 fingers pass, 1 finger passes with difficulty. These are the kinds of comments. There's no mention of the delay in reporting. What did the victim do after the assault? Did she wash herself, clean herself? What are the use of restraints? So, was she threatened? Any intoxication, the delay in reporting? There's just no mention of that in the medico-legal form. The evidence is collected just as procedure. So it's irrespective of the kind of assault. So if she's reporting anal sexual assault, still her vaginal swab will be taken. So if she's reporting oral, still anal and vaginal will be taken. So there's just no sense. It's just done very mechanically, irrespective of whether she was menstruating. All the swabs will be taken because that is a procedure to be followed by the doctor. There's no medical opinion, no correlation to her history and what the doctor has found. The most glaring gap is in the absent therapeutic care. Most often, treatment may just not be given. There are cases documented clearly where women have had to come back for abortion because an emergency contraception was not provided, or children have been brought back for burning micturition complaints because they were not given any treatment but the medico-legal evidence was collected, but the treatment was not provided. This is just to emphasize that, painkillers have been prescribed in the form for the patient for genital injuries, but the doctor has written on the medico-legal form that the patient is uncooperative. Instead of saying that a per examination was not possible because of a genital injury, this is the kind of comments that are made. all of this is rooted in the most insensitive gender, absolutely stereotypical notions about rape, which are still there in the latest of forensic textbooks. There's no time to get into the details, but this presentation is here. So it talks about the kind of, types of women who can resist, who cannot resist. It keeps rape is the easiest allegation to make but difficult to prove. There's a whole focus on commenting on sexual habituation of women. So they're instructed, the medical textbooks actually instruct doctors to do all this. And this exists in the 2013 editions. Now coming to medical evidence in sexual violence, as you all know, it could be in the form of trace evidence, it could be injuries on the body, or it could be infections. But one needs to understand that medical evidence has its limitations because there could be gap between when the incident took place and when she reported to the health facilities. The nature of sexual assault will determine what kind of evidence is going to be found, whether a condom was used, whether there was intoxication, whether drugs were given. All of this affects the kind of evidence that could be found on a rape victim. Post-assault activities. So the fact, if there is no medical evidence, it does not mean that sexual assault did not take place. Coming to the model that we've set up in 3 hospitals in Mumbai in collaboration with the Ministry of Mumbai there. So it's a collaboration between Sehat and 3 hospitals. We've set up a comprehensive health sector response where informed consent has been operationalized to seek consent for treatment, for evidence collection, for reporting to the police, and for collection of evidence. So at all stages, for all these 4 procedures, consent is taken, and it has been followed for all survivors who report to these hospitals. Detailed documentation of history of assault. There's a gender-sensitive examination, collection of relevant forensic evidence, and provision of a medical opinion. There's also medical treatment which is provided free of cost, and first contact psychological first aid is provided, and a documented chain of custody has been set up. Because often we found in most hospitals, evidence is collected, but it's just lying because there's no documentation as to in whose care this is supposed to be kept. Referral to appropriate agency. So this is the kind of model, and what I'm going to talk about is the lessons learned from execution of implementation of this module since 2008. This is based on the medical legal protocols that have been maintained. Total cases were 448, and what's been picked up for analysis is 411, and 17 codes have been analyzed. We found that after 2012, so 2008 to 12, we had about 94 cases across these 3 hospitals, and after 2012, which is when there was a huge campaign in India, a 3-fold increase in the number of survivors coming to these 3 hospitals. If you look at the age of survivors, we have about 42% who are less than 12, they are children, another 35% who are adults, and about 23% who are adolescents. Nature of sexual violence, it's non-penetrative assaults, which have been 25%, and I think that's the huge difference that the definition of rape, it has been changed, makes in terms of access to justice for these survivors. Profile of perpetrators, almost 77% in cases, the perpetrator was known to the victim. 25% of these cases followed up for counseling and other. This is the analysis of legal outcomes, and if you look at the 17 court judgments, 2 minutes, yeah. Factors leading to convictions, we found that the documentation of detailed history by the doctor, the trace evidence when it was explained in terms of presence or absence of trace evidence. So if the ejaculation was her body, so it was explained that therefore there's no trace of semen. The detection of lubricant, so the absence of injury was explained. The fact that she was menstruating, so the doctor was able to explain that there was no, therefore there is no forensic evidence. Even injuries were interpreted in terms of the delay in reporting, the fact that the assault took place 35 days back, so the injuries have healed. Or the redness, the distinction between redness or soreness caused because of sexual violence and that by STD. Factors leading to acquittal, often there was no the interpretation put up by the doctor for injuries was not picked up by the prosecution. Evidence was not explained. In an offense of fingering, where the doctor has said that there was fingering and therefore there is no forensic evidence, the judgment and the final judgment says absence of semen. So in a case of fingering, you're not going to find semen. So the occupation of the judicial system with medical evidence and especially forensic evidence comes through, and their biases towards rape comes in. For offences of non-penetrative sexual assault also, the court asked for semen. Why was there's no semen that was found. Of course, there were social factors where cases were withdrawn. These are details which there's no time to go through, but this presentation will be available. So these are just to really say what is how the doctor explained the medical evidence. What's emerging from this analysis is that for the courts and the prosecution is that they need to recognize infections also as evidence. So even cases, the whole preoccupation is with semen and injuries. So but infection itself provided, that itself needs to be recognized as medical evidence. To conclude, it's possible to conduct these medico-legal in a gender-sensitive way. Evidence-based scientific forensic practice is absolutely essential, and that can really stand the test of time. Doctors need to explain the absence and presence of injuries. Guidance on medical evidence and its limitations has to be provided to doctors and prosecution, police and the judges, because there obviously seems to be a lack of recognition of it. These are few issues that I would like to flag. One is that mandatory reporting to the police has come in, and that really comes in a way, it kind of contradicts the whole right to treatment provision that the law has brought in, because those who don't want to report to the police, often they can be denied treatment, and informed refusal for informing the police, which has been what we are practicing in these hospitals, realize that it really requires ethical practice. Most doctors would like to just go with the law. So when the law and the ethics, there is a kind of dilemma, often doctors choose to go the legal way. They don't want to take an option. And this is a problem, especially with women who are reporting, who come for abortion. So often they are reporting rape after 2 months. So it really makes no sense for the doctor to mandatorily report to the police. The other is married women reporting marital rape, and you know what our country and our parliament thinks about marital rape. We've had about 12 cases within these 441 who reported rape by their husbands or boyfriends. So marital rape is very common, and I think it requires a legal, because the rape law excludes rape by the intimate partner, a criminal case cannot be made by the police. Transgenders and boys are also reporting here. We've had about 2 transgenders in the last 2 years, and about 3% of these 411 are boys who reported with sexual violence. So yeah, I'm done. So this is to acknowledge the interventionists, because we are on call for these hospitals, and we provide 24/7 on-call services to the doctors and survivors and their families. And lastly, I would like to thank the MSF for including us for this conference. So thank you.
Thank you very much. I'll open the floor for questions. And I'd like to request that those of you who ask questions, please speak into the mic so that it can hear you clearly. Who would like to go first? Okay.
Is it on? First of all, thank you for that presentation. You mentioned that there needs to be better recognition of infection as evidence of sexual violence. What proportion of rape cases will lead to infection, or if you don't
lead to?
Will lead to an infection? How common is it for an infection to occur when a rape happens? Sorry, that's a dumb question.
Yes, please.
So at least from the court, this was based on the 17 court judgments, And in cases, about 50% there was acquittal. And in cases where there was acquittal, at least about 5 cases did have clear infections. So there was medical evidence which was not picked up. In terms of our overall 411 cases, about 50% reported a health complaint. It may not be infection, it could be an unwanted pregnancy, it could be a range of other health consequences, but about 50% did report a health consequence.
Good. Yeah. Oh, he has a mic. Yeah. You.
Just a comment to add that NACO has recently revised its post-exposure prophylaxis guidelines to include those victims of sexual assault for provision of post-exposure prophylaxis for HIV. And this is now a part of the post-rape, whatever protocol is.
But they haven't done it for people who have sex.
That is the issue that we can discuss, but since it was context of rape, so I just informed that it has been done for. There are issues of not doing it for regularly for sex. We are in debate for opening it up for cases of ruptured condom and all those situations.
Right.
That is under debate. But for regular sex, I think it's an issue we can debate.
Yes. You and then you.
Me?
Sure, and then you and then you.
Sorry.
Yeah.
I just want to respond to this thing. You were saying that when they say the vaginal rape, they take only a swab from the different area. I'm just saying, as an academic exercise, it's a normal practice to take from all the orifices, because once you say there is an STD, evidence of STD, that's never known, isn't it? When we try to investigate, it's always from all the orifices we take swabs. It's just an academic find out what is the extent of disease. It's not just that you don't do it from one area.
Okay, just to clarify that the mindlessness of the swabs is not for infection. Is not about clinical care. It's about just sending it to the FSL. So.
Okay, question in front and then at the back, and then we'll come this side.
Hi, thanks for the presentation. I was just curious about, you mentioned doctors usually prescribe painkillers to victims after they've been, I was wondering about the accessibility to mental health. Is that something that's accessible in Mumbai? Was it? And is it community-based or is it just in the hospital?
Yeah. Okay. So just to clarify that the painkillers are not routinely administered. That was just to illustrate one example where a painkiller was given, but the doctor has, labeled her as a patient who's uncooperative instead of saying that because of severe injury, a per-vaginal examination could not be done. Now, when you say patient is uncooperative, the judiciary will take it very differently. So it's interpreted as she did not allow the examination to take place. So that was what I was trying to say. Psychological first aid is absent currently, and whenever you talk about the mental health consequences, people feel that's the role of the psychiatry. And I think I just want to highlight here that the Ministry of Health and Family Welfare has issued guidelines for the first time. It's a national guideline and protocol to be followed for responding to sexual violence. This was done in 2000. Which includes psychological first aid.
Okay. I have time for just maybe one question, maybe half a question actually, but we'll take one. So sorry about the others.
Yeah, Padma, nowadays it is being reported that instead of being sexual violence and natural, you say anti-natural, whether it's oral or anal or like that. And media is also equally adding to violence. So how you are dealing with this type of situation?
I didn't understand.
Anti-natural sex.
What?
Anti-natural.
Anti-natural.
What is that?
Oral or anal or other types of. And media is also adding to violence.
Okay, so there's a contradiction in our, the rape definition definitely now anal, forced anal intercourse, and therefore it's not unnatural. It is, the definition of rape has been changed, but 377 continues. So this notion of it being unnatural continues. So that's a very different discussion, but it's not at all, rape definition includes oral, anal and vaginal intercourse, any forced intercourse.
Penetration of any orifice is now considered a rape, and therefore it is in contradiction with section 377, but thereby hangs another tale.
Yeah. I just have one last question.
Okay, I think I've been allowed to expand by a few minutes more. Were there, just, I'll come to you, but I thought I saw a tentative hand being raised here. No, we can't get into this natural debate right now, but we can meet during tea.
Yeah.
Yes, can I?
So I would just like to ask one. The presentation was very interesting, and I've seen this kind of context while working in Pakistan. You have the same, almost traditionally very family-oriented program. My question is, it's a very difficult topic to tackle in Pakistan just because of the sensitivity of the issues. What I wanted to ask is that based on the statistics that you have, a lot of are under 12 and a lot of them know their perpetrator. My question is there a shelter that can actually keep these victims of the sexual violence here in Mumbai in place right now? Because that is also one of the big challenges that we have, is that it's very difficult to start up a gender-based violence program if we cannot have a shelter sheltering the victims of this violence. Thank you.
Okay, so yeah, I mean, some children may require institutionalization, and such institutions are available. But I just want to say here that that's not the best, that's not always in the best interest of the child. We've had cases where the child welfare committees have institutionalized the child, and we've gone as counselors and made presentation to the CWC that the child needs to be in the care of the mother. There's this perception that if the child has been sexually abused, the parents are incapable of further taking care, which is not, it's a notion. I mean, sexual violence has occurred, but there's a way by which the parents can keep the child safe.
Because the parents may not even know.
No, exactly. So I think this notion that every child who is sexually abused needs to be institutionalized is, some children, yes, have to be. If it is incest, then, there's just no other option.
Yeah. But just to answer your question further, our experience is we have a good law in place, but service provision is not exactly the best. So it's very difficult, for example, for women who are trying to flee domestic violence, impossible to find shelter. So that's an ongoing issue, I think, across the country. Yeah. Yeah.
You said about Pakistan, so we know that there's an war, which is working very closely with hospitals there. And I think some legal work that they're doing is really of high quality.
Yeah.
All
across,
hospitals, I understand.
Absolutely. So on that not so happy note, I would like to end, because we really cannot expand this time frame anymore. So we are going to break for tea, is my understanding. Oh, right now is keynote? Oh, I was looking forward to tea. Okay, all right. Okay, so we now have the next speaker, come on, who, by the way, is an inspirational man. I don't mind deferring tea.
That's not me.
No. Thank you.
All right. So, one more session before tea. Keynote, all the person we've all been waiting for today. It's my honor to introduce the keynote speaker for today, Dr. N. Kumaraswamy. Dr. Kumaraswamy is a clinician and a researcher in infectious diseases with more than 20 years' experience in the field of HIV medicine. He is the Chief Medical Officer of HIV Care and directs the clinic which provides medical care for more than 20,000 people with HIV in Chennai. He is the Chief and site leader of the Chennai Antiviral Research and Treatment Clinical Research Site of the U.S. Institutes of Health to conduct multi-site clinical trials on therapeutics and prevention. He is also involved as an investigator in several ongoing clinical research projects with the University of California, San Diego, and Brown University. Dr. Kumaraswamy studied medicine at Madras Medical College, underwent specialized training and a fellowship in infectious diseases and HIV at Brown University and Johns Hopkins University in the USA, and completed his PhD in infectious diseases at the University of Madras. He is an expert panel member of the for the WHO ARV Treatment Guidelines Committee, a clinical advisor to the Clinton Health Access Initiative, and has published more than 250 manuscripts in peer-reviewed medical journals. His publications on the impact of generic antiretroviral therapy have led to several antiretroviral scale-up programs in developing countries. He has a particular interest in the long-term impact of antiretroviral therapy in resource-limited settings. It's my pleasure to introduce Dr. Kumaraswamy.
Thank you for the kind introduction. At the outset, I'd like to thank MSF and all the organizers of this meeting for inviting me to do this presentation today here. And again, I like to tell you this is the second time I'm speaking in an MSF forum. First time I was been counting, and actually when it was sometime in the year late 2000 or early 2001, I was asked to give a talk on generic antiretroviral drugs in Paris, in France, in your MSF office, very beautiful office. I still remember. I'm sure many of you would not have even joined MSF. Some of your old friends here, might be there. So I still remember those days where how MSF have now moved from just an advocacy organization to a scientific body today after hearing all those wonderful presentations. So what I'm going to do today is, and I was to do a keynote on what happened to developing countries in terms of HIV disease on the introduction of these antiretroviral drugs. And again, why I was invited, I'm sure the organizers would have reviewed the medical literature on seeing what we have done 20 years from our institutions as well as in resource limited settings, what you have done in this particular field. So what I'm doing today is I'm going to review some of the published data from our center as well as from other developing countries, and I'm going to give you a challenge what you should go back and do in the community in the interest of better patient care. So I like to tell you that today the long-term impact of antiretroviral therapy is all thanks to that what's happened today because of our Indian generic drug manufacturers. What you can see, all these drugs have been today available from India. I'm using the word proudly, standing in this podium, and been available to our patients. We heard this morning intravenous doxycycline was not available. I think that's a shame that our generic antiretroviral drugs all been manufactured in our doorsteps. Why they can't make that easiest thing? I think this time to advocate with our companies to get that done, for our patients for scrub typhus. I've been involved in the development of some of these molecules with the Indian pharmaceutical companies, starting from Cipla to other companies, either as a monotherapy or in starting from the safety studies, stability studies, bioequivalent studies, and some of those efficacy studies. So I feel proud that it had made a huge impact across the globe. I still remember in the year 1994, Sudafedine has been available through our Indian generic market by one company, and subsequently there are 5 different companies mushroomed, and all those white-colored drugs been available. Just for one of the people on the other side, I may use this pointer in the computer. And some of those other drugs which have been shown in the greenish color, these are newer drugs, not available through our Indian generic companies, but been available in India, some of them, or will be available soon through some sort of a partnership which is done by the Indian companies with some of those proprietary companies. I like to tell you that today we can't say that we don't have drugs available. All those drugs are available at our doorstep. And again, this particular study, I like to tell you that, not because I led this study, because this study really made a revolution, which you all know that. Of course, MSF also did a study similar the same time in the year 2001-2002 in West Africa. Both the papers came, the next issues. Ours came first, and subsequently the next month in the same AIDS journal, a study came from MSF. Indian-made generic drugs are safe, tolerable, and effective. Why I'm showing this data is when we talked about the Indian-made generic drugs, when we used to present anywhere else, he said it's so cheap. It's whether it is safe, whether it is tolerable to a patient, whether it will really suppress the virus. All those questions were put to us by the so-called biologists. For that reason, we need to do all those studies to shut their mouth, stating that Indian-made generic drugs are safe, tolerable, effective. Even in dying, when we put these drugs into their mouth, they're able to walk around. So this has made a huge revolution today. So this is again a data which I'm not showing, but the UN is showing this. Now recently been updated. This is something which has got a year back, very clearly shows that over a period of time, antiretroviral drug scale-up has been rapid and robust. This is something we should feel proud of. Indian companies, where more than 12.9 million people are now receiving antiretroviral drug in lower and middle income countries, including India. There are some countries started early, but some countries started late. Still, they are not too late, but why they started late? Because they always look for evidence. Whenever, when we have been talking about some new disease and new drugs, people don't jump immediately, this should be provided. They always look into evidence. Sometimes that is good because you'll have a solid evidence. You can put very well in a public health, put it in a guidelines that will be sustainable. And many times that can even does a lot of damage where you look for more evidence. Sometimes some of our policymakers will look for it. By the time more damage will happen to your public, by the time it might be too difficult to repair the system. But here, this is one study again, we published very long back in the year 2003. I think it's published in 2005. We presented in many meetings in 2002 and 2003 and made big voice in many countries, including here in India. Dr. Rivari is here. I'm sure you'll appreciate this. This is something where one of those first evidence outside US and Europe stating that death rate in HIV-infected people coming down dramatically following antiretroviral therapy. One of the success program is our national program, NACO. Presentation earlier by Paul showing about stockouts, but on the other hand, we have got a lot of greatest thing happen that also some like that. So this is again a slide given by our NACO friends. Dr. Rivari is here. They have an updated slide now till 2014. They have put around 850,000 patients on treatment, and in a private setting, almost around 100,000 people, almost 1 million people receiving antiretroviral treatment today in India. That is great. Next to South Africa, India is one country receiving, large number of people are receiving antiretroviral drugs. Again, mostly, almost all, everyone is being Indian-made generic drugs. What this has led to, this is again not a long-term impact, it's a short-term impact. It's again a data from NACO. I'm sure you'll have access to this on their website, but it very clearly shows that following this introduction and rapid, robust scale-up of antiretroviral drugs in our Indian antiretroviral clinics, you can see how the number has been coming down dramatically. There are a lot of people asked different questions on this, why the numbers in India has been coming down. Is it because of those methodology what they used, or because of more awareness, or because of this antiretroviral therapy? I will call this a combination of everything, but on the other hand, more and more, I will put this because of robust treating people, which reduces infectiousness, which you will see in some studies soon, and following these, we are seeing this fruit. And also, UN has very clearly now shown that how the morbidity and mortality has been coming down following this antiretroviral therapy. Here you can see a success story in India, here where we have 38% decline. But on the other hand, if you want to sustain this success story, we also have to listen to what Paul said. We need to prevent the stockouts and a lot of other things like adherence and everything. If you don't do that, this 38 will not may drop down. This also has been very important. It's not only in India and in other countries, but also today. You can see this blue color graph is where patients who have got access to antiretroviral drugs, where death rate has been coming down, and as compared to people who are not receiving antiretroviral drugs, which is shown in the red color line, where death rate is continuously going up in all continents. This very clearly shows that antiretroviral therapy prevents death in HIV-infected people, which is a major indicator for any disease. But again, if you ask me a question whether it's a long-term effect, no. Being a clinician and an epidemiologist and a public health person, I will say this is a short and medium term. What is a long term? Today we really do not know. So that is something where we need to pose a question to a lot of public health makers as well as clinicians when they have been taking care of these patients on a long run. So one of the things is this example. So this is a study called HPTN 052, which was conducted by the US, and I was also one of the principal investigators of this trial, which was conducted in Chennai, as well as in many other countries, in Thailand, in Africa, in Latin America, and as well as in the United States. What we did is, we wanted to study whether antiretroviral therapy prevents HIV, I'll call sexual transmission, among the married serodiscordant couple. What we mean by serodiscordant is, for people who are not aware of this, is one partner HIV positive, another being negative. So for this study, we selected patients who have been with a CD4 of 350 to 550. At that time, they don't need therapy. So we recruited for this trial. One arm, another one did not, but they received only the standard of care for the setting, that is treatment of opportunistic infection, STI. But when the CD4 dropped to less than 300 or 350, then they were also put on treatment. So this study, I like to tell you that we ended last week globally on 1,750 couples. But on the other hand, the interim results we published in New England Journal of Medicine, There is one of those landmark findings. What we showed is there was 96% reduction in HIV among patients who received immediate antiretroviral treatments. That means the couples who received treatment immediately, soon after randomization, not waiting up to the 350 threshold, they had reduction in HIV transmission among their partners. Also, very interestingly, we found there was significant reduction of clinical events, HIV-related clinical events, as well as including extrapulmonary TB in among patients who received antiretroviral drugs immediately. So following this very landmark study, which has also been picked up one of those top scientific discoveries by the Science magazine in that year, 2011, WHO and all the other developed guidelines also said that now we need to raise the threshold of starting treatment at 500, or in certain populations like serodiscordant couple, or if you feel there is a population who can transmit infection to others, where you need to start treatment irrespective of the CD4. So following this, now robust guideline changes been happening. WHO and a lot of other country partners have been doing this, including India has already moved, but I heard implemented also. So this is the 2000 the real lower income countries in the high, including the is median of patients who are starting of clinics is those is including there are two observations the data clearly shows that the guideline recommending you start treatment at 500, 550 and 600, but what's happening in the real life is we are seeing people who are very sick at the clinic and the CD4 is less than 200. So what we can do to them? And again, UN has already said these figures. If you take in India, among the people who need treatment, only around 40% of them on treatment. What I heard from NACO is now it's moved to 50 or up to 60. So, but still, almost around 50% of the people who are either not aware of their HIV status, or they are still living in the community, they are not being detected, and they are not put on the treatment despite this treatment has been available. So how we can put them on treatment? This again, we did an exercise, again in collaboration with this Harvard group with a grant from USNIH. This is again a modeling exercise. We use the incidence and prevalence, which has been published from our NACO, as well as some of the other individual agencies. And also, we use in this model the cost of HIV testing, including for counseling, testing cost, and as well as for collecting these results and for dissemination and counseling, post-test counseling into this model. What we found is, in a country like India, with the current prevalence and incidence, if we want to find everyone, a country with 1.2 billion people, now we have found only 2.1 million people being estimated living with HIV, and among them only 1 million are being put on treatment. How we can find the remaining? You have to offer voluntary HIV screening among our national population every 5 years. I don't know how we are going to do this in a country with a lot of stigma and with a lot of other logistical issues. This is something what we've been proposing, which will produce substantial clinical benefit as well as cost effective. And also annual HIV screening will be cost effective, especially in high risk population as well as in high prevalent districts, especially in injecting drug users and in gay population as well as female sex workers. and also certain in high prevalent pockets in Andhra Pradesh and as well as northeastern state. If we can do this, we'll be able to identify these individuals at a higher CD4, put them on treatment, we can prevent morbidity, mortality, as well as we'll be effectively see reduction in HIV transmission. This is something where we have made this model. I'm not sure that how we'll be implementing. We are discussing very closely with NACO how we can do this. I'm sure MSF rural clinics can take it up as a big issue, how we can implement this HIV testing, which is very important for our country, as well as another resource-limited setting to bring them into the antiretroviral treatment clinics. So what's still now happening is we have got treatment available, but if we put them on treatment, these are studies very clearly shows that even when you put people on treatment, still patients die in our clinics, either because of tuberculosis or because of those undiagnosed opportunistic infection. Because you have put them on treatment at a very low CD4. It's not only seen in India, but also in globally. So this is something where we need HIV testing. We need to identify people before they progress so that we can put them on early treatment and not only prevent HIV morbidity, but also will prevent HIV transmission. One word about TB. TB accelerates HIV disease progression. Enough studies had been done, as well as vice versa. The earlier guidelines always used to wait to start treatment. We always used to treat TB first, then we used to start on antiretroviral treatment. Now, following this, what we have seen is these are all 3 different clinical trials, and one of those studies I was being involved called the ACTG 5221 ASTRIDE, which was done in India, Thailand, and Africa. And there are other studies done in Camellia, which is in Cambodia. I think it's MSF led this study, and SAPI is a trial which was done in South Africa. So MSF with ANRS Paris. So all these studies very clearly shows that if you delay the antiretroviral treatment in patients who are co-infected with TB, you will see high morbidity and mortality. So here again it shows you have to start treatment immediately along or at least after 2 weeks when the TB therapy is tolerated. If we can effectively do this, we may effectively reduce HIV and TB morbidity. So it's already been started seeing. If you see the data from 2012, in a country like India, it's almost 50% reduction in TB-related mortality in HIV-infected people. But we expect to see 100% if we are able to effectively identify all those people and put them on not only on TB therapy, but also on effective antiretroviral drugs. Now, moving away from these early epidemiological figures related to antiretroviral drugs to some of those drugs. There are a lot of drugs what we used earlier in our lives in 1997, 98 had caused major morbidity and mortality of our patients, which we had seen in our clinics. One of those, this worst drug is stavudine, which we have been involved in the clinical development and also personally I was been involved in the destruction of this drug, showing these such data to WHO and other bodies. So this is something where now it has happened, phasing out these drugs, now better drugs are coming. But still, there are some drugs still in the community like our AZT, still widely used in India, even despite the presence of tenofovir. This is again a study called PEARL study, which was again done in resource-limited setting, where very clearly shows that if we compare cidovudine versus tenofovir, both can be equally efficacious, but on a long run, if you see this is a data showing that if you use cidovudine on this patient, they'll have more side effects on a long run. Immediately, they'll be doing well, but on a long run, after 4 to 5 years, they'll have more side effects as compared to tenofovir. As a result, more morbidity and mortality can happen because of antiretroviral drugs. We gave a very strong warning to WHO and other guideline makers, stating that we need to move that out of our guidelines. At that time, there was a severe protest came from a lot of guideline makers. These drugs are newer drugs, but how can we introduce in a public health setting where if you are going to put tenofovir, you can treat only one person, but on the other hand, if you want to put stavudine or AZT, you can treat 2 or more people. So at that did this cost effectiveness studies, where I'm again using the word cost effectiveness. These studies are very important, not only observational studies and randomized clinical trials. If you don't do such cost effectiveness studies and show to our public, the policy is not going to change because cost is a major barrier everywhere in the world, in India as well as today in the United States. So this again, the cost effectiveness study very clearly shows that using tenofovir in India, even at that time the cost was being cost effective on a long run. Following this, every guidelines have changed. Today we have got the WHO guidelines, even our national program now completely changed to this tenofovir containing regimen to start with. Again, having said this, today someone may be positive if you start them on treatment. In our clinics, the median age to start treatment is around 30 to 32 years. If they fail, we have got second line drugs available. With that again for another 10 to 15 years they can do well if they have been adhering to the drugs. And also now we have got third-line drugs available, but soon will also be available through our public health sector, which they have already announced, but will be implemented. So for another 10 to 15 years. So today, someone who is HIV positive for 30 to 40 years live productively and healthily. And if you put someone on treatment at 30, 35 years, for 70, 75, they can live like any other normal person. By the time they can have been attacked with other natural or unnatural disasters. So this is something what we have seen in HIV disease, which had made these antiretroviral therapies, made these HIV infected people to live longer and made this disease as yet another chronic manageable disease. But this will be happening only if we have been doing this properly and appropriately. Same like our cricket matches. You know, I'm sure you're all watching this IPL and everything. Our top order batsmen are doing well, again, that whole team will do well. If the top order batsmen are not doing well, if they're not following the proper basics, or the coach is not sending the proper batsman as an opening batsman, the whole team will collapse. Here again, the drugs are available, but here the coaches, we clinicians and public health makers. If we are not doing this properly by doing the proper monitoring of viral load, again, these whatever regimens we are going to use is not going to help this patient to live for 30 or 40 years. So this is something for the biologists here to know that, and also the public health makers here. The first thing when the patient fails is what happens is a virological failure, followed by the immunological failure. That's the CD4 cells will drop down. If you don't switch the patient to the alternate treatment, then they'll develop one of those clinical events like tuberculosis or cryptococcal meningitis or pneumocystis pneumonia, and they die of those. The duration between virological failure to clinical failure or immunological failure can be anything from 6 months to 2 years. And also science shows that the resistance mutations to these drugs can occur much early and can also keep accumulating, also jeopardize some of the newer drugs which are not used for first line or second line, or you are preserved for future lines, or some of the drugs under development can completely get jeopardized. This is something what science has said. Today, because of lack of technology or because of lack of resources, we don't do routinely viral load monitoring in our public health program. We do more of a CD4 monitoring or clinical monitoring. And because of that, what's happening is, this is a study again done by our group very long back, almost 8-9 years back. At that time, our patient didn't have access to viral load. What we did is, patients who had been failed following the WHO definition of immunological failure of declining in CD4, we had stored specimens for this particular study. So we did a resistant testing. What we found is, very interestingly, just for one up time, we'll not go into the detail, they'll have variety of mutation, resistance mutation, even if they had mutations to some of those drugs which have never been used, as well as some of the drugs which have been preserved for second line or third line, or even some of the drugs under development. So following this very clearly, we gave a warning to the guideline makers, if you're not doing viral load monitoring, you're going to jeopardize all the drugs. Immediately, there was some reaction against us, but our science was rapidly supported by other groups from Thailand and as well as from Africa. So today, again, I go back to the same the sequencing therapy which made patients live for 30 or 40 years. Before 2013, we started with drugs like zidovudine or D40, stavudine, but no viral load monitoring. So what happened is, when they failed with not only with these drugs, but also they accumulated certain mutations, also jeopardized some of those drugs we preserved for second line, like tonight. That means they ended up in like a protease inhibitor monotherapy. And because of this, we also did clinical trials to support this patient to upgrade one of the integrates we preserve for third line. Like in a IPL, where you upgrade some of those hot hitters to first one or anything to get the run rate. Same thing now in these patients. We have been doing this. If you're not doing this because of the cost or because of not availability in a public health program, again, this protease inhibitor will become like a monotherapy, which can also accumulate more and more mutations, which are 3 different studies have shown from resource limited setting, which can also jeopardize a lot of future third line drug, wonderful drug like darunavir, which NACO is in the process of implementing in their program, as well as the second generation NNRTI, some of them under development, some of them available. So that means if you're not sending the proper batsman up, you will fall. Or as a coach, if you're not using the proper monitoring assay, even if you've got the proper drugs available, that's not going to do. So this is something what we have been seeing in our patients, which I'm not saying the whole world is now collecting data and showing everywhere. And it's not only going to cause more damage to our patient population, but also I personally feel it can also end up in a major public health emergency in our setting of transmission of multi-drug resistant HIV, which we had seen in TB and antibiotics and so many other things we have seen. It's no time, we'll also end up seeing with HIV. But on the other hand, the success story is, if you do it properly, in some IPL teams are doing, including my Chennai, today they have been playing Mumbai Indians, we'll see what's going to happen. So if they have been doing well, our patients will live longer. This is something what we have seen. This is a study again presented by a couple of years back, now been published. So what we have shown is, people who have been living for more than 10 years with antiretroviral therapy, this is a cohort of almost 1,000 patients, 2 years back we published this, of median duration of antiretroviral treatment is 10.3 years, with a median latest CD4 of 510, almost 82% of the patients still have support. Almost 60% of them still they are on first-line therapy. If they have been adhering drugs, they'll do well. Very few percentage have died. But on the other hand, just for want of time, I'll not go into the detail of the statistics, why these patients in this long-term cohort, people who have got access to antiretroviral drug for more than 10 years, why they become morbid or they die or get admitted in inpatient facilities, either because of cardiovascular disease, or kidney disease, or worsening of diabetes, very common in southern India, or the complication of hepatitis C, especially our injecting drug user patients, or they develop malignancies, those neurocognitive effects. This can be either because of drugs or because of longer duration of HIV induces a lot of inflammation. It's also been very recently been published from Brazil, another cohort where they published on very large number of patients. It very clearly shows that their non-AIDS complications are on the rise in people who are taking drugs on a long run. Why this is a new phenomenon? So if you look into these diseases like diabetes and cardiovascular, these are all been there from might be the 15th century onwards. These are all not new diseases. Why we are seeing much in HIV infected people? That is because, one, we are already seeing in our aging population, because of inflammation they develop this. But also science shows that someone who is HIV positive, over a period of time, the viral infection, even if you put them on drugs, even if it suppresses the virus to a lower level, also induces a lot of inflammation, which also can lead to this. So today, our HIV infected people are getting aged quickly. For example, if you see somebody who is 35-year-old, they look like somebody who is 50 years with one of those diseases. Now with these antiretroviral drugs, whether it will come down, we do not know. So this is time that today, HIV is integrated with the TB program, without our MTCT program, with our sexual health program. But it is time that we also have to integrate with our other non-communicable diseases like diabetes and hypertension. If we don't do that, our patients will have suppressed viral load. They will not transmit infection to others, but they will die of one of those kidney disease and diabetes by 40 years or by 45 years. So this is something where another epidemic we might see, which we are seeing in our inpatient facility today. Our work has completely changed from HIV work to our internal medicine work of taking care of those complications. With antiretroviral drugs, whether these inflammations and some of those non-AIDS complications will change, we do not know. This again a study we are done in a research limited setting in different countries. What we have shown is even with antiretroviral drug, they'll continue to have inflammation, they'll continue to have this morbidity. For this reason, we need to eradicate. I'll take one more minute and wind up. So why we need eradication? So we can suppress a virus. We got drugs for 40 years, then why not? Why you have been bothered? People can swallow the pill and they can live happily. But these virus multiplies in different organs, different lymph nodes, and different, we call it as reservoirs. And because of this, it can also induce inflammation in those organs, and which can lead to all those various cardiovascular disease or kidney disease or evolution of viral hepatitis or cancers. And because of this, our patients can continuously be morbid. So just to wind my talk, say that whether the cure will be possible, it will be $1 million question. There are two types of cure. One is called sterilizing cure, completely eradicate. Please believe me, till today there is no cure. But on the other hand, there is another one called functional cure. At least we should attempt to this. This is something suppressing virus to less than 50 copies or to undetectable level and sustaining this. Like all those 1 million people who are put on treatment in India, we expect that to happen. If we can do that, at least we can prevent major morbidity related to HIV disease as well as prevent transmission. If we don't do that, we cannot even expect to cause this sterilizing cure. So today, in the history of world, there are only one particular individual had been completely cured of HIV. I'm sure you would have seen this in scientific articles and as well as in newspapers. He's a patient, we call it as Berlin patient. We had an opportunity to meet with him, who had acute myeloid leukemia. He went into multiple blood transfusions. He had a stem cell therapy. He had a chemotherapy. And he has been transfused with a CCR5 deficient hematopoietic stem cells. and just for one time, I'm not going into the science, he's been completely eradicated of HIV. Then can we give stem cell therapy to everybody? Impossible, because the morbidity related to this is very expensive, and also it can also kill people. So, but on the other hand, science behind it can be used to eradicate, which a lot of science currently been happening on that. And also now, we are also developing a lot of other novel drugs, how we can get this virus from the reservoirs into the blood, and thereby we can powerful antiretroviral drug. This is something where currently a lot of research been happening. You can see these various trials. 10 years back, I used to show such figures to show trials for when to start and what to start, what drug to start with. Today, trials now happening on how we can eradicate HIV. You know, even at YRG Care in Chennai, we've also been involved in some of those clinical trials in collaboration with ICMR. I'm very optimistic one day we'll have a cure. So till that time, we need to use the benefits of ART in prevention. The success story is the mother-to-child transmission. We have colleagues from NACO here. They completely have implemented this. We have got post-exposure prophylaxis program in an occupational setting. And also I just heard from Dr. Rivari that NACO has introduced in the sexual settings following rape. But also other questions happen about in the common people. We need to debate that. What about the pre-exposure prophylaxis? There are demonstration projects happening, so let us not jump immediately. We need to know the feasibility and acceptability and the usability of this. But on the other hand, definitely secondary prevention of HIV. That means you treat as many people as possible, put them on treatment. If you put them, reduce the virus, you'll be effectively see the prevention of HIV transmission. I'd like to conclude my keynote lecture. I'm not sure whether I satisfied all of you with all those in such a short time of 30 minutes. Global progress on scale-up of ARVs has been extraordinary. Earlier, we all were depending upon Global Fund, PEPFAR. Yes, still we are believing on them. But on the other hand, I like to tell you that countries have taken up. For example, if you take in India, what I heard is 55% of the resources are going from the Indian government. South Africa, they have already said 50% they'll take care. There are many African countries that have taken this. So this is something where the countries have shown the way in the last couple of months. Definitely, there is a decrease in morbidity and mortality and decrease in declining incidence. But on the other hand, very important presentation. It's very importantly about the sustainability of ARVs. If you story of these having these antiretroviral drugs, but if you don't look into some of those forward-looking policies on the sustainability, we'll again fail miserably. Not only prevent people who are already on treatment, but also spreading unnecessarily MDR-HIV to others. So this is something policymakers have to think very seriously before they push forward. So this is something important on prevention of transmission of resistant strains, as well as prevention and management of non-communicable diseases. I personally believe, not only as a clinician and public health makers, the last 20 years I have seen, if you treat HIV-infected people, put them on treatment, not only they do well, definitely there is a reduction of the transmission. Now, we have seen in our clinics, in our population, in our cohorts, and in our trials, where we all should go back to the community, identify people, counsel them, put them on sustainable, and if we are able to do this, we'll be able to succeed enormously in preventing and ending this HIV epidemic. Thank you again for this opportunity. I also like to thank many of my collaborators. Without their help, I would not have shown any of the data, or they collaborated with us, and without that, we would not have generated any of those data, what I said. Thank you again. I'll be very happy to take any other questions. Thanks very much. Also, I apologize, I would not have covered everything related to HIV on ART, but happy to take any questions in 30 minutes.
Great. So we have 15 minutes. We'll take perhaps a bunch questions together. We'll collect a few questions, and we'll do 2 or 3 rounds of Q&A if that's okay with you. So, microphone, please. The gentleman in the front. Anyone else? Yes.
The most exciting proposition that you made on in terms of policy and public health impact is the proposition that you made that once in 5 years the general population to be screened. If you expand this hypothesis to HPV, we could tackle 2 of the major problems in the country: cervical cancer and HIV/AIDS. And it has its spin-offs. We will be able to identify, not only target to the individuals who really need require in both the diseases. We will prevent deaths due to cervical cancer as well as HIV and productive nature. How would you expand this advocacy tool for HPV and HIV together? once in 5 years testing, all women and all across population, once in 5 years.
I agree with you, sir. Right now, there is a guidance for HPV, where anybody more than 35 years, they should go for annual pap smear. So this is only for women. But we are also now advocating, it's not only been limited to the women, but also to men. How women get HPV? They get from men. So you have to start, screening men also. And also, what about the vaccination? Now been recommended only for women. Why not for young boys? Where HPV start from there. I think it goes with that. Already we have this guidance, but it should be implemented. But again, we had these HPV vaccines. I was one of the investigators who conducted a clinical trial to show that HPV vaccine is safe and tolerable in immunogenicity. But on the other hand, because of another project, which has been hampered, so I think, I think this is a time that scientists, public health makers, policy makers, and the community have to sit together, effectively move forward with HPV in this country, because I 100% agree it's going to be a major killer disease in women. So, but on the other hand, it's not going to be tackled there. So here, when I'm talking about HIV, not only HPV, there are a lot of other things. We can screen them for diabetes, simple blood sugar, screen them for anemia, which is going to cause. They have been talking about malnutrition, a lot of other things can be coupled. I think today, HIV is teaching everyone a lesson where you have to link them to care, adherence, ethics, and everything we have been talking about. I think you're right. I think we have to bring other disciplines using HIV as an opportunity.
Questions? Other questions? Yeah. And then you.
Not really related to your presentation, but is VRG care, initiatives being taken on looking at hepatitis C infection among HIV positive people? What is being done?
Of course, we have been involved in hepatitis C work, almost 15 years, working with the injecting drug users, both in Chennai. Now we have got a very large program in collaboration with the NACO in Northeast India, as well as in Northern India, in Punjab, as well as in Northern Delhi. So we are not only looking at HIV, but also hepatitis C. And of course, we are involved in the advocacy of getting hepatitis C drugs in the country. Now it's been available. And 5 different companies have been involved. Now we started treating. I know still it's very expensive. Definitely we are involved. Also now we are involved in doing some studies, what best drugs with HIV drugs, that type of things we have been involved.
I would just like to add to that, along with VRG care, now NACO is taking up a study on national prevalence. Almost 500,000 samples which were taken for HIV sentinel surveillance and IBBS. Now they will be tested for hepatitis C. So we'll have very soon have in 3 months, 4 months, the national prevalence of hepatitis C in different groups. And WHO India has also taken up that advocacy for the treatment. And you would be delighted to know that Institute of Liver and Biliary Sciences in Vasant Kunj, which is an autonomous organization under Delhi government, has been taken up as a WHO collaborating center for Asia. This is the second collaborating center on hepatitis after CDC Atlanta.
Thank you.
Just a comment. Kumar was fantastic. It was very inspiring presentation. Actually, I would like to bridge your presentation with Paul's before, because Paul was actually telling us that the civil society is struggling for getting 3 days drugs, at least 1 month drugs, and instead of asking for supplies for 3 months. And then he talked about stockouts of viruses, which are very specific indications instead of monitoring. And you have been advocating for systematic monitoring with viral load. And we saw that the civil society was asking, just at least don't have stockouts of viral load, instead of asking why you don't test viral load. And because also Dr. Iwar is here, I would like to see the bridge between the civil society not asking don't take already what is there, but asking for more. And I would like to make this bridge.
Yeah, first let me comment on basically related to scientific facts, and I'll turn around to the policymakers to answer this, because I may not be qualified to do that. So here, any infectious disease, unless you measure that organism, anything you are doing, like clinical examination, CD4 count, anything is like an indirect measure. So we need to do this. If you don't do the viral load, you're not going to see anything. It's something like walking around with the scissors in a dark room. You do not know whom you're going to cut. So this is something where, same thing with antiretroviral therapy, we are doing this. We have to do this. But if you ask the policymakers, they're going to give a lot of other unwanted excuses. I'm sorry, but this is something they'll say, lack of technology, lack of money. And I'll tell you, when I returned from the US, after seeing all those patients are receiving sophisticated triple therapy, I never even dreamed that one day these drugs will be available to our patient. We used to smuggle drugs from the US to our poor patients. But today, have made it possible. If the Indian-made generic drugs have been possible and feasible, why not this viral load? I think this is time that we have to develop a partnership with the Indian generic companies to develop these testing kits or testing equipments and all this to do this. And that will be cost effective. Also, I know MSF is doing an efforts with Oxford Group, how we can do other point of care viral load diagnostics. We don't need to know as a clinician, this patient had 253,000 copies. I don't need to know. I need to know whether it is detectable or detectable, whether my drugs are working or not. Some sort of, bands or some type of dipstick. This is something that a lot of groups are doing. I think the minute when it comes, I'm sure it will be widely available. But now, at this time, I'll, turn around to Dr. Vivari to say that, what NACO's efforts on viral load with the current technology as well as to the stockouts. Thanks, Dr. Vivari, for coming to this meeting.
No, I specifically came to listen to you and to answer some of these questions. No, there is no denial about the science. There is no denial about the evidence that viral load is required. It is not there in the program, is a fact which is well known. It is only a targeted viral load when you have immunological failure, but you have an update. There are, of course, issues of technology, issues of funding, issues of suppliers not supplying drug kits, which Paul has very well known. Supply for 1 year, despite money being there. Roche kits to Indian program. Now the plan is basically, we are going to roll out in first line ART, moving away from targeted viral load, but definitely again there will be a phased rollout. And phased will be all pregnant women, all children, all people on ART more than 5 years, all those with immunological failure definitely, or immunological decline if not fitting into failure. And then this will be followed by all others getting into. So there is a 3-year phase plan, but again 3 years is too long a period. So it will be expedited as soon as possible, and India has applied to new funding model of Global Fund in which specifically it has been asked for, and I'm told it might be approved that viral load funding may come in. Also, now NARI is validating at least 3 point of care, including gene expert for doing viral load testing. So there are some new interesting developments in that.
I think there are some positive signs.
Okay, one question and then two.
Yeah, I have a question or one technical about the first line treatment. We have been many patients and many percentage are on the treatment with the tenofovir, lamivudine, and nevirapine. And we are now seeing some studies that tenofovir, lamivudine, and nevirapine combinations have poor virological outcomes and seeing patients with the early virological failure. So previously we have been stavudine, lamivudine, and nevirapine big group, and we phase it out into the tenofovir, lamivudine, and nevirapine. So, how do we do with those cohort? Right. Should we change to tenofovir, lamivudine, and efavirenz, or that's right. Opinion.
Yeah, I know that there are 2 case series, which has been published, which shows that the combination of tenofovir, lamivudine, and nevirapine, where there are higher chance of failure, right? So, but also, it's been said that if you use tenofovir, FTC, the tenofovir emtricitabine, with a nevirapine, probably will be better, right? So, I personally feel as a clinician, we had used it's such a wonderful drug. The first 2 weeks, if the patient get away from the toxicities like skin rash and hepatitis, they do extremely well. But I feel that these 2 studies, which showed more failure, that is because of adherence. If you put someone on tenofovir 3DC efavirenz, that's a single pill. They tend to take it. When you put on tenofovir 3DC, that will be a single pill. Then again, they have to take 2 different nevirapine pills, one in the morning, one in the night, which our patients sometimes tend to miss one of those. I personally feel because nevirapine is a very weak genetic barrier, even if you miss 1 dose in a month, there's a high risk to fail. So because of and not because of this particular combination, I feel because of the adherence, that has to be closely. So, but on the other hand, today guidelines are recommending, if you have going to put somebody on tenofovir 3DC nevirapine, is FTC is preferred. But on the other hand, guideline also says FTC and 3DC are interchangeable. So in our clinics, we have put many number of people on tenofovir 3DC and nevirapine when we change from stavudine-based regimen. They do well, but on the other hand, many of our patients, they like to swallow a single pill. I think put them on efavirenz-based. And if you look into the cost between nevirapine and efavirenz, it's almost averaged out. I don't think there's not a major cost difference. Even in the public health program, it's almost the same. So I think probably that's the best for our patients.
Okay. One more question.
Yeah, please go ahead.
I think very good talk, Dr. Kumaraswamy. But I just wanted to highlight my concern. I used to head the Indian VCT and PMTCT programs. We started the provider-initiated testing and counseling for pregnant women, and that strategy in PMTCT turned out to be, in the long run, a sort of a mandatory testing for every pregnant woman. So, this country, when you say voluntary HIV testing for the whole population, once in 5 years, there's nothing called voluntary here. It quickly turns out to be mandatory testing in a country which is having so much of stigma and discrimination against HIV positive populations. It's something which we need to think about with a lot of caution. My only complaint about those sort of things is that you have not analyzed the sort of high level of stigma and discrimination still prevalent in this country against PLHIV groups. So that needs to be very much underscored when you make such suggestions.
Yeah, I agree, I think probably we cannot sit tightly with what we had, a decade back or something. Today, there are a lot of countries have shown, where if you don't test people, you're not going to find them. You'll see them in your clinics only when they are sick with multiple infection, more cost to you, cost to the program, and cost to the individual by the time they would have transmitted infection to others. I think unless we start something, I use the word because we all know that by law, you can't do any mandatory HIV testing on them. You have to inform them. You don't need to have a written 100-page informed consent. You can do even an oral consent stating that I'm going to do HIV testing, and as long as you're going to keep it confidential, I'm sure our patients are not going to stop that. I think we have to find some ways to do this. I think in this country, in India, if we are not going to do this, I think we are not going to find them. So we'll still with the 1 million or 1.5 million, but on the 2 to 3 million people will be in the community without knowing. I think we have to find some ways, to do this testing. Some countries are successful already.
Okay, we'll take one more question. The gentleman with the microphone. That's the last question.
Thank you very much, sir. I would like to know your experience with regard to the side effects of the ARVs and how you are managing these things.
Right, I can give a lecture for a day on side effects of ARVs,
okay, fine,
but yeah, what I have done a lot. So what I can do quickly is, in the interest of time, we used a lot of bad drugs earlier, like stavudine, sidavudine, didenosine, a protease inhibitor called indinavir and sakinavir. These all drugs were more poison to our patients. So we have killed those drugs. Now the current drugs are less toxic, but some of those side effects with the current drugs are all not immediate term. These are all long term. For example, if you take tenofovir, on a long run, it produces renal damage, kidney damage. It causes thinning of the bone. It can produce fractures, and also it can produce a lot of other metabolic complications. Take efavirenz, of course, it can also produce giddiness. On a long run, now data coming up stating that it can produce a lot of neurocognitive people. People have suppressed viral load, but they have bizarre neurological complications. There are some protease inhibitors. Short term, they may not have any problem. On a long run, it can produce lipid abnormalities. So some of those drugs currently, who are developed, they may not have short term, in the sense 2 to 3 years or 5 years. They can have longer toxicity. We really do not know this is because of HIV or because of the drugs or the combination of multiple factors. This is something, there are a lot of studies going on. Currently, a lot of our focus in our studies are all to.
Okay, great. I think we have to end the session here. I'm just going to use the chair's prerogative to make a statement as well. I think you painted a very optimistic picture. I mean, a lot of progress has been made in the last 10 years, 13 million patients on treatment, Indian generic companies contributing in a big way. But all of that is also at risk at the moment with real pressure from European Union, the American government to change the patent laws. So very soon we could be in a situation where the second line, third line drugs could be frightfully expensive. How do you see that, and how do you think that NACO and the Indian government can sort of prepare for a scenario like that, if the Indian government decides to sort of, was.
Right. I was telling HIV disease is teaching everyone a lesson. Here again, a lesson for some of those generic companies who are not respecting patents and other things. So I think to combat this, now there are a lot of other collaborative programs that come. For example, if you take hepatitis C, we have been talking about, it used to call $85,000 to treat for, genotype 1, 12 weeks in the US. But today, the same drug, sofosbuvir, is available in India by Gilead Sciences, who are inventor, but through a partnership through Indian companies to something like 54,000 Indian rupees for the whole course of the treatment. So this is something where it had happened, some sort of a partnership where they had developed to sell the drugs here. On the other hand, these companies also given some sort of technology transfer to them in a scientific way, in a very ethical way to do this. I think same thing will happen to the antiretroviral drugs too. So what I heard is now this drug called dolutegravir, the thing that's going to be a new blockbuster molecule for HIV, for first line, second line, and new class of integrase inhibitor, once daily, going to be very cheap in future. So currently Indian companies cannot manufacture, but on the other hand, there is already a this type of partnership happen. So I'm very optimistic. And there are a lot of celebrity advocacy for HIV, so I'm sure this will happen over a period of time. I'm sure our patients will have access to treatment.
Thank you very much, and that's tea time.
Thank you very much. Thank you.
What?
Thank you very much. Oh, thank you. Very interesting. Thank you. Hope it was useful. I think we should do collaborative work with the MSF. And since you are doing a lot of work with
नाम इकबाल है। 4 साल पहले मुझे MDR-TB का शिकायत हुआ था, लेकिन मुझे पता नहीं था। 15-20 दिन से मुझे खांसी हो रही थी और अचानक से मुझे ब्लीडिंग होने लगा। जांच कराने के बाद में वहाँ पे पता चला कि तुमको TB है।
Okay, good afternoon. Welcome back from the break. So we are continuing with the last session of today, which is the fourth session, and this is also a special session because this session will be live streamed in the UK, in London. So what it means is that the people in the auditorium of the Royal Society of Medicine in London will follow this session, but also on the session will be live streamed. So I would also to welcome our audience in London and to the MSF Scientific Day in India. So the fourth session will start with introducing the chair, who is Dr. Suman Rijal. So can I ask Dr. Suman Rijal with the presenters to come up to the stage, please? And I'll introduce him, and then Suman will introduce the presenters. Suman Rijal joined DNDi in 2014 as the Managing Director of the Regional Office in India. Before joining DNDi, he was Professor of Internal Medicine and Chief Tropical and Infectious Diseases Center at BP Koirala Institute of Health Sciences in Nepal, where he has been a faculty member since 1997. For the last 15 years, he has been working in the field of neglected tropical diseases, particularly Kala-Azar. He coordinated several collaborative research projects and participated in the development of guidelines for the control of Kala-Azar in the region. He undertook his medical training in Kolkata, India, and the United Kingdom, and was awarded a PhD from the University of Ghent in Belgium. He's a member of several national and international committees, including the WHO expert panel on parasitic diseases, leishmaniasis, in Geneva, and the regional technical advisory group on VL elimination at WHO SAE, that's Southeast Asia Regional Organization. So I welcome everybody, and I wish you a good session. Thank you.
Thank you, Martin, for the kind words and introduction. I welcome you all here in India and also in London and around the world who are watching this program to this final session of the scientific program, first scientific program day in India. I am pleased to let you know that we have a panel of 5 speakers who are going to present to you on the different related to Kala-Azar control. Just to briefly introduce to you, as many of you would be aware, but some of you may not be aware, that India, Nepal, Bangladesh had started a Kala-Azar elimination campaign in 2005, and with a target to reach this elimination target by the end of 2015, which has been agreed to be increased to 2018. There has been quite a remarkable achievements to attain this goal, but there are still some major issues remaining. And the speakers today are going to discuss on some of the ways to challenge some of these important issues which still are needed to be challenged. For example, how do we reach our patients early? How do we manage PKDL? How do we manage HIV-VL co-infections, etc.? So I would like to start the session by introducing you to the first speaker, who is Manimoy Chakma, who is from MSF. He has been with MSF since April 2010. He's currently outreach supervisor in a post-Kala-Azar dermal leishmaniasis project in Mymensingh district in Bangladesh. He holds an MBA in management and is studying for an MPH at the American International University in Bangladesh. So he's going to talk to us on the active and passive case detection strategies for control of VL in Bangladesh.
Honorable Chair and distinguished guest, I thank you everyone and good afternoon. As I am introduced, so I'm going to present today active and passive case detection strategies for control visual leishmaniasis in Bangladesh. As we know all, Kala-Azar is a parasitic disease that kills if remains untreated. So in other words, it's a deadly disease also. More than 7,000 cases of Kala-Azar were reported till 2007 in Bangladesh, and since 2005 to 2007, around 200,500 to 3,000 patients were reported from specifically to and Trishal Upazila. Post Kala-Azar, dermal leishmaniasis develops in 10 to 15%. Pygidial patients serve as a source of infection if not treated. And pygidial patients usually do not seek care by themselves. Reason they are not aware about the disease, about the reservoir or parasites, and more importantly that they are not sick. They don't feel sick, so they just eating whatever they do just like a normal person. Out of 64 districts of Bangladesh, 32 districts are affected by Kala-Azar, and 70% reported from Mymensingh districts. In Mymensingh districts, actually 5 upazilas or sub-districts are endemic, Kala-Azar endemic, which are Phulbaria, Trishal, Muktagasa, Bhaluka and Gophergaon. Phulbaria and Trishal, which are hyper-endemic for leishmaniasis in Bangladesh, contributed 50% caseload. Why did MSF intervene? The conventional treatment was of Kala-Azar and pygidial was long and not safe. The treatment was SSG, and it was a painful injection, Kala-Azar, and also 120 days injection for pygidial. Passive case detection was missing a lot of patients in the community, especially pygidial. As I said earlier, that pygidial patients usually do not seek care by themselves because they are unaware about the parasites. If pygidial is not treated, then elimination of Kala-Azar will not be possible. Project location, this is the map of Bangladesh, and this is Mymensingh district, Phulbaria Upazila, Trishal Upazila. Phulbaria and Trishal Upazila are neighboring Upazila. Objective of the study was to determine the yield of active case detection in terms of number of cases of BL and pygidial diagnosed, and to compare it with that of diagnosed by passive case detection. Method: study design, this is descriptive study type. It was a traditional research. It was done in a program setting. That's why data were collected retrospectively. Study population: all Becher leishmaniasis and pygidial patients diagnosed between April 2010 to December 2011 in MSF Kala-Azar Treatment Center and also Health Complex of Trishal. Ethical approval: we obtained ethical approval from MSF Ethical Review Board. It was also approved by Ethics Advisory Group of the International Union Against Tuberculosis and Lung Disease. Permission from the Director of Communicable Disease Control, Ministry of Health, Dhaka, Bangladesh. Results: I'm showing the results by this bar diagram. Case diagnosed during April 2010 to December 2011. Becher leishmaniasis cases, and at the right side is the pygidial cases. So Becher leishmaniasis, by the active case detection, MSF diagnosed 1087 patients, which was 59% of total patients, and in detection area, which is case were reported 756, which is 41% of total patients. And in case of pygidial, MSF diagnosed by active case detection 1145 patients, which is 97% of total patients. And in Trishal, active passive case detection area, only 37 patients were reported, which is only 3% of total patients. And by outreach, MSF did the active case detection by a trained outreach worker team. And in case of visual leishmaniasis, outreach referred 195 patients, which is 18% of the total patients. But in case of PKDL, MSF referred directly 667 patients, which is almost 59% of the total patients. So this is very clear that active case detection, patients can be found more than the passive case detection. Conclusions. Successful active case finding strategy based on cluster approach. I should say something about the cluster approach. In the beginning of the MSF work, we started our active case detection by the door-to-door approach, but later on we had to switch cluster approach, considering the and the resource. So cluster, we defined it as 200 meters radius index case as a cluster. I visited almost every clusters more than 3 or 4 times. So an active case detection strategy at the sub-district level resulted in an increased yield of visual leishmaniasis and a much higher yield of PKDL. Limitations. We have some limitations in our study. Crossing over patients from one upazila to another upazila, one limitations. We have one different doses means detection area. The treatment was for strategy of detection can the Indian subcontinent. Recommendation Bangladesh to adopt active case detection for the diagnosis of leishmaniasis, especially PKDL. Thank you.
Thank you for a very nice presentation. I would like to open the floor for any clarifications on this presentation. Yes, please. Could you use the mic?
Thank you for the very nice presentation. Active case detection by its very nature, it is definitely going to give increased yield. But to me, one of the questions that lingers is what was the cost per patient identified? So would you be able to...
Sorry, it's not clear actually.
So were you able to estimate the cost per case identified by the active case?
As I said, it was an operational research. So we did it in a program settings as a program. MSF had own staffs who used to go to the outreach. So it was part of the program. So there is no actually specific cost related to it.
Can I have one more question? Yes. Okay. So the second question is in the government health program districts. Were these was there a dedicated program and workers dedicated only for control efforts? We have a dedicated tuberculosis program, or was it part of the general health setting over there?
It was actually especially for the Kalajor, because MSF started working there for Kalajor, and before MSF started, the Kalajor condition in that area was very poor, very bad. So as I presented that why MSF did intervention. So MSF outreach staffs, outreach team who were dedicated to go to the community level and find the patients in the community, and we referred patients to the MSF Kalaza Treatment Center.
Thank you.
Thank you.
Yes. At the back there.
Thank you for the nice presentation. My question is connected to the earlier question, but it's a bit different. My question is that what has been the sustainability strategy? Was there an effort to give the methodology to the government system to do the active case detection, and whether the government brought this idea of active case detection in their program? That's question number one. Question number two is just clarification. That I read through the document. What was the confirmatory test which was performed at the clinic? It says that the kit was used, Kit-39 kit was used at the community level, but what was the confirmatory test at the clinical level?
So I would like you to answer the second question and the clarification. The first question is very important, and we could take it up in the discussion, which will be.
So Kit-39 test is also done in the community by the outreach team, but when patients were self-referred, they came by themselves. Then in the clinic settings, we had a laboratory. There they were tested.
Okay, thank you very much. Actually, as you know that we don't have any vaccine for prevention of Kala-Azar, and the only strategy we have is early detection and appropriate treatment along with vector control. So this is a very important demonstration that if you have a strategy of active case finding, you will not only be able to take the reservoir out of the community and decrease transmission, but it also has a benefit effect on the patient that they will also have a better outcome of treatment, which has been well demonstrated. Thank you. So now I would like to invite the second speaker, Dr. Vishal Goel. Vishal is a medical doctor specialized in anesthesia. Since January 2011, he has been working as a clinical manager at the DNDI initiative. He has various global clinical trials, has a special interest in drug development, and is knowledgeable about the Indian health structure. He has implemented studies for VL involving government agencies and international partners at primary health center and district level in India and Bangladesh. Vishal is going to talk to you in the next 10 minutes on effectiveness of new treatment regimes for VL in Bangladesh and Nepal.
Thank you, Dr. Soman. Good afternoon, everyone. I'll talk on safety and effectiveness of new treatment regimes for visceral leishmaniasis in Bangladesh and India. Just to give you a background and introduction, so in last decade we have seen development of new treatment regimes from liposomal amphotericin B, paromomycin and miltefosine. So various new treatment regimes has been developed, like combination of paromomycin and miltefosine, ambisome. Maybe you need to check. Thank you. So new treatment regimes, that is combination of paromomycin and miltefosine, combination of ambisome and miltefosine, combination of ambisome and paromomycin. DNDI has conducted phase 3 clinical trials completed in 2010 on these new treatment regimes, which have been reviewed and then recommended by WHO expert committee and regional technical advisory group of WHO. So they also recommended to do a field implementation study at a primary health center level so that it can be adopted into the national program. DNDI conducted 2 studies on new treatment regimes, one in Bangladesh, another in India. Phase 3 clinical trial was conducted in Bangladesh to assess the safety and efficacy, and a pilot implementation study was done in India to assess the safety and effectiveness. The objective of these studies was to provide data authorities to provide evidence policy makers for replacing miltefosine monotherapy, which has been given for 28 days, with new treatment regimes and to be adopted in the national Kala-Azar elimination program. The rationale of this new treatment regime was to reduce the of the treatment, depending on the type of treatment. Like single dose ambisome, it's given for 1 day. Miltocin, paromycin treatment is given for 10 days. So from 28 days, it will be reduced to 1 to 10 days. Effects, improving the compliance and also preventing the emergence of resistant parasites. I'll start with a trial done at Bangladesh. Phase 3 open label randomized non-inferiority study was conducted in Bangladesh from 2010 to 2014. Treatment regimes were miltocin and paromycin combination for 10 days, ambisome and miltocin combination for 8 days, ambisome and paromycin combination for 11 days. They were compared with ambisome monotherapy. Their total dose was 15 milligram per kg. This study was conducted in 2 steps, step 1 and step 2. So in step 1, 120 patients they were enrolled, and at Medical College at Mymensingh. All these patients they were hospitalized for 15 days and treatment provided. The primary purpose of step 1 was to assess the safety of new treatment regimes, and then this data was reviewed by a Data Safety Monitoring Board, which gave a green signal to proceed to step 2. In step 2, 3 Uppsala health centers were identified, Trishal, Bhaluk and Gafargaon, where 482 patients were enrolled. Total of 602 patients were enrolled. Talking about the results, in ambisome group, 158 patients were enrolled, ambisome paromycin group, 159 patients were enrolled, ambisome miltocin group, 148 patients were enrolled, paromycin miltocin group, 142 patients. Initial cure was assessed at day 45, and in all the treatment groups except ambisome and miltocin group, the cure rate was 98%, but in the ambisome miltocin group, the cure rate was 94%. Final cure was assessed at 6 months, in which cure rate was 98% for all the treatment groups except ambisome and miltocin, in which cure rate was 94%. There was no relapse when during the 6-month follow-up period, but this is the conventional period for doing follow-up in VL studies. But then when the sites were followed, it was observed that there were 2 to 3 patients that relapsed, but that was between 6 to 12 months. There was no loss to follow-up in the study because we had a dedicated team of field workers who were employed for active case detection for all patients enrolled in the study. This slide talks about the adverse events. So approximately 60 to 64% of patients one adverse event in each treatment arm. There were total 12 serious adverse events in this study. 4 were drug related and 8 were related. There were 3 deaths that were not related to the study drug, and all SAs, whether related or not related, they were resolved. To conclude, all these new treatment regimes, they showed excellent safety and efficacy. Single dose of ambisome has been already adopted in the national guideline of Bangladesh, and combination treatment has been adopted as second option for treatment of VL. These new treatments, they can be safely administered at the primary healthcare level, as the treatment duration, more compliance, and less side effects. So ambisome treatment requires cold chain storage of between 2 to 25 degrees. So combination regime can be choice of treatment where cold chain cannot be employed. Now I'll talk about a study done in India. It was an open label, prospective, non-randomized, non-comparative, multi-center study done at public health sector from 2012 to 2015. Still the follow-up is ongoing. The objective of this study was to evaluate the safety and effectiveness when conducted in actual real scenario field conditions within the routine program settings, further generating evidence for the policymakers to adopt the regimes in the national program. This study was done in collaboration with State Health Society Bihar, Rajendra Memorial Research Institute of Medical Sciences based at Patna, MSF. Here I'll mention that at all sites, patients were diagnosed, investigated, and treated by the government, doctors, health staff, except one site, Hazipur District Hospital, where patients were treated by MSF team, where they have experience of treating VL patients since July 2007. In this study, it was conducted in 2 districts of Bihar, Vaishali and Saran. In Vaishali district, Hazipur district hospital, single dose ambisome treatment was given. Patients were hospitalized and treatment provided. And 5 PHCs of Vaishali district, ambisome and miltacin combination treatment was given for 7 days on outpatient basis. In Saran district, at district hospital as well as PHCs, combination of miltacin and paromycin was given for 10 days. At district hospital level, majority of patients, they were hospitalized and then treatment provided. But at the PHC level, treatment was done on basis. RMRI was one of the site where all the treatment were given, and mainly the complicated patient, they were referred here. From each side, whether it's for Saran or Vaishali at PHC or district hospital, all the 6 severely complicated patients, they were referred to Hazipur district for a saving treatment, and then they received, majority of them received single dose ambisome. Total of 1761 patients were treated in this study. Initial cure was assessed at day 10. Each arm had cure rate of around 99% at day 10. Till date, 1591 patients has completed 6-month follow-up. Rest of patients follow-up is still ongoing. Final cure at 6 months was 93% cure rate in single dose ambisome arm, 89% in ambisome miltacin group, and 97% in miltacin and paromycin group. Relapse, there were 4.5% relapse in single dose ambisome group, 4.8% relapse in ambisome miltacin group, and 0.5% relapse in miltacin paromycin group. Here we can see that, like I mentioned earlier, so complicated patients, they were treated in single dose ambisome group, so maybe having a higher number of. So the national program recommended to do 12-month follow-up of these patients to generate evidence on relapse. So in January 2015, 12-month follow-up was started in this study, and this till date it further yielded 6 relapse in single dose ambisome arm, 6 relapse in ambisome miltacin arm, and 5 cases of picadil in M+P arm. Talking about adverse events, so there were around 13% of adverse events, 13% of subjects had at least 1 adverse event in single dose ambisome arm, and 22 to 25% in other 2 arms. Total, there were 5 serious adverse events in this study, ambisome group. 2 were drug related and 3 were non-drug related. So they were all resolved. Talking about limitations of the study, it was a recommendation by DCJ regulators of India that children should be treated at district hospital level only, and so children they were not treated at primary health center, and they were treated at only adults were treated at PHC level, and higher number of severely complicated patients, they were treated in only 1 arm, that is single dose ambisome arm. To conclude, all treatments except ambisome miltacin group, which had cure rate of efficacy of 94%, they showed excellent safety and effectiveness when conducted within the public health sector setting, within the national program settings. Based on the data, Indian national program, they revised the national policy for treatment of VL in last year, 2014, in which single dose ambisome was considered as first option for management of VL patients, and combination treatment has been adopted for treatment of VL patients. So combination regime can be choice of treatment at sites where cold chain cannot be deployed, maybe in the case of ambisome. There is need for establishment of active pharmacovigilance center, public health care facilities, and systematic collection of the data at all the sites, and integration with the national pharmacovigilance program. So lessons learned from both the studies, all these new treatment regimes and single dose ambisome, they are safe when conducted at public health sector level, and it is very much feasible to implement these regimes at large scale in conventional doing follow-up is 6 months, and relapses continue to occur beyond 6 months, so there is need to follow patients beyond 6 months, maybe till 12 months to have more evidence. Cohort event monitoring should be strengthened at all sites in India and Bangladesh to document long-term outcome data to generate evidence on relapse, PKDL, and treatment failure. So important thing is there is a need to have a dedicated field workers. Like in these studies, there were health educators which did detection and involved ASHA workers from the field to do the ensuring less loss to follow-up in the studies. So I'll acknowledge all the collaborating partners, and special thanks to all the doctors, nurses, technicians, all the staffs involved in the study, without whom this study would not have been possible. Thank you.
Thank you, Vishal. We have time for 1 or 2 questions for clarifications of the study. Yes. Yes, yeah.
I have a question from the online audience. Having the single dose ambisome based treatment is already included in guidelines in Bangladesh. Why should the MOH take up the proposed treatment of D&AI? This is someone called Ashish Kumar, who is based in Bangladesh, MSF. I think this question is for you.
Yeah, single-dose ambisome has been already adopted. So we started this study in 2010. So in between, this was changed and national policy was changed, but we have to complete the study. And then in the study, there were other treatment regimes, combination treatments. So now recently it has been adopted. Treatment, they have been adopted as second line option.
Back there.
Thank you, sir. I'm H. Kumar from Energy Media. My point is that I have no question or observation that in the context of safety, health and environment, one issue is climate change in the healthcare system, that is called ecosystem. In this, medicine is there, but the ecological footprint decreases. जल और वायु, जब जल भी शुद्ध नहीं होगा, वायु भी शुद्ध नहीं, तो how to make the increase in the process of immunization of the body? शुद्ध वायु भी शुद्ध नहीं मिलेगी, जल भी शुद्ध नहीं मिलेगा, तो how to increase? The question is, prevention is better than cure. How to increase the ecological footprint of the
Okay, thank
areas?
you, thank you, sir. I think we can consider this later on. Yes. One last question, please.
Vishal presented his data very succinctly. Just one question. You said the combination was less superior as compared to the single dose. You have any good reason for it? Because 2 combinations you have used, both appear to have inferior to a single drug, ambisome. You used both amb and miltefosine, and was it a randomized trial? Or how did you determine who is severe and who is not severe?
So you're talking about Bangladesh study?
I think both other study also you use, no? In the Indian study
So
also
in Bangladesh, it was only ambisome and I think it's a miltefosine group which had efficacy of 94. Rest all they were around 98%. And there was a study conducted in 2010. So in which phase 3 clinical trial in which combination treatment they were compared, and efficacy was also 97%. And then the ambisome monotherapy study was done with Dr. Shyam Sundar, which had efficacy of around 95.6%. In this study, being done in India over here, so efficacy of 93-94%, and ambisome miltefosine group, it has efficacy of 89%, and paromycin miltefosine has 97%.
It's less, no? Ambisome miltefosine,
Yeah.
that's what I was wondering.
Yeah, it's less. Maybe, sir, ambisome miltefosine, it's like dose of ambisome in single dose ambisome is 10 milligram, and dose in ambisome it's 5 milligram per kg plus 7 days of miltefosine. Maybe the duration of miltefosine, it has to be increased.
Thank you, sir. I think there are a lot to ask. I would like to request if you could keep your questions for the last half an hour, which we'll have for the discussions, if you don't mind. So I would like to move on to the next presenter, and it is Dr. Temi Sunyoto. Temi is a doctor currently working with MSF as a medical coordinator in Delhi. She holds a MPH from the Institute of Tropical Medicine in Antwerp and completed a medical training at University of Indonesia in Jakarta. She has previously worked for the WHO and had worked for MSF since 2005 in numerous countries and settings. She has a special interest in epidemiology and neglected disease and has published on VL. So Temi, I invite you to present on combination treatment for VL patients co-infected with.
Okay. Good afternoon, everyone. Thank you very much, Dr.
introduction. So this afternoon, as you know, is a session on leishmaniasis. I would like to bring your attention to one subgroup of the visceral leishmaniasis patients, or Kala-Azar, which are co-infected with the human with HIV virus in Bihar, India, which we have treated with a combination treatment. So I will not repeat what has been said before by Manik Moy, that VL or Kala-Azar is a neglected disease, meaning it has a very limited treatment option. It affects the poorest of the poor in the rural areas. And the elimination goal that is in the Indian subcontinent for India, Bangladesh, and Nepal is because actually we found that only one parasite is causing it, the Leishmania donovani, and it's transmitted by sandfly, the bite of a female sandfly. So, as you know, I mean, VL in general, the whole world is between 300,000 to 3 to 5 lakh cases per year, but 90% are happening only in 6 countries, which is India, Bangladesh, Sudan, South Sudan, Ethiopia, and Brazil. However, we know that even in India itself, not everyone knows about Kala-Azar because there's only 4 states that are endemic for the disease. Bihar is actually one of the epicenter. You know, Bihar is one of the massive states in India with population more than 100 million people, and it contributes to more than 50% of the global burden of VL. So if you look at the number that is reported by National Vector-Borne Disease Control Program of India, which range between 40,000 in 2011, more close to 80% are only reported from Bihar. The other states like Jharkhand, West Bengal, and Uttar Pradesh are contributing very small proportion. However, I would like to note as well that this elimination also, we note that in the last seen a declining trend in the epidemiology, that we see the number from 2011, if you see, was 33,000 reported cases from India, and then it goes down to 20,000 in 2012, and last year was less than 10,000 patients are reported. Now to bring to the other side, which is the HIV burden in Bihar itself. This is, as I said before, has a massive population, and it's also out-migration, meaning a lot of people from Bihar are working in other states in India. The prevalence generally is considered as low, 0.2%. However, it's one of the few states in Bihar with the prevalence are increasing, and these are the statistics that are officially from NACO, that this number of people living with HIV/AIDS are served with only 14 ART centers, and also they're probably reporting around there's between 100 to 300,000 people living with HIV/AIDS in the state. My apology that actually the first line treatment that are now being used as the NACO guidelines is, as we know before, it was zidofudin and TDF, lamivudin, and nevirapine, and efavirenz. So this is not correct. Now we'd like to bring on attention why this co-infection is important. So first of all, we don't know really the magnitude of the problem. So there is limited evidence on the prevalence of HIV/VL in tests that we use are less sensitive, and as well they have a atypical presentation, because normally Kala-Azar have a prolonged fever, splenomegaly, and all that, which is not always the clinical manifestation subgroup. And also it has been very well established in the evidence that they have a worse treatment response with the options, with the treatment that are available. So they have higher risk of mortality, so they die much more, and they relapse much more, meaning they have repeated episode of VL throughout their life, let's say. So there's a recent study, I will come back to that later, that when you compare to the HIV negative patient, for sure the rate of mortality and is much higher. And until recently, they're also known as a high-risk group of HIV, meaning the voluntary counseling and testing are not routinely offered to them. And as I've mentioned before as well, actually in India, since October 2014, the single-dose AmBisome has also been adopted as first-line treatment for primary Kala-Azar. However, this regimen is not suitable for this co-infected group because it's kind of low dose. So for the moment in India, there is no national guideline available how this co-infect actually, but there look in. So we work in Faishali. We have been adopting the national but the higher gram for between 2012 close to 10,000 patients. They were given the same regimen, which is 20 to 25 milligram per body weight. So the combination treatment that I'm going to speak here is actually a combination between 30 milligram of ambisome, so it's divided in 6 doses, and plus 14 days of 100 milligram of miltefosine. So the objective is to determine the long-term outcome, because this is the evidence that are missing. What are the outcome in the longer term for this particular subgroup? So this is observational study, retrospectively analyzing routine program data. We diagnose VL using the RK39, and whenever feasible, we do the spleen and bone marrow aspiration. And we do a monthly follow-up of the patients. So this study fulfilled the criteria of exemption of MSF Ethical Review Board, and as well the use of the combination treatment itself has been approved by in compassionate use based on expert opinion, and as well by RMRI Institutional Committee. So when we look at the results here, we saw that, okay, throughout from July 2012 until September 2014, we have 102 patients. Majority are males, and we see that quite high proportion, they seek treatment beyond 4 weeks. Almost half of them already has previously treated with VL with various regimen. They have concurrent TB, and almost half of them, they know that they were HIV before, meaning they were actually already somehow managed in the ART center, and they were referred to us for the VL management. So when we look at the mortality analysis, we saw among the 102 patients, we have 16 deaths. Maybe just to say that the mortality at 6 months is quite high at 11%, at 12 months is 14.5%, and 18 months at 16.6%. If you see from the graph, you saw that actually there's quite high risk of early mortality 6 months, although later on it reached kind of plateau. Risk has and not have it. Now time the risk to relapse is at 6 months is 2.5%, at 1 year, meaning test of cure, like at 6 months we don't test parasitologically for the additional study for co-infected. We include
encouraging
try to tackle both men from the HIV. The that we
any such things that you have observed in the
You want to answer?
I would have that have a before 200 prime of immunocompression.
Just for your information, experience, but then supposed to say in the management.
Myself, some patients, and even the convent. Before 2000, one single case dealing is waived by our institutional ethical committee. In the past 7 years, these are the admission rate: 4459 HIV patients, 408 VL patients, and 24 VL HIV. The VL patients diagnosed to be HIV infected after admission, and almost majority of the patients had previous relapses. Most probably five had 2 relapses, 7 had multiple relapses. And look, from 2010, the HIV is gradually, blue is the HIV is gradually steadily decreasing, VL is stiffly decreasing, whereas HIV VL from 2010 is increasing and now has reached a plateau. If you compare the baseline characteristics of HIV VL and the mono-infected VL, I have collected data of a historical cohort of 120 VL patients and compared with the HIV VL, the significant difference you look in the age, whereas in VL it is 18 years and HIV VL 38 years, and in the spleens, hemoglobin 7.1, it is severely, hemoglobin is low in comparison to significantly low in HIV VL, and other features like hepatomegaly, liver size, etc. are same. K39 positivity in serum is more than 90%, and with RK39 positivity with the testing with urine, you all know that it can be tested also with urine, it is more, 23 was positive with 24. CD4 count was 1, less than 200 CD4 was in 87.5%, and 3 patients presented with atypical features. The predominant clinical picture was diarrhea in 2 and cough with respiratory trouble in 1. And diarrhea not controlled with antiprotozoal, antibiotic, and ultimately anti-leishmanial drug given to control. Treatment outcome, amphotericin B was given a total 20 mg per kg, 14 patients lyophilized, 10 patients liposomal. End of treatment cured at 96%, 1 patient died while on treatment. HA hurts completion of total dose. It is our policy to give after completion, after control the treatment, infection, and then. Another factor is that we are giving tenofovir for HIV. And amphotericin B is nephrotoxic. Tenofovir is also nephrotoxic. And look, there was 2 patients with respiratory involvement, GI involvement. You give heart, immunity will be raised, and theoretical chance of IRIS. So our policy is to complete the treatment of VL. It is easy to initially cure the patient, then start HIV. And if CD4 rises, then relapse rate will be low. We have given secondary prophylaxis to 12 patients, that is 52%, with 1 mg per kg monthly amphotericin B, and the result is spectacular. In the secondary prophylaxis group, no relapse, no death, whereas in the no secondary prophylaxis group, 8 patients relapsed over 1 year, 5 patients died over 1 year. The difference is highly significant. So ours was 23 patients, 1 patient died before treatment. Secondary prophylaxis given in 12. At that time, the mean CD4 count was 122. No prophylaxis group 11. Mean CD4 count was 126. 6 months cure rate, that is end of treatment and follow up for 6 months. Here it is in the secondary prophylaxis 12. After CD4 steadily increased from 122 to 180. And what is the problem? And in 1 year and 2 years follow up, CD4 then 378 after 2 years, after 1 year, and no patient relapsed. In the no prophylaxis group, in the 6 month cure rate 3, 8 relapsed at least 1 6 months, and within 1 year, multiple relapses in 5 patients and they died. Amongst them, 2 stopped ART, and we could not follow up 3 patients. They are lost to follow up. In Kaplan-Meier analysis, you can see the graph. There is definite survival advantage for the secondary prophylaxis group, and with the Cox regression analysis, of multiple variables, we found secondary prophylaxis is the most robust, most important factor to prevent relapse and death. Baseline CD4 is also important. If you look at the picture, no prophylaxis group, CD4 was, when those patients were not on secondary prophylaxis, but CD4 rose after ART, the CD4 was 175, they did not relapse. Though the sample size is very low, but those where CD4 steadily decreased from 126 to 108, and then no result. Their relapse and death were high. So limitation, our limitation is that our data was not computerized, detailed clinical laboratory data of every patient were not available. Some data had to be eliminated from the analysis, as very few data were available. Prospective analysis, very small cohort size, some no secondary prophylaxis may be due to other associated infection because of declining CD4 count. Detailed investigations were not always available. And Burja et al., they have studied with, most probably Sunito presented it, 159 patients, they have already seen it. So what do we learn from this, from my experience? It is increasing, it is deadly, if not deadlier than VL at least. Early initiation of ART appears to be promising tool. Along with the secondary prophylaxis against VL needs to be considered with seriousness and generation of evidences against opposition of eminences. Those of the eminent physicians do think secondary prophylaxis may give rise to resistance because of giving lower dose, but we need larger studies to establish our hypothesis. That is a very important tool. Personally, as a clinician, I think giving secondary prophylaxis, giving life to the HIV VL patients. Thank you for your patience.
Thank you, Dr. Goswami. Now I open the floor for any clarifications.
So thank you, sir. That was a very good presentation, and it's really a big issue, treating the relapse again and again. It's quite inspiring about the secondary prophylaxis. But you've not mentioned, like, how long did you go with this secondary prophylaxis?
Secondary prophylaxis is usually given till CD4 rises above 200 to 250, and it is sustained and maintained over 200 for 6 months at least. Then we have stopped secondary prophylaxis.
So you mean to say that after you started?
That is the reason. Actually, so we have to continue amphotericin B monthly for 1 year to 1.5 years at least to get CD4 above 200.
Yes.
That was also the reason why we select. If we go on giving 5 mg per kg liposomal amphotericin B monthly, then the cumulative toxicity will give rise to permanent renal injury.
Yes. Thank you, sir.
I think.
Yes, thank you very much. Now I would like to invite the last speaker of this session, Dr. Saqib Burza. Saqib has been involved with MSF since 2003. Originally trained as an anesthetist, he now works in public health and community medicine. He has previously worked in Sudan, Gambia, Palestine, Uzbekistan, Afghanistan, and India. He is currently completing a PhD in VL at the Institute of Tropical Medicine at Antwerp, while researching the economics of NTD, neglected infectious disease. Saqib is going to talk on PKDL treated with amphotericin B.
Thank you, Saman. First of all, thank you all for staying. I was expecting most of the people to disappear by now, so well done for sticking it out. I'm going to talk today, it kind of fits nicely with the other presentations that we've had. This is one of the subsections of visceral leishmaniasis that's not very well known about to the general public. As Temi was saying, even VL isn't particularly well known throughout India, let alone the world. It's one of those things that you sort of remember from medical school, but not really much about. It's something to do with the sandfly. And this is something that's even smaller, so to speak, than that. So PKDL, post-Kala-azar dermal leishmaniasis. It's essentially a complication related to visceral infection with visceral leishmaniasis. It's common in areas endemic for VL caused by L. donovani, and it's characterized by a skin rash after an episode of VL, although there is some evidence of it can happen concurrently as well. However, it poses quite an interesting dilemma for us because the patients are typically not ill. It's not a fatal disease, and the main issue part is that of aesthetics. However, at the same time, based on existing evidence, it's a substantial public health problem. Why? Because it's a major reservoir of L. donovani. So when we talk about elimination, which is something that my colleagues have mentioned a few times, in VL that basically means reducing the incidence of disease to less than 1 in 10,000. Not to be confused with interruption of transmission, but elimination as a public health problem. However, once we get the numbers down, sustain that level at a low level for the next 5 to 10, 20, 30 years. If you have this major reservoir remaining, then of course that's going to be very difficult to do. So from the public health perspective, it's imperative that we treat these patients. However, at the same time, it's not considering the patients from the aesthetics aren't actually ill. There's a burden upon the healthcare provider to make sure that whatever treatment is provided is a safe treatment with minimal side effects or compromise for the patient themselves. Now, unlike in Africa, in South Asia, PKDL isn't thought to self-heal. In Africa, what we see, the same parasite, but we see that about 50% of cases do tend to self-heal by 6 months after the onset. Say in South Asia, if we're looking at interrupting transmission, then we do need to focus on treating PKDL. And just numbers-wise, about 5 to 10% of VL cases are thought to go on to develop PKDL, depending partly on the treatment used, giving us an incidence of about 4.8 per thousand, with an interval of between 0 and 3 years after suffering the initial VL infection. So, as I was saying, it's really a neglected disease within a neglected disease. We don't really know very much about this condition. We don't know really why it happens. We have some ideas, some immunological factors that are being looked at closer and closer. We don't really know what the pathogenesis is. We don't really know what the risk factors are. There have been some studies, but primarily based on the very small sample sizes, it's very difficult to establish any patterns or causality. To pick up on I think one of the questions from Vikas, which was about diagnosis. Accurate diagnosis is really a challenge. Presently, we don't really have any very sensitive and specific tests. Normally, PKDL is diagnosed by the use of the RK39 serological test. However, this is a test that any patient who has VL will test positive for different periods of time following the infection. So if a patient presents with a lesion that may look like PKDL, but they've had a previous history of VL, their RK39 test may be positive, and that doesn't really help you with regards to diagnosis. Parasitological visualization, so basically sampling the lesions and looking at the lesions looking at the sample under a microscope, is the gold standard test. However, for the majority of lesions, which are macular lesions, basically, I'll show you some pictures in a minute, the sensitivity is very, very low, 30 to 50%. And most importantly, it requires experience and skilled human resources, which aren't available in the majority of the sites, and certainly not in the public, at the primary healthcare level. Secondary to this, there is very little evidence on management. We don't really have any idea about how well the current drugs used for visceral leishmaniasis, of which there are very few, how well do they penetrate the skin? So when it comes to estimating doses, duration of treatment, it's really just guesswork. How much does a drug injected intravenously, does it access the epidermis? The same thing goes for oral drugs, topical drugs as well. And there's also no evidence on the endpoint of treatment. We don't know when to stop treatment. We know that after some time, usually between 1 to 3 months, there is a response following treatment. But obviously, wait for complete clearance of all the lesions? Do you wait for partial clearance? Do you wait for a biopsy to show no parasite? We don't really know. So some pictures here about to kind of show you what PKDL looks like. This is the macular form. Basically, look very easily confused with vitiligo. Can be confused with leprosy as well. The difference being that you have some sensation. We have papular lesions here, slightly raised lesions, which are more disfiguring, and then finally we have nodular or tumorous. 4 minutes, okay. Tumorous lesions here. If you actually look at the very back page of the Scientific Day guide, you can see a nice picture of a lady who's pre and post treatment. And this here is the same patient that you can see how once the lesion resolves, how it looks. So, what is I'm going to focus now on the existing evidence for PKDL. What is the existing evidence? Essentially, in South Asia, there's only one randomized controlled trial to date, comparing oral miltefosine 100 milligrams for 8 weeks compared to 12 weeks. The result was that it was a 93% cure rate at 12 months. However, this was based on a sample size of 15 cases. No children were treated, no macular PKDL, which forms the vast majority of cases, and there was no safety data post 4 weeks. In addition to this, considering it being a very aesthetic condition, a lot of the people who self-present for treatment are females. And in women of reproductive age, you need to have this treatment safely, you need to ensure contraception for above 7 months. And of course, for any treatment that you're giving an oral treatment for 12 months, how many of us take treatment, complete a course of antibiotics? Taking oral treatment for 12 weeks is also a major issue, and it may lead to resistance. Essentially, the regimen poses high direct and indirect costs, both the patient and the healthcare system. So, what was MSF's approach? It's really started in the use of ambisome in PKDL started in Bangladesh. The diagnosis was clinical, so we weren't doing samples and microscopy as a standard. Essentially, clinical symptoms, i.e. the rash or the lesions, a history of VL and a positive RK39 test. Treatment was given with 30 milligrams total dose ambisome. That's 6 doses of 5 milligrams twice a week in an ambulatory fashion. Initially given in Bangladesh, they treated, I think, 2,500 patients, and then started in India after a WHO consultative meeting in 2012 recommended it as a treatment option. However, subsequently, the treatment in Bangladesh was reduced to 15 milligrams based on some safety concerns, which we'll talk about in a minute. As I say, it was an ambulatory treatment over 3 weeks, so patients could go home and come back in to receive their treatment. And the endpoints was at 12 months, whereby photographs of the patients and the lesions pre and post treatment were taken, and then assisted in validating the scoring from the clinicians themselves. In particular, safety data was monitored closely, particularly hypokalemia, because of reports of rhabdomyolysis from the larger cohort that was initially treated in Bangladesh. So, just to give you some examples of some details on the types of patients that we saw, as you can see, it's quite interesting. We have 97% of patients in Bangladesh presenting with macula. That's the vitiligo type condition. Equal spread between males and females, and of the patients had ambisome as a previous treatment for their VL prior to developing the condition. And the average onset of symptoms, the median was 6, with a mean of 15 months. In Bangladesh, in India, it was quite different. We had a lower prevalence of macular PKDL with much more mixed morphology. The average age was younger. We did see a high number of females, and the treatment of choice, let's say the historical treatment for VL was SSG above all of the other treatments, and the median time was slightly shorter to presentation. So, looking at effectiveness and safety outcomes at 12 months, so far 50 patients have completed the 12-month follow-up. Of these, 84%, 42 patients showed substantial or complete cure. In Bangladesh, of the 88 patients completing 12 months follow-up, 80% showed substantial or complete cure. However, there were some safety concerns raised in Bangladesh. Now, we're not really sure why, but they weren't seen in India, but they were seen in Bangladesh. There was a concerning incidence of severe hypokalemia in the Bangladeshi cohort that we didn't see in India. The same thing went for mild and moderate as well. Fortunately, none of these patients had any other sequelae. None of them developed rhabdomyolysis, and all of the hypokalemia resolved without incidence. However, reflecting the safety concerns in Bangladesh, the treatment was switched to 15 milligrams per kilo. So this was a prospective observational study, the primary objective of which was to evaluate the effectiveness of the new regimen at 12 months, 3 milligrams per kilo given in 5 doses over 2 to 3 weeks, with a particular focus on safety, specifically looking at hypokalemia, and looking at which point in time did the lesions start to respond to treatment. A good sample size, 275 cases, is if you speak with anyone familiar with PKDL, it's really quite a large sample size. And here are the results so far as of March 2015. We don't have the 12-month results yet. That data collection has just started, but 73% of patients showed a substantial or complete improvement by 6 months. Definition of substantial is between 80 and 99% improvement, and complete, of course, is 100%, complete clearance of lesions. Excellent safety data, no severe adverse events or severe hypokalemia. There were some adverse events which are quite common to ambisome, such as lower back pain and shivering, but nothing, all of which resolved by themselves. As I say, 12-month data collection has already started. Number of limitations with the studies. It's very difficult to standardize assessment of improvement. Patients have lesions on their hands, their arms, their legs, their faces. So each part of the body resolves at different speeds. In addition to that, some clinicians choose to feel that the classification of complete cure should be when you have complete repigmentation of the lesions, where others feel that actually when you show a substantial amount of resolution of the lesion with no parasite on biopsy, that can be defined as a complete. Also, cross-checking of the clinician's decision-making, there was some regularity in the quality of the photographs in the 30 milligrams per kilo group. However, this was improved in the 15. And of course, finally, the inclusion was clinical assessment-based. So if you did come in and have your parasite, if you did have a skin biopsy and there was no parasite, it did not preclude inclusion. So there is a possibility that a number of the patients didn't actually have PKDL and had other conditions. So, in conclusion, 30 milligrams per kilo appears effective in the treatment of PKDL. Seems to be safe in India. We don't know why, but it has shown safety concerns in Bangladesh. However, 50 milligrams per kilo appears safe, tolerable, and showed good adherence for these patients. The effectiveness appears to be similar to the higher dose, pending the 12 months results becoming available. And essentially, there's an urgent need for course treatment options for PKDL. Ambisome can be can be considered an option in this case, with a caveat that it still requires the more difficult administration, and of course any monotherapy being given for a condition runs the risk of developing resistance. And that's it.
Before we have the general discussion, I would like to invite questions to Saqib for clarifications on his presentation.
For the hypokalemia, did you have centralized laboratory monitoring between the two sites? Quality control.
And yes and no. We have a reflotron that has quality assurance done and is maintained. We don't have a regular annual quality control check though. No, we don't do that. One question I think I'd like to address about the use of miltefosine. Obviously, Ramesh, you mentioned why does the combination not work, and it's somehow important in PKDL as well, because what we've seen with more recent pharmacokinetic studies is that actually the allometric dose that we typically use in children with miltefosine isn't really appropriate, and that's led to an increased number of relapses for VL in children. Now, that also, we think that's one of the reasons why the results of the pilot study were slightly lower for that ambisome miltefosine arm. But what we've also seen in PKDL, if you in children, then we don't really know what dose to use because the current dose hasn't been tested on any child.
Thanks, Saqib. I think we had a very nice presentation from the 5 speakers. Just to recapitulate, we had a presentation on strategies how to get a better yield of patients by having active case finding follow-up, and which was demonstrated in Bangladesh. The difference they saw compared to the sites in the passive case finding system, which is actually, as I mentioned, very important if you are going to decrease or control the transmission. We had a presentation on demonstrating the efficacy, effectiveness of newer regime of treatments, including ambisome and combination therapies, both in Bangladesh and India, and the benefits of these new regimes compared to what we have been using, basically monotherapy for prolonged periods of time, with the risk of developing resistance. Just to let you know that there are very few drugs, new chemical entities in the pipeline for Kala-Azar, and I think we'll have to live on with these currently treatments for quite some time. So there has been how to make treatments which we can preserve for a long period of time, because we, in the past experience, for every 10 years or so, we have been having losing the drug. For example, antimonials, when they stopped working, we pentamidine, which didn't last very long, and then we moved on to miltefosine, and miltefosine, there's the drug has not been effective. The efficacy has come down quite rapidly over a period of a decade in India, and also been demonstrated in Nepal and Bangladesh. So now, then we moved on to more difficult areas. For example, HIV/VL co-infection. It's not very new for people for, say, South Europe, where they have experienced pre-ART era. They had been having a lot of co-infections, and they have a lot of publications. But with this different species of leishmania, the response to treatments and the doses required are quite different. So there is a need to understand what works here in our part of the world. Just to give you an example, ambisome, which we consider is a very good drug here, it doesn't work at all in Africa, and they don't use ambisome at all there. So similarly, then last and not least, Saqib presented the PKDL and the challenges of, and he had a very nice introductory slides on what is the importance of PKDL and what are the challenges we have. So on this note, I would like to open the floor for discussions. We have about approximately 20 minutes or so, and I would like to ask you to direct the questions to any particular speaker if you would like. Yes. I think we have some questions online, so we'll take that first.
This question is for Temi from Raffle MSF. Do you often or at all see cases of immune reconstitution disorder among the HIV/VL patients?
I think it was briefly answered before by Dr. Rijal, actually, that the VL as such is not recognized as this immune reconstitution immune syndrome. And especially actually in India, we don't have much evidence about it, in the sense that the cohort that I presented is probably the largest cohort that we collected. So we need larger study to follow up later on to establish yes or not it's iris phenomenon. Maybe Dr. Rijal, you want to add something?
As you rightly pointed out, we'd have very little evidence from this part, but if you look at from reports from, say, from Africa, where they have a larger cohorts of HIV/VL co-infection, they have not had much problems with iris with regards to treatment with HIV/VL co-infections.
One more. I think this again is for you, Temi. It's from our MSF OCA. Why not routinely treat Kala-Azar with HIV even when the CD4 count is good? Will it be unethical?
Can you repeat?
This is verbatim. Why not routinely treat Kala-Azar with HIV when the CD4 count is good?
Well, actually, that's what we call for. That's what I was speaking about, having VL as finding disease, because when you have a stage 4 disease, meaning you are eligible for ART regardless of CD4 count. And actually, I didn't have time to elaborate on that, but in September 2014, when NACO meeting with WHO, with NVBDCP, sorry, when we proposed our recommendation, there was a consensus to say that all Kala-Azar patients with HIV should be started on ART regardless of CD4 count. So yes, Basically, that should be the way to do.
Yeah, I am Professor Sarman Singh from AIMS, New Delhi. My question is basically to Dr. Goswami and then to the. He said that prophylaxis. Dr. Suman Rizal very nicely said that, in any case, we have, very less armamentarium now left with, and only amphotericin is, with us. And now if you give prophylaxis for, couple of, several months rather, don't you think that, you are encouraging the resistance to amphotericin also, so we will have nothing left?
This is an issue of debate. These are two schools of thought. There are two schools of thought, giving prophylaxis or not. This is my experience. Though the small cohort, I have saved my patient with this regimen. This is a small cohort, but a prospective randomized control study is to be done to see. And for secondary prophylaxis, you give secondary prophylaxis for toxoplasmosis, you give secondary prophylaxis in HIV patient, you give secondary prophylaxis in atypical mycobacteria with azithromycin, you give secondary prophylaxis in tuberculosis with single lineage. So there is in medicine, in clinical practice, there is a long history of giving secondary prophylaxis in various drugs, and it has been proved. It is my experience over a period for a small number of patients. Up to you, to the scientific world, to determine whether to accept it or to reject it. But my experience is such.
I think that's a very, very valid and important question, and I think that we should keep in mind. Now, there are two issues here. One is, the presentation from TEMI, which shows a pilot demonstration of a combination regime. And if you compare the results of this cohort although they have a very low CD4 count, they have a very good outcome. I mean, in fact, if you look at the cohorts from the other regions, they have a very high relapse rates without prophylactic treatments. But here we are having very good response. Now, second thing is, there has been resistance of natural resistance development for ambisome, liposomal amphotericin B, and they have been following up patients for 10 years with HIV-VL. Have been repeatedly who had relapses and who had received multiple courses of treatment, and it's good news that none of them have so far demonstrated to develop any resistance. 10 years of using ambisome in those patients. So, but then I would really say that we need to be very vigilant. We need to understand if we have better regimes which we can do without bringing prophylaxis, maybe we should be cautious. But as Dr. Goswami says, that this is a debate when we can speak from many angles. Thank you.
Suman.
I think he was.
Comment for all the people to look into it. See, we are talking of eradication. You said from 2015 or 14, it has been changed to 2018. And in any eradication, you see whether it's leprosy or whether it's malaria or whether it's tuberculosis, the whole population is taken into consideration. Even the doctors who practice are taken into consideration. And they are also encouraged to give a sort of treatment, a regimen, which is feasible, and they are also asked to treat. But this is probably the only see that such where recommendations are given even in the WHO books, technical report series, they would write miltefosine, a drug which is not available. They would disband sodium stibogluconate, which cannot be purchased because of fear of resistance. And they are asking us to give amphotericin B, which most of the practitioners refuse to give in their clinic. And liposomal is also very costly. It's not available within the scope of the patient. Still, we say we want to eradicate. We don't even know which regimen works. And still, we are talking of eradication for a condition like leishmaniasis. And as I was putting the question before to the lady before in cutaneous leishmaniasis, a large number of these patients are like a flotsam. They are floating into our population from Afghanistan, from Yemen, different areas. They come to us cutaneous leishmaniasis. And the simplest drug is sodium stibogluconate. It's not available. We don't have any regimen for any, it's not written in any of the technical report series, and they're all referred to us. We also have to give them other trial regimens. And then we are talking of eradication.
I think you have really cut, put your finger on the nerve, because you talked of access. It's no point having these good regimes if you don't have access. But I think what we would like to always advocate is and the best science suggests that these drugs are much superior to antimonials, which has had 60% resistance demonstrated in Bihar. So obviously you would not like to use a treatment even if it's available when it's 60%.
No WHO technical series writes, refer the patient to this hospital. How will the practitioner or somebody sitting down in Kerala where lots of people from Bihar are migrating?
No, that's a problem of access. That's a totally different issue. So we have to look at it access from a different angle, and that's something I think could be one of the recommendations from this group is we need to have this access to these treatments everywhere and not limited to or other places. Yes.
I have a slightly different opinion as compared to what was commented earlier. If you look at the work which MSF has already done over the past several years, that's a clear evidence that MSF, it's all published. Saqib has been one of the ambassadors for this. MSF should be proud of the work, not only saving thousands of lives, using Ambisome as free treatment, but generated a lot of data. We clearly know that what works best, although there have been some clarifications about, you yourself raised the query, why is Ambisome alone is superior to Ambisome plus miltefosine drug. If you read carefully his own study, Vishal, correct me if the Ambisome alone group received 15 milligrams of 10 milligrams compared to the other group, which is 5 milligrams along with miltefosine, which is actually not a good comparison. One is double the dose. Look at Tammy's evidence, miltefosine plus Ambisome, but higher dose of Ambisome, 30 milligrams per kilo, very clearly shows very effective and relapse rates are extremely low. So I don't think we have, the problem was in recognizing that the comparison was not made clearly. Again, Shyam Sundar's study earlier, which was published in NEJM, 10 milligrams per kilo, very clear evidence, about 95% cure rate. But with the data which MSF has generated, even better cure if you go for 20 to 30 milligrams, the total dose. So I don't think there is any doubt about what is the evidence. MSF should be proud of what it has generated, the evidence. The other important issue of the secondary prophylaxis versus what Tammy has proposed, I would also suggest that secondary prophylaxis, probably resistance development will be slower, but practicality of secondary prophylaxis every month for several months, many of the clinicians, maybe including you, if you have a comparison with Tammy has presented, would be practically more easier. And today the Ambisome availability for single dose therapy has been made much more easy. If you have a patient, please refer to us. We will give free treatment for that particular patient. So I don't think, there has been a lot of effort. MSF itself has shown the numbers declining over the past
from 20,000 odd to down to less than 10,000. So I think it's all a commendable job. This is something which the last session brings out what MSF has been trying to do over the past several years.
We are way to Bangladesh, India. Historical data show that. Now, the most significant aspect, as we had in polio eradication, was and shall remain how effectively we operationalize the last mile. That is the paper that you presented, Manimoy. The transition from passive case detection to active case detection shall ultimately determine the effectiveness. Now we have an excellent tool. How the program managers today are willing to take up the evidence and integrate in the actual policy, which was not happening earlier. Today, whatever data comes out within months, the program is willing to take up. In fact, liposomal amphotericin B and how Bangladesh, India and Nepal have been able to actually operationalize, I feel that the way things are going to move, in spite of doubts which were raised when we were in the last phases of polio eradication, are going to be settled down, and this is a wonderful phase when we actually develop our own tools to operationalize in our own part of the world and actually see that things work effectively. That will make the operational difference, and that will be a turning point for other diseases as well, so-called neglected disease where Western models do not give a solution, but Indian models or our own locally developed models. I think that underscores the point how MSF has been able to catalyze in its capacity to help the Indian and Bangladesh program managers to take the lessons and quickly move forward from just managing the program to the elimination phase. I think that makes all the difference ultimately. Whether in fact, the most glaring example that I could find was VL HIV co-infection and how effectively NACO and the government of India could actually adopt that this is the time when we need to initiate ART early and provide us. If you see the numbers in Bihar, the number of ART centers, the number of ICTC is tremendous, while the prevalence is not that high. If you see pan-India, Bihar is not a high incidence in terms of HIV. And in any case, if it's not, VL is not an age-defining criteria even today. Yet, in spite of that, it's not yet. We do in clinical science, we do practice and in Indian situation, but it's not defined as yet. It's not being accepted as that.
It's basically atypical disseminated visceral leishmaniasis is considered a stage 4. So asymmetric disseminated is considered. So what does that mean? That means patients presenting with pulmonary leishmaniasis or gastrointestinal symptoms. Yeah. But you're right, not your normal typical VL. Yeah, that's not.
So it takes a lot of courage to accept that you need to study because you are investing, because ultimately the program management would be effective in controlling HIV as well as VL. I think these are the few points I wanted to underscore, and I must thank MSF to bring up a panel on the disease which India is actually going to show case to the world. Thank you.
Comments.
I have a question from someone called Vikash Kumar, medical team Hajipur MS. He says in primary visceral leishmaniasis, we give 10 mg in one dose. DL, we do 30 mg divided in 6 doses, which translates into 5 mg twice per week. So why don't we do this? Why don't we do for PKDL on daily basis to reduce the treatment period?
Yeah, it's a good question. I mean, in fact, when we started treating patients with VL in India in 2007, we started using 20 milligrams over 10 days, which we then, based on the patient burden, we reduced it to 4 days, once every day. I think what the main issue that's for PKDL is that of safety. We have as I was mentioning before, we have a much higher threshold to start treating a patient with any drug. Because with any drug there's always a risk of complications. So with PKDL, so that the patient can come in, receive a much slower dose, knowing that with higher doses there's always higher risks, but over a more frequent period of time, which is of course has to be counterbalanced against the inconvenience and the feasibility for the patient to return for 6 treatments. For the treatment of visceral leishmaniasis, a single dose was considered effective and safe based on it being a fatal disease, a potentially life-threatening illness. Therefore, that threshold to treat was a little bit lower. That's the reason.
I'm Hemant from the Union. So I have 2 questions which deal with operational issues of I have 2 questions which pertain to the operational issues. First one is to Manimoy. Manimoy, you had given data that because of active case finding, you got some additional cases. So you have given the crude numbers. What I would be more interested in is from n number of patients that you referred from the community, what percentage actually reached clinical diagnosis? So that question is for you. And Vishal, I have a question for you. In your conclusion slide, you had in point number 4, you had mentioned about requirement of a field staff or something. Is that conclusion backed by data? Thank you very much.
Okay, so first I would like to respond to my questions. I think I had the same question more or less from one guest. So active case detection strategy is a combination of pre-treatment of ambisome, travel expenses for the patients or patient attendants, and also tailored health education. So this is the active case detection strategy. And by this strategy, the patient we found in the field, we referred, and the patient referral by the outreach team, it was done the RK39 in the field, and the positivity is 75% the PKD in case of PKDL, but in case of PK it is 40%. So referral, whatever we referred, the maximum cases was confirmed by the clinicians that it is the cases.
So if you had 100 people who were referred, did all of them reach?
Yes, all patients were reached to the clinic. Yeah. Thank you.
Yeah, there is evidence from other parts, like there is huge loss to follow-up of patients, particularly in VL. And over here we have, from the start we have seen that we have dedicated field workers who are health educators, IECs. They were actively engaged with the ASHA workers, accredited social health activities with the village level. And they had the database of all the patients, doing the telephonically contacts and making the home visits, and substantial, very less loss to follow up in the study. But yes, there is evidence from other parts that there can be huge loss to follow up in the study.
We are coming toward the last part of this session, and if there is no other questions from the online. No, okay. So I would like to thank all the speakers for the nice presentation and the clarifications. I think it was a very interesting interactive program. I would like to thank the audience for your patiently waiting till almost 6:30, and I would like to thank the organizers, MSF, for giving us this opportunity to come and talk and present out here. Thank you.
It's probably the first meeting I've attended in India which started on time and finished on time. So, great job. So, they won't be penalized for, slower number of overs played, whatever. I'm not even going to try and summarize all of what was said today. I think there was a rich, wide variety of operational approaches that were discussed, a lot of new evidence, and some directions going forward. So I'm not even going to try and summarize all of that. But as I'm standing here and I've got the mic, I'm going to talk about myself. In 1995, I went to Ethiopia to start a TB control program, tuberculosis control program in Ethiopia, with Somali pastoralists. So these are people who move around with their cattle all the time, and my job was to get them to take tuberculosis drugs for 9 months. Get them to stay in one place and get them to take TB drugs for 9 months. Now, what I want to sort of illustrate is much has changed in the last 20 years. In 1995, MSF only treated pulmonary tuberculosis. All right? Everything else we were afraid to touch. We were using chloroquine for the treatment of malaria. There was not a single patient on ARVs, publicly funded ARVs, in the continent of Africa in 1995. Sleeping sickness, we used melarsoprol, which is an arsenic drug, which basically killed many of the patients that we were actually trying to treat. And Kala Azar, I remember, we were desperately trying to secure stocks of antimonials in 1995 because we had a fear that the production was going to stop. So this was what was going on in 1995. And I'm very proud of being part of an organization that never gave up. I remember the doctors in the field, they continually refused to accept the status quo. They put up a fight. They demanded that people deserve the right sort of care and shouldn't be penalized just because they lived in a poor country or just because they were poor, right? And someone referred, I think you referred to MSF sort of catalyzing change. That is true to some extent, but it happened by building coalitions like this, with researchers, with scientists, with activists, because this is not a job that one organization or one group of doctors can do alone. So the Scientific Day today is a good example of such an effort to bring together various practitioners and policymakers under one roof to have a dialogue, discuss, and hopefully push for lasting change. Now, we also have in mind that we are doing this research, we are doing all of this work because a lot of the places where we work are hard to reach, not easy places to do research. So any research on neglected diseases, by its very nature, happens in resource-strapped places. It's very difficult to get research up and running. So, all of you who presented their work today deserve a round of applause for actually working in these places and getting much needed evidence, and presenting them to first of all contribute to science, but also eventually pushing for change in policies, pushing for better treatment for people who need it. I remember in the case of malaria, it was very clear that chloroquine was not working anymore. We knew from evidence from Southeast Asia, and we knew in Africa as well, that chloroquine wasn't working. But it took us 168 studies to get African governments to change a policy on chloroquine to artesunate combination ACTs. 168 studies. So I want to underline the importance of studies that are being done, operational research that is being done in the field, and the linkages that we create with the academic community, with scientists, with policymakers, because it may not seem at the moment like things are changing, but from where I stand 20 years ago and today, there's been a sea change. A lot has changed, and I hope that we will continue to, together, all of us together, will continue to change the treatments and the diagnostic tools, the new therapeutic tools that are available to neglected patients and neglected populations, not just in India but around the world. So once again, I want to thank all of the presenters for showcasing their work, but more importantly, giving us an to understand and engage in the discussion, all of the work that is going on, and wish you the very best in engaging with policymakers, because all of this is meant for one reason only. It is to bring quality healthcare to patients in the places where we work. So thank you very much day, and I hope this will be the first of many scientific days that we will be able to host in Delhi, and I wish MSF and the organizers the very best. Thank you.
Okay, thank you, Uni, for your closing words. I also have a few, but they are related to basically a lot of thank yous. First of all, I want to thank all of you for being here, obviously, especially, as Uni also said, the presenters, the chairs, the online audience, and of course the venue here, the IIC. I also would like to thank the sponsors. We have quite a few sponsors. F1000, I mentioned them by name. Biomed Central, the India Journal, India, and the Wellcome Trust. So they are all also on our website, and they have supported us with organizing and basically making sure that it was possible to organize all this. Perhaps it's also nice to know that the online audience was in fact coming from 49 countries, and that there were, as I understand, 348 people following us during the day online. So I think that's quite a number for a first time. So last but not least, I also want to thank basically the MSF team and the editorial committee and the organizing committee who have put in a lot of effort and a lot of energy to make. I want to thank one person in particular, because she was basically the central focal point of the whole organization, and that's Catherine. Catherine, thank you very much. I'll stop. I think it was indeed an engaging day, and the idea is indeed to do it, to organize it again next year. So I'm to that. I hope to see all of you back then as well. One more thing, please don't forget therefore the evaluation form, because we can use it to further improve the next MSF Scientific Day in India. And last but not least, also please give back your badge at the reception. That would be nice, then we can reuse them. Okay, thank you very much, and have a very nice evening. There are drinks, as I understand, on the terrace, so you're invited to join all of us. Thank you very much.